Morning to all guests, faculty, and delegates. We welcome all of you to the day 2 of Max Prostate Conclave 2025. Yesterday we had multiple lectures, interactive session, and surgical demonstration. Today we begin with an engaging masterclass of multi-parametric MRI prostate led by Dr. Amit Kumar, Principal Consultant, MRI Division and Neuroradiology, Max Hospital. This session
The session is chaired by a distinguished panel of experts, Dr. Anand Kumar, Dr. Mrigang Shekhar Jha, Dr. Bijay Mansingh Katwal, Dr. Himanshu Sharma, Dr. Kinjal Banerjee. Dr. Sarkar. Amit sir, the stage is yours.
Okay, we're going to start today with some radiology, and I'm going to talk about a very important investigation that has become very popular now, the multi-parametric MRI of the prostate. So the layout of the discussion is going to start with the protocol that we use for multi-parametric MRI. Then we'll have an overview of the anatomy and the zones of the prostate and how they look on MRI. Then we talk about PIRAD scoring, which is now the basis of the multi-parametric MRI. A short discussion on whether multi-parametric or biometric MRI would be required in certain circumstances. Then what about doing MRI before biopsy? How important is that? And then a word about prostatitis. And if time permits, we'll look at some cases. So what is the MRI protocol for a multi-parametric MRI? What sequences do we use? So the basic sequences that we use are the T1 weighted images, which describe the anatomy of the prostate. The T2 weighted image is the workhorse of the scan, and this actually tells us most of the vital information that we need to characterize a lesion. The other sequence that helps us characterize and grade lesions is the diffusion weighted scan, and the dynamic contrast enhanced images are used as an adjunct to the T2 and diffusion scans. So we look at these one by one. So what is a diffusion weighted image? So diffusion weighted imaging is the principle of this scan is the fact that there is Brownian motion of water molecules in all living tissues. So there is a random diffusion that water molecules have in any living tissue. So what happens when there is tumor proliferation? Tumor proliferation causes accumulation of water in the tumor cells, and because of that cellular proliferation, there is a restriction of the random motion of water in that tissue. So we use the term restricted diffusion when there is a restricted water diffusion in tumor tissue. This is what a diffusion scan looks like. It's a very grainy image, but wherever there is diffusion restriction, you will be able to see that there is a bright area, and correspondingly, we also obtain what is called the ADC maps. Now, ADC maps are calculated from the diffusion scan and are read in conjunction with these images, and we call a lesion restricted when there is a bright signal on diffusion and a dark signal on ADC. So again, to reiterate, diffusion is used as a measure for the mobility of water molecules, and diffusion is reduced in hypercellular tissues such as prostate cancer. ADC maps are used in conjunction with the diffusion images, and a high signal on diffusion and low ADC is characteristic of tumor tissue. Now let's look at T2 weighted images. Again, a very, very important sequence. How do you recognize a T2 weighted scan? You look at the bladder. These are fluid sensitive sequences. So all fluid containing structures will appear bright on the T2 weighted images. T2 weighted images are used for calculating the volume of the prostate. It is used for zonal anatomy. It is the dominant sequence which is used to characterize nodules and lesions in the transitional zones. It is also very sensitive for prostatitis, and normal seminal vesicles appear bright on T2 weighted images because there is fluid in them, and any infiltration into these seminal vesicles will result in loss of that T2 signal. So now let's look at the radiological anatomy. Let's start from the base, from the apex to the base. So this is a scan through the apex of the prostate, where you can see the urethra beautifully demonstrated. This is the pelvic floor or the puborectalis sling, and the rectum, which is situated posteriorly. Most scans that we see in daily practice will be axial images, which means they are going to be transverse sections through the prostate. And we obtain those sections from the level of the bladder up to the apex or the pelvic floor. So coming to a section through the mid gland. Now this section clearly depicts the peripheral zones, which are situated posteriorly and laterally to the transitional zone. The capsule of the prostate is seen as a uniform, dark, hypointense structure which goes all around the prostate, and any extracapsular extension will be seen as a breach in the capsule. As we mentioned, seminal vesicles are, I think I will project it here. This is easier. So the seminal vesicles, so what would be better? Which image? This one. So the seminal vesicles, as we discussed, are grape-like structures which are hyperintense on these T2 weighted images. Any disease in these seminal vesicles will lead to loss of the normal T2 signal. Coming to the transitional zones. So transitional zones are structures which are seen in the center of the image, usually with enlargement of the transitional zones with multiple nodules, as seen here. There is compression of the peripheral zones around them, and these nodules are characterized using the T2 weighted scans. The neurovascular structures are seen posterolaterally at mid-gland level, and any invasion of the prostate and tumor that goes beyond the capsule might cause infiltration of these neurovascular structures. What about dynamic contrast enhanced MRI? So this is the third entity in the multiparametric scan, and it is based on a principle that whenever there is tumor proliferation, there is recruitment of vessels, and tumor angiogenesis. So this neoangiogenesis is formed by a lot of disorganized vasculature, which is abnormal as well as leaky. And because of leaking of the contrast through the permeability of the basement membrane, there is contrast extravasation into the tissues, resulting in an early and high amplitude of enhancement within tumor. So to explain, whenever there is a tumor present, there is going to be extravasation of contrast through a permeable basement membrane of the recruited neoangiogenesis, which will give us early and high amplitude of enhancement in tumor. So DCE, as we call it, is used as an adjunct to the two sequences that we just discussed, the T2 weighted image and the diffusion scan. There is a disadvantage of the DCE, and this has been well demonstrated in 2015 by Nobin, which states that there is an underestimation of the tumor boundary by DCE. That is, pathologically, we have found tumor boundaries much beyond the area of dynamic contrast enhanced signal or area which shows DCE hyperenhancement. So what does a benign prostate look like? So let's look at these images. This is what the peripheral zones usually look like. They are homogeneously hyperintense. These are T2 weighted scans. These are homogeneously hyperintense on these T2 weighted images, and they do not reveal any hypointense area. This is what the central zone looks like. It is an area which encapsulates the ejaculatory ducts, and it appears dark because of the fibrous tissue and is present posterior to the transitional zone. The transitional zones are separated by the peripheral zone by a pseudocapsule which encircles the entire transitional zone, and this is what the diffusion scan and ADC map look like on a normal prostatic, normal patient with a prostate examination. So coming to PIRADS. So we are in the version 2.1 of PIRADS, and PIRADS was established to improve the detection, localization, and more importantly, the characterization of lesions, which helps in the risk stratification of patients with suspected clinically significant cancer. What does PIRADS describe? So it has a complete description of the minimal technical factors that have to be used for a multiparametric MRI. It also simplifies and standardizes the terminology that has to be used. It also provides a roadmap for the targeted biopsy and fusion of the MR images with the biopsy equipment. It helps in development of categories and summarizes the levels of risk for each lesion, and more importantly, it educates the radiologist and reduces the variability in image interpretation so that there is a standardized communication with the surgeon. What is the aim of PIRADS? It is to detect clinically significant cancer, which is described by a Gleason score of more than 7, a volume of more than 0.5 cc, and with or without the extraprostatic extension. So just a word about Gleason score. The Gleason's grading is a description of the glandular tissue that is present in a lesion. So Gleason's 1 is usually the normal glandular tissue, and as there is de-differentiation of the glandular tissue, the grade increases. So as the cells become more de-differentiated, the grade is increased from 1 to 5. And 5 is showing all bizarre de-differentiated cellular tissue. So Gleason's is described as a score which has two components. The first component is mainly the first component is the predominant tissue which is present in a lesion from 1 to 5, and the second component is the less predominant tissue cellular type that is present. So what has been described is that a Gleason score of 6 is favorable, 7 would be average with moderate differentiation of cells, and a Gleason score of 8 to 10 means that there is a poorly differentiated cellular picture which has an adverse prognosis. The ISUP grading also talks about the same, where the low risk is with Gleason's of less than 6. Intermediate favorable risk would be 7, but the first component is more well differentiated. The grade 3 has an intermediate unfavorable risk, where the first component is more undifferentiated, and then a high risk group is between 8 and 10. So what is the description that PIRADS gives us? So we use the PIRADS grading from 1 to 5, where a PIRADS 1 lesion is highly unlikely to have any cancer present. A PIRADS 2 lesion would have a high unlikelihood of any significant cancer being present. PIRADS 3 lesions are equivocal, which means that there is an intermediate picture which might suggest that there is an equivocal chance of cancer being present. PIRADS 4 means that there is a high likelihood of clinically significant cancer to be present, and PIRADS 5 is a description of a highly likely chance of clinically significant cancer being present in a nodule. So what does PIRADS describe the technical factors as? So there is a complete description of what all has to be obtained by the radiologist for proper estimation of the PIRADS grading. A high resolution T2 weighted scan has to be obtained in all three planes, axial, coronal and sagittal. The measurement of the gland is done in sagittal and one more plane on T2 weighted images. The diffusion has to be obtained with a high diffusion value of at least or more than 1400 millimeters square per second. The ADC has to be calculated from the diffusion that is obtained with a B value of less than 1000. This actually helps in giving a very smooth and high resolution image. The DCE images, or the dynamic contrast enhanced images, have to be obtained within 15 seconds of at contrast administration to pick up the early enhancement. T1 weighted images are a must post biopsy to differentiate hemorrhage from tumor, and it also recommends that a wide field of view image has to be obtained up to the aortic bifurcation to look at all lymph nodes which are present. So this is the sector map that any radiologist will use to describe a lesion. We divide the gland into the base, the midgland, and the apex. And from the base, all lesions are described whether they are present in the transitional zones, anteriorly or posteriorly, the peripheral zones, anterior or posteriorly, the central zones which are present posteriorly, and the anterior fibromuscular stroma which is present anteriorly. Similarly, the description is made for the midgland and the apex of the gland. Let's have a look at how we characterize lesions with the PIRADS version 2.1. When we look at the peripheral zones, which usually harbor tumor more commonly in 70 to 75% of patients, we will use the diffusion weighted images as the workhorse to characterize any lesions. If in doubt, when we have an equivocal PIRADS 3 lesion in the peripheral zone, we will use dynamic contrast enhanced images to either downgrade or upgrade that lesion. For transitional zones where the cancer is less likely to be present, we use the T2 weighted images to characterize the lesion, and diffusion will be used as a tiebreaker to either downgrade or upgrade equivocal lesions. So let's look at examples. Any peripheral zone lesion which does not show any diffusion restriction and appears and the peripheral zone appear homogeneous on T2 weighted images is scored as a PIRADS of 1, which means the lesion is definitely benign, and all normal prostates would fall in the PIRADS 1 classification. PIRADS 2 lesions in the peripheral zones are seen as linear or wedge-shaped areas of hypointense signal in the peripheral zones, which will not show any diffusion restriction or darkening on ADC maps. These lesions usually are very common in the elderly patients and are suggestive of prostatitis. Any lesion in the peripheral zone that shows either a hyperintensity on diffusion without any darkening on the ADC maps and no evidence of dynamic contrast enhancement will be characterized as a PIRADS 3 lesion. I will repeat, any lesion which does not show restricted diffusion, meaning that it is bright on diffusion but does not show corresponding hypointense or darkening on ADC, and no evidence of early enhancement on DCE, will be characterized as a PIRADS 3 lesion. However, when a lesion is characterized as 3 but shows early uptake on contrast scans, will be upgraded from 3 to 4, which means that once we pick up any contrast enhancement, then the likelihood of cancer is increased. So let's look at that lesion again. This lesion was characterized as a Pyrad's 3 lesion because it did not show restricted diffusion and did not show any enhancement. However, the lesion situated posteriorly does show a hyperintensity on diffusion, some darkening on the ADC maps, and early contrast enhancement, and that is why this lesion from a 3 will get upgraded to a 4. So, looking at Pyrad's 4 lesions in the peripheral zone are very, very characteristic, where you will get a hyperintense signal on diffusion, a darkening on ADC, a hypointense signal on T2 weighted images, and early contrast enhancement on DCE. So this is what is characteristic of a Pyrad's 4 lesion. Any lesion that falls in category 4, however, is more than 1.5 centimeters or is showing extracapsular extension will become a Pyrad's 5 lesion. So looking at this lesion, which is more than 1.5 centimeters on T2 weighted images, shows a hyperintense signal on diffusion, corresponding darkening on ADC, and a hyper enhancement on DCE will be characterized as Pyrad's 5. Any lesion which has extracapsular extension, as you can see here, the lesion is clearly going beyond the margin of the capsule. This is the capsule, which is seen as a dark structure. Any lesion that is going beyond the capsule into the extraprostatic fat will be characterized as Pyrad's 5, and this lesion also is showing high uptake of contrast on the DCE. Another such example where the lesion measured here is more than 1.5 centimeters, has a broad base with the capsule and is showing irregularity of the overlying capsule, which is suggestive of extracapsular extension, is characterized as Pyrad's 5. Similarly, any lesion which is showing extension into the seminal vesicles will also get the grading of Pyrad's 5. This lesion is also seen on the T2 weighted images beyond the capsule into the periprostatic fat. Another such example where the lesion is clearly bulging through the prostatic capsule, showing hyperenhancement on DCE as well as diffusion restriction, will be characterized as Pyrad's 5. So to summarize, any peripheral zone lesion which is characterized by diffusion showing indeterminate diffusion abnormality is upgraded using the dynamic contrast enhanced scans into category 4 from 3, and diffusion is used as the main sequence to characterize lesions in the peripheral zones. Coming to the transitional zones. When we look at transitional zones, this is the characteristic appearance of an enlarged prostate with disorganized nodules being present in the transitional zones, which cause compression of the peripheral zones, and each nodule has to be evaluated in the transitional zones. What do we score? We score any lesion present in the transitional zone which does not have a characteristic appearance of a benign nodule, and we will see in the subsequent images how we use T2 weighted images to characterize each nodule present in the transitional zones. So this is a diagrammatic representation of each nodule that is present in the transitional zones. Let's look at it carefully. A Pyrad's 1 nodule will have a dark rim and a well circumscribed appearance on T2 weighted scans. This typical nodule will be encapsulated and have a dark rim surrounding the nodule, which suggests that this is a definitely benign lesion. Any atypical nodule which does not have a capsule surrounding it and gives a partially unencapsulated appearance will be given the grading of 2. All heterogeneous nodules which appear obscured and do not have well-defined margins will be given a grading of 3. 4 and 5 lesions are usually lenticular. They have obscured, ill-defined margins and are moderately hypointense on T2 weighted scans. Just to remind everyone that T2 weighted images are the workhorse of any lesion that is detected in the transitional zones. So what does a Pyrad's 1 lesion in the transitional zone look like? It has a T2 hyperintense signal with a rim of hypointense or dark capsule surrounding it. It is well circumscribed, well encapsulated, and is given a score of Pyrad's 1. Any nodule that does not have a complete capsule around it and appears homogeneously hyperintense will be given a Pyrad's scoring of 2, which means that there is highly likelihood of it being benign. These nodules will not show any diffusion restriction. So, any nodule that is well defined on the T2 weighted images and has a well defined margin is given the grading of Pyrad's 2. However, if that nodule shows diffusion restriction seen in the diffusion scans and the ADC maps, will be upgraded from 2 to 3, which means that there is an unequivocal appearance and there could be a possibility of cancer in this nodule because diffusion scans are showing restriction of water molecules in this nodule. Looking at another nodule, this nodule has a partially circumscribed capsule, however, does not show any diffusion restriction on the diffusion scans, but is showing some darkening on the ADC maps. This again becomes an indeterminate nodule, which will be characterized into the Pyrad's 3 category, as there is some amount of ADC darkening which is present in this nodule, and the T2 appearance of the nodule is not characteristic of a Pyrad's 2 nodule. Similarly, this lesion, which does not show a brightening on diffusion, but is showing a dark appearance on ADC, will also get a Pyrad's 3 grading because there is a possibility of it showing some amount of diffusion abnormality. Let's look at this nodule. Present anteriorly, it is showing an obscured margin, and when we look at the diffusion scan, it is showing bright signal on diffusion as well as darkening on ADC. So this nodule, from the 3 that we gave it on T2 weighted images, will be upgraded into a 4 because it is showing a grading of 3 on T2 weighted images, but because of diffusion restriction, it gets upgraded from a 3 to a 4. So just to repeat that, any heterogeneous nodule with an obscured margin which falls in category 3, if it shows diffusion restriction, will be upgraded from 3 into 4. This is another example. The Pyrad's grading of this nodule was 3 because it had some amount of obscured margin, but because it was showing diffusion restriction, from 3, this lesion was upgraded to 4. Let's look at a characteristic Pyrad's 4 lesion in the transitional zone. When we look at the T2 weighted image, we have a lesion which is ill-defined, does not have any capsule or margin surrounding this lesion, and when we look at the diffusion scan, this lesion shows bright signal on diffusion and ADC darkening, which means that there is a high likelihood of cancer being present in this transitional nodule. Similarly, all lesions in the transitional zone which are poorly defined without any margin and show diffusion restriction but measure more than 1.5 centimeters will have a grading of 5, which means that there is a high likelihood of cancer being present in this nodule. So to summarize, when we look at transitional zones, we use the T2 weighted images to characterize any lesion. All lesions which are heterogeneous and do not have a well-defined margin, which means that they have an obscured margin, will fall in category 3, and if they show diffusion restriction, they will be upgraded from 3 into 4. I just want to reiterate that dynamic contrast enhanced scans do not have any role in characterization of transitional zone nodules. What about the central zone? So central zone is a fibrous tissue which is present posteriorly in the gland in the midline and contains the ejaculatory ducts. This is a coronal image where the seminal vesicles and the bladder are seen superiorly, and the prostate gland shows the central zone being marked in this image, appearing homogeneous, hypointense on T2, and showing a very symmetrical appearance. So if we draw a line in the middle, it will be a very similar appearance on both sides. Any lesion in the central zone will lead to asymmetry of the central zone and will appear hypointense on T2 weighted images and show restricted diffusion and early enhancement on DCE. Again, looking at anterior fibromuscular stroma, which is present anterior in the gland, this is the bladder, this is the anterior fibromuscular stroma. Any lesion within the anterior fibromuscular stroma will lead to asymmetry in the tissue, and when we look at the diffusion scans, it will show restricted diffusion, and it is suggestive of a high likelihood of cancer being present in the AFS. Another lesion in the anterior fibromuscular stroma, which is showing restricted diffusion and early enhancement on DCE, which was suggestive of high likelihood of cancer. What about patients which have hip replacement or metallic implants in the pelvis? Due to metallic implants, the diffusion scans do not obtain very good resolution, and there are artifacts that are present in diffusion scans due to the metallic implants. In such a situation, T2 weighted images will be used to characterize any lesion in the peripheral zone as well as in the transitional zone. Similar characterization is made in both the peripheral zones and the transitional zones. However, all equivocal lesions which are graded as PIRADS 3 will be upgraded to 4 if that lesion is showing early enhancement on the dynamic contrast enhanced scans. What about patients where contrast cannot be used and is contraindicated? A small subset, but in that situation, peripheral zone lesions will be characterized with diffusion scans, and transitional zone lesions will be characterized with T2 weighted scans, and similar approach to transitional zones lesions is made where a 2 will get upgraded to 3 if it shows restricted diffusion, and 3 will get upgraded to 4 if it shows restricted diffusion. So just to summarize, this is a case which was done last week at Max Saket, which had an enlarged prostate gland, a high PSA of 28, and multiple nodules which needed to be characterized. Looking at the peripheral zones, the right peripheral zone appears hyperintense on T2 weighted images, shows multiple linear areas which are suggestive of prostatitis, and is a benign area. However, looking at the left peripheral zone, there is a darkening of the area on T2 weighted images with corresponding hyperintense signal on diffusion and hypointensity on ADC, which then is characterized to PIRADS 4 lesion. Coming to the transitional zones. So most of these nodules are seen with well-defined margins. However, this nodule in the posterior transitional zone has partially obscured margins and will be characterized into 3. However, when we look at the diffusion scan, it is showing restricted diffusion with corresponding dark signal on ADC, and from a 3, it will be upgraded to a 4, which means that there is a high likelihood of this lesion being malignant. Just a word about prostatitis, very commonly seen in the elderly prostate. Multiple linear hypointense areas in bilateral peripheral zones, no evidence of restricted diffusion, graded as benign and characteristic of chronic prostatitis. Just a word about the rationale of doing MRI before biopsy. The advantage of MRI helping in road mapping all nodules for biopsy has well been established, and any lesion which has undergone biopsy will show hemorrhage, which will interfere with the lesion detection on T2 weighted images, and hence a biopsy should only be done after an MRI so that there is no interference of blood in any nodule. The ideal interval for an MRI post biopsy would be at least 8 to 12 weeks. Also, hemorrhage in seminal vesicles may make the staging very difficult, as blood on T2 weighted images has a dark appearance. Post biopsy scar tissue and fibrosis will also appear dark on T2 weighted images and will cause capsular distortion, which will obscure the lesion which is present in that area. T1 weighted images have been recommended to exclude any area of hemorrhage which will appear bright on T1 weighted images. So concluding this talk, I would like to reiterate that PIRADS is and has been used for the standardization of terminology during communication to the surgeon by the radiologist to characterize lesions and assess the risk of clinically significant prostate cancer. MRI also has become a prerequisite for road mapping of all lesions which need to be biopsied. Following a structured approach for peripheral zone lesions using diffusion and contrast scans, and for transitional zone lesions using T2 weighted images, the radiologist uses the same language across the board to communicate to the surgeon, and we have to look at the central zone as well as the anterior fibromuscular stroma for any asymmetry to detect lesions, and separate protocols have been recommended for all patients who cannot receive contrast or in whom a good diffusion is not possible. Thank you.
Thank you, Dr. Amit. Wonderful presentation with very clear message, and we learned a lot. And this was very, very clear, good lecture. We appreciate it very much.
Thank you, sir.
And anybody who wants to ask a question can ask about the anterior lesion.
Yes, sir.
You did not mention much about interior lesion. So anterior lesion is located just at the top of all the images,
Yes, sir.
and from where you get same characteristics.
Yes, sir.
Yeah.
So I'd like to congratulate you, Dr. Amit. Very lucid and illustrative talk.
Thank you.
So as a clinician, I'd like to know, so you have talked about the PIRAD scoring. What would be the specificity and sensitivity vis-a-vis actual cancer being there?
So, multi-parametric MRI has a high specificity and a sensitivity of more than 95% in trials which have been done with the biopsy correlation for any lesion detection in the prostate. So the specificity is slightly lower, it's around 90 to 95%, but the sensitivity is much more than 95%.
Okay. So the other thing is you talked about the Gleason scoring also. So does the PIRAD scoring correlate with the Gleason scoring?
Yes, so we are already having around 250 cases that we have done where we have correlated MRI findings with biopsy, and the grading of the lesions on MRI are showing similar results with the biopsy findings. So there is a very high correlation between the grading, Pyrites grading and the Gleason score.
Okay. The other thing is like Pirate score, that is the one area which we are really concerned as a clinician because Pirate 3 would be equivocal.
Yes.
So Pirate 3 in peripheral zone versus Pirate 3 in transitional zone. So does that change the outlook or, I mean, does that change the impression how we read a Pirate score?
Yes. Lesions in the peripheral zone are easy to characterize because of the homogeneous appearance of the gland in the peripheral zones. All lesions that we detect in the peripheral zone have a better correlation with histopath. However, because of the heterogeneity and disorganized appearance of the transitional zones, lesions in the transitional zones and lesions which are present anteriorly are difficult to characterize, and sometimes we are in a dilemma and have to characterize lesions as equivocal as Pyrites 3, and I think the surgeon then goes ahead and uses biopsy to further evaluate the lesion, because we are definitely, it is a kind of handicap for us as radiologists to characterize every lesion in the transitional zone due to the mosaic appearance that we have on T2. And sometimes diffusion is also equivocal. Of course, diffusion is used to upgrade lesions, but if diffusion and ADC are not correlating, in that scenario, the nodule will still remain equivocal and will need a biopsy.
So let me reframe it. Pirate 3 in a peripheral zone, I would be more concerned rather than Pirate 3 in a transitional zone. Is it so?
Yes. So, as I said, lesions which are Pyrites 3 in the peripheral zone, we can use contrast to further evaluate. However, lesions in the transitional zone do not have any role of contrast. So, it is easy to characterize the peripheral zone lesion, and there are very few lesions where we have to stop at a grading of 3 because we have DCE as a tool to further evaluate the lesion, and there are most likely chances that lesion will fall either into benign category or be upgraded from a 3 to a 4. So what I mean to say is that most Pyrites 3 lesions which are reported in the transitional zones. The peripheral zone lesions, because we have 3 tools, the T2, the diffusion and the dynamic contrast, do not usually have an equivocal appearance. They are either characterized as benign or 4 or 5.
The last question. Regarding the size between Pirate 4 and 5, the determinant would be the size of 1.5 centimeter.
Yes.
So regarding Pirate 1, you were saying it's a well encapsulated lesion. So let's say a well encapsulated lesion more than 1.5. Would you still categorize it as a Pirate 1?
So a well encapsulated lesion which is not homogeneous, is heterogeneous and more than 1.5 centimeters is characterized as 1 only and only if it does not show any diffusion restriction.
Thank you.
And Dr. Amit, is this make difference if it is a 1.5 Tesla machine or 3 Tesla machine? Is that makes the Pirate scoring better?
Sir, definitely 3 Tesla images are more high resolution because it is a double the field strength of the magnet. So it increases the resolution that can be obtained because it has a direct correlation of the strength of the magnet with the resolution that we obtain. So double the strength means higher the resolution.
Any experience of correlating PSA with Pirate score 1? And the second part is Pirate 3. when will you suggest to do repeat MRI? Will it depend on appearance on MRI or purely on PSA numbers?
So PIRADS version 2.1 does not have any correlation with serum PSA. It is an independent description for the radiologist. However, the radiologist is supposed to document the PSA levels when he is assessing every lesion in the gland. What was the second question?
When will you suggest repeat MRI in PIRAD 3? Is it depending on your MRI finding or it will depend on PSA?
So we usually do not recommend a follow-up for PIRADS 3 lesions. We usually recommend, if the lesion is equivocal, we recommend a biopsy, not follow-up.
Dr. Amit, very crisp and simplified presentation.
Thank you.
Just one thing where we get usually, it becomes complex for us, is the sequences. When we see it on the system, getting a T2 image is easy, diffusion weighted is easy, ADC is easy. When we look at the contrast enhanced images, there's like a
Yes.
barrage of sequences.
Yes.
Flare sequence, lava sequence, disco lava. So how can, which is the one that we can use to interpret contrast images?
Yeah, so there is a description by the PIRADS committee on the sequence which has to be obtained post-contrast. So it is the first sequence which is obtained. It's a dynamic sequence, has to be obtained within 15 seconds of contrast administration, and multiple runs are taken through the prostate gland. So what we are looking for is any early enhancement of the lesion before the rest of the gland enhances. The lesion should show contrast uptake, and it has to be compared with the contrast in the femoral artery. So as soon as the contrast in the femoral artery is seen, you are supposed to look at contrast uptake within the lesion, and it is much before the rest of the gland shows any uptake.
So the earliest 2 or 3
sequences post-contrast.
Excellent presentation. How does a low PSA cancer look on multiparametric MRI? Low PSA cancers. Now we know that 25% of patients with the with PSAs less than 4 will have cancers. Do they look any different?
No, sir. That is why PIRADS committee has not recommended any correlation between PSA and the MR images. Any clinically significant cancer present in the prostate will have the same appearance as described by the PIRADS committee.
Nice presentation, Dr. Amit. I would like to know, how can we diagnose or can we comment on PIRADS if we are unable to give contrast in a patient?
Yes. So if one of my last slides talks about any patient which has contraindication for contrast, we will be using T2 weighted images for characterizing lesions in the transitional zones, and we will use diffusion weighted images for characterizing lesions in the peripheral zones when contrast cannot be given.
Thank you.
If biometric is as good as multiparametric, then why do we use multiparametric?
Sir, as I described, contrast is basically a tiebreaker for lesions which are characterized as 3. If they show early enhancement, the 3 category can be upgraded to 4. So that is where contrast is helpful. But in cases where contrast cannot be given, then we use T2 and diffusion, and in those patients, probably a biopsy would be more recommended than relying just on the assessment by PIRADS.
Sir, if the contrast is just enhancing the lesion from 3 to 4, clinically nothing changes because we do a biopsy for 3 as well as for 4.
That's actually
So,
true, yes. So
how does it benefit the patient by giving a contrast then?
So all lesions which show uptake are characterized as 4, and that is why those patients then are more likely to be convinced for biopsy than lesions where we give a 3 scoring and maybe the clinician feels because of a stable PSA that a biopsy can be deferred.
So another thing, just I want to add, the biparametric is for very experienced radiologist. So if he knows he doesn't have very good experience, so better to just follow this multiparametric MRI. And this giving contrast is very important because PIRATES 3 and PIRATES 4, they are totally different thing. So it increases the confidence of patient to undergo biopsy. Otherwise, if it is 3, it is equivocal, then he thinks whether to go for biopsy or not because there are a lot of complications associated with the biopsy.
So is there any absolute value of ADC?
Yes. So because of darkening on ADC, what we do is we put a region of interest or a circle which we draw on the ADC map, and any ADC value of less than 1.2 is considered significant.
But does it vary with the zones? I mean, the value?
No.
Absolute value?
No.
Okay, thank you.
Do we really pass on the benefit of doubt of PIRATE 3 to the patient? I mean, as a clinician with PIRATE 3, if you come
So
across
we
a
take
patient.
lot of parameters in that, like suppose PIRATES 3 is there, how is the PSA, is there any family history, how your rectal examination, other parameter will also influence. Here is the score, if you have other scoring system like PHI, prostate index, that will also help to make a decision. And if you are not very sure, nothing loses because you know it is the intermediate lesion or it may be early lesion. So you wait, get the PSA, follow the PSA start rising, then you repeat MRI. If the lesion also changing the characters, then you know that it's turning to the malignancy, you can do the biopsy. So it is not necessary all 3 PIRATES, 3 lesion you have to biopsy, you have to take clinical consideration, you discuss with the patient. Some patients are happy to wait, repeat PSA, come later. Some are very anxious, then you do the biopsy immediately.
Right, thank you.
Sir,
Sir, does the experience of the radiologist matters in giving the PIRATE score? We get MRIs done from outside with a PIRATE score. Are they supposed to be reviewed or are we supposed to believe that?
So there are guidelines for the obtaining of each sequence given by PIRATES. So if the standardization is there, then images which are obtained with those technical parameters are self-explanatory, and anybody who has reasonable experience to interpret those images can characterize every lesion. So that is what PIRATES committee is trying to do, that everything is standardized, the nomenclature as well as the technical parameters, so that anybody with reasonable experience can interpret those images.
Thank you, Dr. Amit.
Thank you, sir.
Anybody who has a further question, Dr. Amit will be available for further discussion. It's a very, very important lecture, and because we have to start the cases. So thank you very much.
Thank you, sir. Thank you.
Please gather on the stage for the group photo.
Thank you, speakers and chairpersons. Thank you, Dr. Amit, for making us understand the essentials of prostatic imaging, which is being used day to day. I think in the next program we can have one debate of Dr. Amit with AI bots in future. We will now begin with our first lecture session of the day, focusing on the minimal invasive surgical therapies and emerging interventions for benign prostatic enlargement. The chairpersons for the session are Dr. Siddharth Jain, Dr. Upwan Chauhan, Dr. Manoj Kumar, Dr. Tanuj Paul Bhatia, Dr. Kamaljeet Singh, and Dr. Pankaj Maheshwari. Pankaj, sir. We'll request Dr. Anish Srivastav to please join the. Can you display the number of that, Mr. Anup? On the background image, we have number of Mr. Anup, who is the dealing with Shubh Yatra company. So any faculty or guests who are having any doubts regarding their travel queries or flights or train or arranging the cabs, they can contact Mr. Anup from the Shubh Yatra. His number is being displayed over here. So our first speaker is Dr. Vimal Dasi, who is going to speak on RISM.
Before starting the lecture, we would like to get connected with the OT. So all the 3 OTs are ready. We would like to connect with Dr. Samit Chaturvedi in the OT of robot. He is doing robotic simple prostatectomy.
Are we connected to the OT?
आवाज जाएगी वहाँ पे? We are ready. We are ready.
Hello.
Hello. Hello.
Polar TRP with Dr. Ajay Sharma.
Okay.
Hello. Am
Yes.
I audible?
Yes, sir, we can hear you, sir.
Okay. So, I think I'll start talking once the case is being presented. And I thank Max Hospital team, Dr. Anantkumar and team, for giving me this opportunity to demonstrate one case of PURP, monopolar. And I will say that I am not doing this for the consultant sitting here. I will be doing it for the residents. I hope there are quite a few number of residents around. And my job is not to teach TURP. I will be coaching TURP to those who are new or who are under training. So let's see the case first.
Yeah, so now we'll present the case first. Good morning, gentlemen. So this is the first case capsule of the day. We have a 52-year-old male patient who came with us with mixed voiding and storage LUTs. And he has been on alpha blocker therapy since last 6 to 7 months. He has a history of pulmonary coughs and right tympanoplasty. His examination and digital rectal examination were grossly normal. Ultrasound revealed prostate volume of 54 grams with 12 millimeter of median lobe projection, and his post-void residual volume was significant. His blood and urine workup were normal. PSA was 1.58, and his maximum flow velocity on uroflow was 10.1. This was the flow pattern. And this is the ultrasound image showing the median lobe projection into the bladder. So the plan was made to perform monopolar TURP. This case is being demonstrated by Dr. Ajay Sharma, a senior consultant, Department of Urology, Sir Gangaram Hospital. Thank you. Over to you, sir.
Instrument. And I want, simultaneously, I want to show the screen also. So you see, the thing is, this is for the residents again. If you understand the instrument, you see once my loop is out and it goes in, it goes and rests within the sheath. And similarly, if you see on the screen, when the loop goes and disappears at the 6 o'clock position, and that is where there is a rule we call, whatever you see, it will cut, and it will not cut whatever you don't see. So this is the very important point in this for the understanding of this instrument. This is mainly for the residents, that remember this, that it will cut everything what is seen. and it will not cut what is not seen. Okay. So now now what I have done is, there are two things which I'll emphasize. One, before you put the instrument in, isko badal do. Once you put the instrument in, always check the meters, either by metal dilator or by Hagar dilator. I have already have done this, and check the meters, and the meter should be very comfortably allowing the our sheath. Second thing is, we have stopped quite some time back. We have seen Mark Soloway speaking about use of Vaseline-based jelly, Vaseline-based ointment onto the sheath. So what I have done is, I have put Neosporin. We don't have sterile Vaseline in our country. So we have put Neosporin ointment. The thing is, the principle is, if you put jelly only, jelly being water soluble, this disappears, and within say 5-10 minutes. But this Vaseline-based ointment, it stays. So now, can you see the cystoscopy?
We are not getting the endoscopic views.
Endoscopic though? So urethra is perfectly fine.
Endoscopic view,
I'm not
please.
getting the endoscopic view.
Yeah, I'm waiting.
Audio visual team, can we have the endoscopic view, please?
Are you getting it? I'm in urethra. ऐसा इसका जूम आउट कर सकते हो? इसको मेरे को पूरा सर्कल देखना है.
By the time they are correcting that, can we connect to Dr. Samit, please, sir? He is starting his case.
इसको ये क्या पूरा सर्कल देखेगा क्या?
Can we connect to Dr. Samit till we are sorting out the issue in this OT?
और हाँ, इससे कम और होता है? जूम और कम है? 0 होता है क्या? देखो. हाँ, बस ठीक है.
Are we connected to Dr. Samit OT, please? Hello?
Okay, हम चलते हैं अंदर.
Now we have the endoscopic view from Dr. Rajesh OT.
For the vision, the urethra was normal, and this is, I'll tell you one more thing. This is again for the residents. You see, right now I am seeing almost full circle of the view. Sometimes what happens, if the things are very much zoomed in, the bottom and top, like even in this, I am not seeing the 12 o'clock complete circle and 6 o'clock complete circle. So this has to be remembered, because we are not seeing the last few millimeter, last half or so millimeter when the loop goes in. So be aware of this part. So this is the verumontanum. There are kissing lobes inside, and there is a median lobe which is not very big, but yes, it is there. And of course the bladder is trabeculated. I just seen. Pani dekhna? Okay. So bladder is trabeculated, not very heavily, but yes, significantly. And of course both the orifices are okay. Here this is the trigone, this is one orifice, and again in the groove you can see the other orifice, right? Okay. So I will just change over to my loop, and then I will tell few nuances. As I told you, I am not teaching PURP. I will be coaching and telling you few nuances, because teaching part is done by during the course of DNB and MCH, and there are so many things given in books, but there are certain things which are not mentioned. So since I have been teaching DNB students for last, I think, more than 20 years, so I have realized, in fact, I have learned from the students that where do they have difficulty. The first difficulty is uncertainty. Second difficulty is fear. So these are the things which I thought how to get over these for the residents. So what I have revised was, give me the loop. So there are three things. One, that all residents should know that partly there are blind cuts. Our temptation to be in the vision all the time, that restricts us at places. I will actually show you. This is very strange when you hear this, that there are many blind cuts. and the resident doesn't know that there are blind cuts, so they get confused. That is one part.
Good
I'll
morning,
show you
Ajay
where
sir.
Yes, are you able to hear?
Hello.
Yes, are you hearing me?
Yeah. Good morning, Ajay sir. Uppan this side.
Good morning. Hi, Uppan.
And you,
So,
when we were your students, we
Yeah.
are still your students, but you explained us that whatever you see with the loop,
Yeah.
within the loop, only that much
exactly.
is cut.
Yes,
That
so
is
I just explained that.
Yeah.
Could you hear when I was explaining this?
Yeah.
Okay, so now the loop is inside. You can see the loop, and the moment the loop goes inside, it will stop cutting.
At that
So
time, we were
whatever
not
you are-
having the endoscopic view, sir.
yeah. Okay, so what I was telling you is about the blind. That there are two things which all students now should understand. Can you imitate? See, if I tell you to draw a line on a paper, try drawing a line on paper. So our psychology is our eyes, they are glued on the thing which has already done. That means जो line खिंच गई है हमारी निगाहें वहाँ पे रहती हैं. We do not look forward. So this is one training which we should develop, and this is important when you give skin incision also. So psychology is when you can you focus it onto me? Am I visible? Not the endovision. Surface view. Okay. So can you hold it? So what I am saying is, if you try to draw a line, so when you draw a line, your eyes naturally look here, not where you are about to go. Now this habit should change, and we should actually train our eyes to look forward. So when you give skin incision, always look where you are going. So your speed will be good and your line will be straight, and you will know the difference. So here the relevance is, when I'll cut, I'll tell you, try not to look at the loop, try to look at the tissue you are cutting. Like this, we are not looking the loop. We are seeing the tissue and we are going to cut. I'll show you later on. Second thing is, for my resident, I had devised two exercises. One, just remove the cautery. Okay. Now I have removed the cautery, and I tell my resident to practice, like press the cautery cutting or whatever, and try to move loop. And now, since there is no fear, do this exercise. This will make your hands and eye coordination, and your your fear will go, and your hands will start getting freedom. Now, last thing, can you show me surface camera? Now there is something called scooping movement. Like when you take the ice cream, you scoop. When you eat from a plate, you scoop. So when you are cutting at 6 o'clock, if you see my hand, I have removed the cartridge out, so I am actually pressing the button. So look at my hand. When I am cutting, I am scooping at 6 o'clock. When I cut laterally, I am scooping laterally like this. And when I cutting at 6 o'clock, so I scoop this way. Are you saying something?
Yes, sir.
So okay, so these are the few important things, and then I'll tell you a few things about the hemostasis.
Sir,
So now I am starting, since there is, now my plan will be, okay, my plan will be to start with median lobe and go anteriorly.
endoscopic
And
view, please. We are not
you have
getting
the-
endoscopic view.
Endoscopic, please. Okay?
Sir.
All right. So now I will start with the median lobe. Now here, every new student starts small bites. So I always encourage to take long bites. There are advantages. One, that loop gets detached. Now you see, I am dipping my loop. First cut normally will not harm. Sometimes, of course, when there is very high bladder neck and no lobe, this bite should be shallow. But otherwise, first bite will never harm. So now you see, I have dipped my loop. I am not seeing the loop. So this is important thing, not to see the loop. And I started cutting. So this is first cut, and then this similar way. I think there is something. So just keep cutting. Try to take long bites. So now you have started seeing the capsule, and this is our first landmark. Now, most of the students, they ask, sir, आपको depth का कैसे पता पड़ता है? So now this is our first landmark. And regarding the depth, I'll remove this tissue also, but I'm just explaining something. Now, this is the capsule. Once you have the capsule, your mind actually automatically works to make a kind of image of a barrel-shaped cavity. You know, it will be concave all around. So once you here, if you see here, there is convexity. The lobes are protruding. End point is it will be barrel-shaped cavity all around. So everywhere it will be concavity. So this gives you a mental picture that this is at the end of the surgery, how will be the fossa appear. Okay. So now initial few cuts of the median lobes are over, and soon I will go to the anterior, 12 o'clock.
So some people like to give a bladder neck incision to reach the capsule and define the depth.
Yes. Actually, you see, yeah, there are many ways to skin a cat. Now, there are advantages and there are not so many advantages. I will see in all cases, I give BNI at the end of it. If you want, you can do, you see, what happens is when there is big median lobe, you don't need it. When there is no median lobe, that helps, because otherwise, if you don't give, initially you may undermine the trigon. So it's not a bad habit actually. So if you prefer, you can do it. But when there is median lobe, you see I have given very deep cuts without doing BNI. Okay?
Yes, sir. Sir, we'll just quickly go to the other OT and come back to you, sir.
But let me tell you the last point. Here is the Viru. Now I am going 6 o'clock. Sorry, 12 o'clock. Now this is what I was telling about the blind bites. You see, this is a blind bite. You can't see anything. Be bold and give. First cut will not harm. Okay? Now you can see. So that was my point. So don't be afraid of being blind, especially anteriorly at 6 o'clock. And then once I'll do this, I'll increase the size of roof and then proceed on one side. Meanwhile, you can go, please.
Thank you, sir.
Yeah, sure.
Can we connect to Dr. Samit OT, please?
Hear me?
Yes, we can hear you, Dr. Samit.
Yeah, good morning. Welcome, everyone. We were planning to do a robotic simple prostatectomy for a 160 grams gland, benign gland. The patient had some ophthalmological problem, because of which the ophthalmologist was of the opinion that you can't keep very steep head lobe for a long time. So we decided to go ahead with the extraperitoneal approach.
Okay.
And you have the surface view?
Right now we are seeing you only.
Please, उधर दिखाइए. Camera उधर करिए इस पर. हाँ. So what we did, if they were transmitting and you were watching, we started off with a very small pen and steel incision, and through which we put a PVD balloon and made space, and then under finger guidance put our ports. So you can see the surface view, the ports are in and the robot is docked. Can you see this?
Yes, yes.
And then we have put in two instruments and freed the peritoneum. So initially we put 3 ports, first port under finger guidance for camera, and then a port can go through the Alexis port as well. So with 2 ports we created more space. Put 2 more instruments, one for monopolar scissor, one for fenestrated bipolar, and then dissected the area around to put the 2 more lateral ports and a 5 mm port for suction. So this is what it looks like from the inside. We have dissected a little bit. You can see these are iliac vessels on the side, and this is the prostate. This is the bladder. So what we will do now is to dissect the fat and expose the prostatovesical junction. At the prostatovesical junction, we are going to make an incision anteriorly like a U, inverted U on the bladder wall, just at the prostatovesical junction, and open it up and then scoop out the prostate, and then close this anterior layer up after doing a posterior reconstruction. We don't do that 360-degree reconstruction of urethra and bladder neck. We do only posteriorly. What it serves the purpose of, mucosa going in, and the chances of late bladder contracture are less. and the rest of the cavity is open for irrigation. Chances of infection, especially in these patients who have long-term prostatic obstruction and multiple episodes of UTI, we usually fear that there may be infection if we totally seclude the area, raw area, and do a 360 mucosa to mucosa reconstruction.
Thank you, Dr. Samit. We'll just present the case shortly and then move on to the next OT.
Thank you.
Good morning, gentlemen. This is the second case capsule of the day. So we have a 66-year-old male who came to us with mixed voiding and storage LUTs with a slightly raised PSA. His examination, the general physical examination and digital rectal examination were grossly normal. Ultrasound revealed a prostate size of 87 cc with median low. However, in view of raised PSA, MRI was done and it revealed a prostate size of 160 cc with median low hypertrophy and pyrites 2 changes throughout. His blood and urine workup was normal. His uroflowmetry showed maximum flow rate of 13. However, he did report subsensitive incomplete evacuation. So the plan of robotic simple prostatectomy was made. These are the MRI images. Thank you.
Samit, are we in your theatre?
Sorry for the interruption, sir. I'll just take a moment to present another case of the day. So we have a 75-year-old male patient who came with mixed LUTs after taking alpha blockers for about 2 to 3 months without any significant improvement. His examination was grossly normal. He had grade 2 prostate, non-tender, non-nodular. He was investigated and ultrasound revealed a prostate size of 42 grams without any significant post-void residual volume. His blood and urine workup was normal. His PSA was 0.19. So his uroflowmetry showed a maximum flow volume rate of 9.3 ml per second with interrupted flow pattern. So the plan was made to perform a bipolar TURP on this patient. This case will be demonstrated by Dr. S.P. Yadav, Chairman, Department of Urology, Pushpanjali Hospital. Thank you. Over to you, sir.
Hello.
Good morning, sir.
Good morning. Dr. Maheshwari, good morning.
Good morning, sir.
See, you are seeing, on which side should I see? This one?
नहीं सर आप सामने ही देखिए.
Yes.
हाँ ये ठीक है.
Dr. Maheshwari, just now Dr. Ajay was telling you about the various techniques. You all know the techniques. There is no issue as far as technique is concerned. The issue is, if I say कि अभी मोदी साहब की substitute नहीं है, same way I say bipolar TURP या monopolar TURP का HOLEP के अलावा और कोई substitute नहीं है. It has to stay for a long time. And it should stay because the results are, as far literature goes, results are as good as of HOLEP, as of any other techniques. So in bipolar TURP, what I am using this technique where we have 4 loops. People say that bipolar TURP takes a longer time. No, its loops are small as well as large. 4 loops are being used: cutting loop, incision loop, enucleation loop, plasma vaporization loop, and electrode for fulgurations. So these 4 loops are being used for different purposes. You all know at times you enucleate the prostate, at times you give an incision at the bladder neck, at times you fulgurate it, and at times you vaporize the prostate. The technique is you convert the solid into liquid, liquid into vapors, and vapors into plasma, and plasma ultimately destroy the prostate or resect the prostate. So the depth of resection in the plasma vaporization and plasma resection is very less, approximately 2 millimeter. So the damage to the surrounding tissue is less. Damage to the nerves is less. Second advantage is the charring which you have seen in monopolar TURP just now by the other surgeon is not seen in this bipolar techniques. And third, people say that it's a slow process. No, I'll show it's not a slow process. It's almost the same process. Same time is taken. 2 things which I want to communicate to the younger generation, that TURP is just like stitching of a coat or a shirt. If the shirt is not stitched properly, you cannot repair it. Same way, if the surgery of the prostate is not done properly, patient will never be happy. And the main problems, I'm going inside, and the main problems are stricture. One, stricture at the submeatal point. Two, stricture if you do a long time surgery at this bulbar point. And three, a contracture at the bladder neck. So, which I want to communicate to the younger generation is, please do not enter forcibly into the urethra. The submeatal area should be well lubricated, should be sufficient to let your scope enter inside, and your resection should be such that the going inside and outside should be smooth. It should not be so tight. If it's tight, you are using bipolar, the chances of the leak and chances of formation of the stricture at the submeatal and formation of stricture at the bulbar region. You may have seen many stricture urethras post TURPs at this site, because you are using for a long time. Same way at this site, this particular hemorrhage is because of the jelly and because of the endoscopy which I have done and they have done yesterday. See, this is the endoscopic view. Third thing which I want to say, that the ultrasound shows a median lobe. I don't think there is a median lobe. So ultrasound is a person-oriented investigation. See, Dr. Maheshwari?
Yes, sir.
The Viru?
We are there. Yes, sir.
Not very big prostate.
Yes. So, sir, for urethral calibration, do you routinely insist on otis or dilatation? What is your protocol?
Sir. Either otis or dilators or catheter.
Or catheter.
If the urethra is very tight, put a catheter. I'll ask him to come back after 4 or 5 days. Or otis or dilators. But I never do forcibly and in a tight urethra TURPs, because a lot of patient comes after 6 weeks or 2 months or 3 months, they have a thin stream, and ultimately the submeatal or the bulbar region. Yes, bladder neck also, contracture also I have seen significantly very high, but if you are comfortable at the end, as Dr. Ajay was saying, make an incision. I also always make incision at the end rather than in the beginning, because in the beginning it may lead to subtrigonal dissection if it is too deep. So now
Sir,
I'm changing.
in this patient, because there is hardly any lateral lobe, would just a TUIP be sufficient?
Honestly speaking, I'm not very happy with the TUIP. Once I make incision, both lobes will fall.
Okay,
sir. Both lobes will fall. So another few minutes to resect them.
True.
Another few minutes. I agree with you that just make a TUIP, and if you make a TUIP, both lateral lobes will fall in the center.
Can we have a lecture,
yes,
sir?
Tanuj may like to put the stents or Eurolift or resume. Let me change to the loops.
Dr. Yadav, sorry to interrupt you in between. Can we have a lecture, sir, in between?
Hello?
Yes, sir. Sir, you have anything to say before we move to one of the lectures, sir?
I think we can proceed
Hello?
with the...
Hello, yes, sir.
Yeah, I'm Anant Kumar.
Yes, sir.
So, so we wanted to, I think patient detail has been told to them?
Yes, sir, we have seen the MRI images and the details.
So this patient has got some ocular problem. So we are doing extraperitoneal. Invariably we do transperitoneal. But advantage of extraperitoneal is that patient position remains flat. So intraocular pressure won't rise. So in this patient we are doing in extraperitoneal, and we wanted to show the port placement. So you can show the port placement. You can see the port placement is the, so lens is at the umbilicus, and then as usual in XI everything is one line and 9 centimeter apart, so that you won't be clashing it. And there is a 2-port, one 12 mm port which is on the right side. And there is another assistant 5 mm port between the lens and the first arm.
True,
so
sir.
this is the confirmation, this is the configuration. And to create extraperitoneal space, that Samit has done a most difficult job. He has created the space, and he has put this hand port, Alexis device, and from there he created the space, and then he used this balloon to go in all the three direction, and then under the guidance, first port is placed under the finger guidance because the space is created, and then once the space is there, and the rest of the dissection is done with the robot, and then when the whole space is created, then the operation becomes the same. So this is the port position, and थोड़ा और पास लाके उधर दिखा
Sir, is this the same balloon we use for retroperitoneoscopy?
Yes, this is the same balloon. You can use the gall volume also, and there is another balloon comes which the general surgeon use for hernia balloon, which they create extraperitoneal space in the same region for hernia operation. You can use also that one because that takes the shape of the pelvis.
True, sir.
So with that, I am going to duck the robot and then start the procedure. Any question for that?
Any questions from the audiences, please? No, sir. We will go ahead with one lecture and then join you back, sir.
Okay, thank you.
I invite Dr. Vimal Dasi to please speak on FRISM. Can you please change one of the views to the presentation? I request Dr. Kamaljeet Singh to please join the panel of chairpersons, sir.
Well, good morning, everyone. At the outset, I would like to express my gratitude to the team of Max Saket for giving me this opportunity, and my special gratitude to Dr. Pragnesh. We have a lot of things as far as the management of benign prostatic hyperplasia is concerned. The problem statement is such that all the elderly people will have benign prostatic hyperplasia. Many of them will opt for the medical management, and many of them might eventually need a surgery. While as we have been innovating in getting different salts for the medical management, the surgical side has also been innovating, and we have a different armamentarium of techniques that are available for the management of benign prostatic hyperplasia. It depends upon the size of the prostate, the individual comfort zones of the surgeon, what he actually wants to choose. Like we have right now going on the monopolar, the bipolar, robotic simple prostatectomy. So it all depends upon the size of the prostate and the comfort zones of the operating surgeon, after making a shared decision with the patient, of course. So what I will be talking about today is RESM, or the water vapor therapy. RESM is a convective water vapor energy ablation technique, and it uses the radio frequency to create thermal energy in the form of water vapor. This thermal energy is delivered in the steam phase, and it gets transferred into the liquid phase upon the contact to the cell, and then this steam disperses throughout the tissue interstices and releases the stored thermal energy onto the prostatic tissues, affecting the cell necrosis within the prostate. So of all the techniques that we do for the management of prostate, wherein we try to actually resect the prostate tissue, herein we actually believe in contracting the prostatic tissue. So this is how it goes. You introduce the machine, you introduce the energy applicator through the urethra, you inject at multiple places at a distance of 1 centimeter at 3 o'clock and 9 o'clock. Then this energy goes and gets dispersed within the prostate. So the difference in the energy transfer here is that we are using a convective form of energy ablation here. Around 0.4 ml of water per treatment is converted into vapor, and it's convectively dispersed throughout the interstices. With convection, the energy transfer is uniform throughout the prostate, while as in the conductive heat transfers and the other techniques, the energy transfer is not uniform and may not actually be affecting all the desired areas wherein we want to act upon. So this is how it has been captured on an ultrasound image also. When you are injecting the water vapor into the prostate, it gets contained into the transition zone only and is affecting at the main areas wherein we want to act. What are the indications? Like any other indications of obstructive symptoms, the voiding symptoms, prostate sizes of up to 80 to 100 cc. Earlier it was only 80 cc, now the FDA has approved it up to the 100 cc size of prostate. Even the median lobe can be dealt with, is not in contraindication for rhizome therapy. Contraindications are the urinary sphincter implant, the penile prosthesis, and an active urinary tract infection. What's the setup of rhizome system like? This is the energy applicator wherein the needle delivers the energy. This is how it looks like. The first thing that you do is that you map the size of the length of the prostate from bladder neck up till the veru. Each area that you are seeing is roughly corresponding to 5 millimeters. We deliver energy at level of around 1 centimeters from the bladder neck and at 3 o'clock and 9 o'clock. And then distal to that, we'll again go to the distance of 1 centimeter and deliver the energy at 3 and 9 o'clock. So the more the size, the length of the prostate, the more the length between the bladder neck and the verumontanum, more will be the energy applications that we'll actually need. So this is how you place your energy applicator. You are engaging the needle into the prostate. Then you are pressing and delivering the energy. That's around a 9-second cycle that delivers water vapor into the prostate. And once that is done, you will disengage the needle again and go on to the next spot. So this is how it looks like before and after rhizome. After rhizome, you can see the gland shrinking and then releasing the compression over the urethra. And post-operative care and course is very critical. Before we actually take up the patients for surgery, they have to be thoroughly counseled that they will require prolonged catheterization for at least 1 week to 10 days. They will have to be counseled that they will suffer from severe dysuria on catheter removal, and that's going to remain there for a few days, because if they are not counseled for the same, then it's going to be a nightmare once we remove the catheter. So we have long-term data coming out now, is the 5-year follow-up data that's showing that the QMAX scores are improving over a period of 3 to 4 years, and then they plateau after 4 years. So similarly, we have the improved results, the reduction in the IPSS symptom scoring systems over the 5-year follow-up period. And one of the most critical part of rhizome is that it maintains the sexual function. So we have seen that ejaculatory function and the erectile function have been maintained. There's very less, if at all, any difference to the ejaculatory function if you are doing a rhizome therapy. So what are the practical considerations? It can be done under local anesthesia in an office setting. The time taken is hardly 5 to 10 minutes. The catheterization will be prolonged. That's very important to convey to the patient. There's a less time spent by the patient in the hospital. The surgery takes less time. It avoids the need for general anesthesia, particularly in those old patients who are having cardiac comorbidities and other things who cannot undergo a general anesthesia. There's minimal to reduced risk to the sexual function. So particularly younger people who want to preserve their sexual function and elderly people who cannot undergo general anesthesia is a good modality for them. That's all from my side. Thank you. If there are any questions, I'll be happy to answer.
Dr. Vibel, this thing.
Sir.
The one basic question which I think so anybody in the hall can correct me. Whatever I have learned about the rhizome is the median lobe remains a contraindication, and you said it can be done in median lobe.
Median lobe no longer is a contraindication now, sir. Median lobe of up to 2 centimeters or even beyond can be dealt with. The only thing is that while injecting to the median lobe, we have to be careful that once we are placing our applicator, you don't have to put it vertically onto the median lobe, because then the energy dissipation there's a potential chance of it going into the rectum. So what you actually do is that you place your energy applicator in the groove between the median lobe and the lateral lobe. You place it tangentially at an angle of 45 degrees and then apply the energy. We have done it, and this is thoroughly recommended.
Dr.
Yeah,
Ashish.
Yes.
Hi,
So you said that the ejaculatory problems are not being seen in resume, but very less so, than 5%. So, that's the data of the West. Yeah. But what we, in my own practice, I've done almost 15 cases now. I cannot guarantee an ejaculation when I'm doing a resume because there were 2 patients where we were not near the Veru, but still there was a problem in ejaculation. So we really do not know how much the steam is entering inside. The other thing is in a medial lobe, because there, the prostate gland may have a fibromuscular stroma and a glandular component. Right. So usually if there is a smaller gland, it has more of fibromuscular stroma, less of glandular component. Here a resume may not be as effective. Rather, and looking at the indication, as you said, I did 3 patients which were more than 100 grams and their flow was very good. Right. Rather than a patient who was 40 grams and he said that he wants to get it done. So I think we need to have to choose our patients. Yes, very carefully. I think size is not a contraindication, but as you said, as per the ejaculatory dysfunction is concerned, every time we are discussing it with our patients, the ejaculatory dysfunction, they are not 0 rates. They are lesser rates, and we have to be very careful. You said you were very careful while you were injecting the viromontanum. The problem is that while we are injecting, the apical lobe bulges out, and we think that we have to inject more over that area. And that is the place wherein if you are injecting more, that energy dissipation can go into the viromontanum, can go into the ejaculatory ducts, leading to a failure and having an ejaculatory dysfunction.
So if you look at the guidelines, the only procedure in MIST which has been recommended by EAU would be a Eurolift, rather than if the patient is very much categorically saying about the ejaculation.
But the Eurolift has its own problems, the size of the prostate and other things. That
I think
everything comes handy.
we need
have
to
to
agree.
actually individualize the things.
We need to agree on this, that if the patient wants a assured ejaculation,
Yes.
then probably resume is not the way to go.
Yes.
So if ejaculation is the most important concern, then we need to tell the patient that there is a 5% possibility
Yes.
that ejaculation would not be maintained.
Yeah, less than 5%.
Yes.
But
So-
it is there, yeah. It
yeah.
is there.
So if that is the major concern, then resume is not the way to go.
Right.
Yeah. Thank you.
Thank you. Thank you.
Hello. Are we connected to the OT? Which OT are we connected to?
Dr. Maheshwari, sir.
Yes,
few
sir.
seconds
Sir,
more.
sir, looking
Sir,
very
please-
good. Fossa is looking brilliant.
Sir, just see how sharp it cuts.
Yes,
honestly
yes, yes.
speaking.
Fossa
And-
is looking extremely good, sir.
It's very sharp cutting. It's not as expected. You just see. And I'm sitting at the bureau. Most of the prostate is out except a little bit at the top. And then now I will make a small bladder neck incision and show.
So here again, would you give a 5 and 7 incision or a single 6 o'clock incision?
Sir?
The bladder neck incision, what would be your plan?
Yes, I'm giving bladder neck incision, sir. At 5 and 7 both, sir.
Both, okay, sir.
Shifting over to next OT.
Can we switch the voice to the
डॉक्टर सर मेरे से बात में
हाँ जी सर, we are there with you, sir.
Okay, so I have actually finished. You see, for resident, what I want to say now is how to do systematic hemostasis. So once we are almost done, so you start from the bladder neck all around, go check. At the same time, you ask the anesthetist to raise BP. I'll show you the fossa and everything. So this is the first part. You start hemostasis going all around, and then you go to the roof. So why this? Because all the bleeder which is coming from the top or the side, they all collect here. So here the clots are there, and initially you keep coagulating the clots. So the rule is coagulate the bleeder, not the bleeding. So this is the bleeding, here are the bleeder. So that is one simple rule. And secondly, I wanted to say something about TURP, especially for the resident. You see, TURP is a very good procedure. So nowadays there are so many lasers are coming up. So for the resident, don't think that if you, TURP is inferior posterior. Understand that prostate gland is better handled in piecemeals. So smaller prostate is better handled in piecemeal. As the prostate starts getting larger, then the piecemeal handling becomes more difficult. So this is a procedure one must learn. So now this is the viru montanum. While removing this, because there was some overhanging lobes, I have just grazed the viru, which is okay. Now you see, by the side of viru, there is no tissue here. I wanted to show how did I do it. So you see the transition between the lobe and the urethra. You put the margin of your field here. As I told you, it will cut only what is seen, and you do a bold cut. It will never go beyond. So this is one thing. Hemostasis is there, and I think fine. This is what we also do is we keep giving Lasix after every 4 bottles. 4 bottles of glycine. This is our practice to prevent the hyponatremia and all. Secondly, we always give BNI. In this case, I have given incision. If you see, the ureteric orifice is quite close, so I went little lateral to it and did the cut. Similarly here, the orifice was here, so my cut was little lateral. And when I thought that bladder is still not opened well, so I have given a little cut at 6 o'clock, which is now not visible because I made the things flat. So I think, are you happy with this? This is the viru montanum, which I have grazed, of course, while removing here, which is okay. And yes, this is the fossa. Yeah. Are you hearing me?
Yes, sir. Wonderful. Perfect,
okay.
Sir.
Okay. Thank you.
Thank you. Thank
So
you.
I'll
Sir.
just remove the before I come out. One more thing. Before I come out, of course, we make sure that
We will
everything
shift
comes
over
out.
to next OT, sir.
Anand Kumar, sir, we are with you.
Yeah, hello.
Yes, sir.
Yeah, you can see it here. I have opened at the bladder neck, and there is a ureteric orifice. There is one ureteric orifice is here. You can see it. Pani dalna jara suction kar lo. So there is a one ureteric orifice is here. Other ureteric orifice is here.
Yes,
Just
very
I
clearly
put the
seen, sir.
needle, and you can see the gland is so vascular. Only
Right.
by needle so much of blood is coming. So I know my ureteric orifice. This is a huge median lobe which is projecting, and you can see this is the catheter always goes to the lateral side, and this is the this is the area. So what we'll do, I'm going to put this 20 vicryl suture, and this suture will lift the lobe, and then I will give an incision here and start doing the dissection posteriorly. The problem with the Millens, actually I'm going to try that. In Millens we have to give incision there, but then I have to go one side, start from anteriorly, goes to the posteriorly. Here we start from posteriorly, and gland is remain attached to the anteriorly, so it is not falling. But once you have mobilized the anterior part, the gland will start falling, and then there may be some little difficulty, but finally it will all done. So I'm going to try that in not in workshop, but after that, and we will see that. Maybe next time we will show you the Millens prostatectomy.
Sure, sir. Sure. I always thought that probably there would not be enough space for the movement of the arms.
The arms movement, I don't think should be the problem.
Yes.
It's the you'll have to do anterolateral dissection first. इसको needle काट दो. ठीक है, okay.
So we'll continue with our next lecture. I invite Dr. M.S. Jha on the dais to please share his ideas on ITIND.
Section करो.
Good morning, everyone. So I will be presenting the next minimally invasive surgical treatment for prostate. We have already discussed Resume. So iTind is another of such treatments. I'll start straight away with what is iTind. It's a temporarily implanted nitinol device, and it has 3 longitudinal struts, as you can see, and an anchor at the base, and a retrieval suture that is attached at the tail. It's implanted cystoscopically and removed after 5 to 7 days. It's coming on that side.
Just put it on our screen.
It's coming on the other screen. अच्छा यहाँ पे नहीं आ रहा. ये front screen. Yeah, so we implant it cystoscopically, remove after 5 to 7 days, and the goal is to remodel the prostatic urethra and bladder neck to relieve the obstruction while preserving the antegrade ejaculation. Now, why iTind? Because as we have seen, there is a spectrum of treatment options now for BPH. This is one of the options. The conventional options, we all know, watchful waiting, medications, and then surgery, either TURP, laser, or nowadays the robotic simple prostate. But there is a treatment gap with these conventional options because there are many people who want to avoid long-term medications and they are not fit for invasive surgery. In sexually active men, they want to preserve the antegrade ejaculation. And nowadays, many people come and demand for these minimally invasive procedures. They read about it and they want to go through this. So we should have it in our armamentarium. This is the mechanism of action, the insertion of the device. It's first deployed in the bladder. We first insert a cystoscope. I'll be showing that video, and then I also have iTind case to demonstrate in the live surgical workshop later on today. So it's implanted cystoscopically through the sheath. It's deployed in the bladder, and then under vision, we position it in the prostatic urethra in a way that the 3 nitinol struts are placed at the 12, 5, and 7 o'clock position, and the anchoring leaflet is placed in the prostatic urethra distal to the bladder neck so that the device does not migrate into the bladder. And once in place, the compressed device expands over time to retain its original shape. This is the property of nitinol, that it gradually retains its original shape. And while it is retaining the shape, it makes the cuts at the 5, 7, and 12 o'clock position. So this is how the device expands over 5 to 7 days. And this expansion period, ischemia, necrosis, and scarring, create the 3 deep longitudinal channels. And in a follow-up appointment, we can do a cystoscopy and check that the integrity of the verumontanum, bladder neck, and external sphincter is preserved, and there is no permanent implant that is left in place. So the patient is relieved of his symptoms without a permanent implant being there. This is how we've discussed ischemia, necrosis, and scarring. It creates the channel. So the ideal candidates would be a patient with IPSS which is more than 13, a Qmax that is reduced, and a prostate volume between 25 to 75. So this is what is given in the literature, but normally we prefer doing iTind for smaller prostates up to 50, 60. We haven't done it in a 75-gram prostate. And for people who are desirous of preserving their ejaculatory or sexual functions. Relative or absolute exclusions would be a prominent obstructive median lobe because iTind won't treat the median lobe, presence of active UTI, urethral strictures, or prior extensive prostate surgery. It has to be a shared decision-making. The patient should be well aware of what his expectations are from this treatment. The improvement in flow might not be as good as a conventional TUR or a laser prostate. He might have some transient symptoms in the first week or so while the device is in place. And even after removing the device, the flow improvement takes maybe another 2 or 3 weeks. And he should know that there is a risk of retreatment later on, maybe 2, 3 years, 5 years down the line, he may need a retreatment. The procedure is done as a daycare basis. We can do it under local anesthesia and sedation or in a short GA. There is a cystoscopic placement. This short video would show how the device is placed. First we do a cystoscopy and leave the sheath in the bladder and remove the scope. Then we put the device in so that it opens up inside the bladder and remove the sheath. Now by the side of the device, we do a cystoscopy again to position the anchoring leaflet correctly in the prostatic fossa. So we withdraw, this blue line should be at the top. That keeps the anchoring leaflet down at the 6 o'clock. We withdraw it gently. And when it reaches beyond the bladder neck, it holds it in place. And the other struts at the 5, 7, and 12 o'clock position. Now, the knot of the thread is cut at the tip, and the thread is taped to the penis. This is the inside view of how the device expands over these 5 to 7 days and then creates those cuts. For removal of the device, the company initially recommended a access sheath of 14 French, but the tip of the access sheath is quite hard, so it may break the suture. Now they recommend a 22 French catheter, which can be cut at the tip, just distal to the balloon. And we insert the catheter over the thread, a rail rolling, and then you pull on the thread, the device comes out through the catheter. So in the perioperative period, we may need a catheter for a short time in some patients. Normally it's not needed. We give alpha blockers and if required, a single dose of steroid. And if there is a retention, we may put in a feeding tube, or they even recommend a 12 French catheter can be placed, but that has to be manipulated beyond the struts that are there. So we have discussed this positioning. The anchoring leaflet should be just distal to the bladder neck. Now this is the evidence at a glance. According to the literature, there is a reduction in IPSS, improvement in flow, the quality of life improvement is there, and the sexual function is generally preserved. Some common transient adverse effects of dysuria, frequency, urgency, hematuria would be there, but all this resolves in 2 to 3 weeks. And uncommon serious adverse effects of urinary retention or UTI, they are quite uncommon. There is no long-term foreign body risk, no device remains in situ. The symptom and flow improvements are sustained in 2 to 3 years of follow-up that we have. The retreatment rate is usually less than 10%, and predictors of retreatment would be a higher baseline obstruction, presence of a median lobe or a large-sized gland. So in the missed landscape, with a Eurolift, you have a permanent implant in place. With a Resume, there is a delayed effect with a long-term catheterization and a persistent dysuria which may last for 1 to 2 months. With a iTint, there is no permanent implant. The effect after removal, there is a very early recovery and the patients have minimum adverse effects. TURP laser obviously have a greater improvement but higher invasiveness and adverse effect profile. So in India, with an ambulatory workflow, minimum disposables, short procedure time, limited anesthesia requirement, it may be ideal for patients who prioritize functional preservation and rapid recovery. So take-home message that it's a reversible office-based procedure without a permanent implant, demonstrates clinically meaningful and durable improvement with preservation of antegrade ejaculation. Patient selection is the key and expectations have to be discussed with the patient. And it fits well within a step-up BPH pathway in a high-volume center where we can give the patient as per his demand. Thank you.
Sir, is there?
Yeah.
Is there any chance of ejaculatory dysfunction with iTint?
We have limited experience. No patient has had it. So according to literature, nobody says 0%. But practically the cuts are distal because you anchor it in a way that the cuts are quite
in my practice also, I'm keeping it for very young patients with high bladder neck. That is my patient for right end. So I think Dr. Saini has done a good number of cases. Will any chance? So just like Eurolift, we can.
Yeah. So we see it's not yet recommended because the data is not there. But then in all the patients, they were done in young patients who were all sexually active. None of them had an ejaculatory dysfunction. So because the device is just cutting at the bladder neck, and we are the superior, the paracollicular area of the veru, which is the one which causes the ejaculation to come anteriorly, is untouched.
Yeah.
So it should not cause the problem.
Another issue that I faced was getting that catheter, 22 French open end catheter.
Actually, this I wanted
it is
to
not
say.
available.
So when they initially came to us, they also recommended a 20 or 22 French catheter. You cut the end, and then the problem is the catheter has an eccentric, there's a channel for the water. So because of that eccentricity, it needs a lot of, the device may not come completely inside it, and there may be pain. So a traditional ureteric access sheath, which was the one which we were using initially, now we are not using the 14 one, that can be used easily, and I'm doing it, there is no problem in retrieval of the device with that sheath.
Does the patient suffer from urinary incontinence because of the thread?
No, it is more of a discomfort to the patient. So,
Some leakage or some urgency?
so some people, the other thing is that the dressing which is there, it can get wet. And because of the dressing may fall off. So I had one patient with the dressing fall off, and he put his foot on the thread, and the device actually came out to the fossa navicularis. So that was in one case.
Sir, what is the principle behind it? After it is removed, then what makes it the prostate, the space?
It's like a bladder neck incision because the device is at 12, 5 and 7 o'clock. And with the pressure of the device, there is a tissue ischemia, necrosis, and it makes a deep cut. So it's just like a traditional BNI that we do with a limited BNI because it does not extend up to the verumontanum. It's just at the bladder neck and maybe reaching up to the mid-prostatic fossa.
This is more like a remodeling that happens.
No, obviously with a BNI, in this it is a more precise and a limited cut. While doing a BNI, we are used to doing it right up to the verumontanum and preservation of. And
this is. Sir, this is more like a remodeling. You're not making cuts. It is the pressure. That's why the ejaculation is preserved.
Dr. Jha,
these are not really cuts. They are.
Dr. Jha, can I ask you one very simple question? Do you continue your alpha blockers after you have done the procedure?
Yes.
If yes,
yes.
Why?
No.
Because your first thing when you are saying to the patient is this is a substitute to the oral medication.
No, we are continuing it just for a month because in the first month, because of the tissue ischemia, necrosis, there will be some edema. So the effects take time to come. So just for the first month, alpha blocker is continued. After that, it is withdrawn.
We have seen a lot of procedures coming in for prostate. When we were doing our MCH, it was Dr. Anish was my teacher. I would like to have comments from the seniors. What do you think from the core of your heart, which of these procedures is going to stay for some time?
So I think that you have put a very valid question, and today if we see is a huge big spectrum, but if you look at the exclusion criteria in all the studies which have come up for iTind, Resume or even Eurolift, they have excluded majority of the patients which we see today. Now if we see, because he also said that Qmax more than 13 is the case to go for
IPS is more than 13. IPS is more than 13.
Yeah. Now question arises that what is the spectrum of patients which we get? We get patients on catheters, we get really big, as Dr. Anant Kumar is showing. So the spectrum of patients which we have is very diverse. And to answer your question, it is the patient which is really on the steering. Patient tells, because we are getting international patients also today, And they say, sir, when I tell him that I'll do good HOLEP, he says, sir, I don't want good HOLEP from you. I simply want you to do something to fine tune my prostate. So this is an Afghani patient who came to me and he told me that I want fine tuning so that I can continue my sexual life. So I think the bottom line is that we have to understand the needs of the patient. We have lot of bouquet in our now, and every modality will find its place. It will be another 4 or 5 years that we will be able to come to a consensus that which one is the best, but ultimate dictator is the patient.
So that's true, sir. That's why we should have all this in our armamentarium, and we can offer a young sexually active male these procedures, and then if he understands the retreatment rate especially, because the immediate results are there. Whatever limited patients we have done, they are happy with the flow initially. We don't know what will happen 5 years down the line.
So to answer your question on what is going to happen in the another 5 years, whether these procedures are going to be there. So if you look at the US data, we had a AUA meeting, and then what they found was that Eurolift is going to be stable because it is the oldest one. Resume is going to increase a bit further, and maybe the ITND may see the initial rise and then it becomes stable. So for any procedure is something like that.
So Dr. Jha, my main reservation for ITIN is, you said you have a big spectrum, right, from say 20 gram of gland to 70, 80 grams. And on the other hand, the mechanism of action is like, or the working is like a bladder neck incision. Now we all know that BNI alone is only for small glands. In Eurolift, the device keeps it open all the while, whereas after a couple of days or 5 days you remove this device, and so how much necrosis and all will be there, or ischemia to the rest of the gland, so that it has a long lasting effect?
So the rest of the gland, the company says, or the literature says up to 75 cc, but we haven't done it in larger glands. We have done it for up to 40-50 gram gland. And there is a nice cut that is there at the bladder neck. We have done a cystoscopy after the removal of the device, and we can see nice cuts at 5, 7 and 12, and the bladder neck seems open. So it's mainly for a high bladder neck patient who wants to preserve his antegrade ejaculation, or a prostate with a prominent bladder neck. So because in such cases, Eurolift is not ideal. When the bladder neck is high, then Eurolift doesn't work. A patient who has come for a mist, and we do a cystoscopy and decide whether a Eurolift would be better or a ITIN would be better. And the patient, it's the patient's demand that I want a minimally invasive treatment.
Yes, sir.
Dogra sir. Dogra sir.
Yes. I think there is a very old saying that you have to give time for the water to find its level. We are in a hurry, just doing few cases, and there is a pressure from the industry to speak. I think you should not be so much emotionally attached or committed to this. You should straightway mention the facts. These are the facts, this is the efficacy, this is the duration. It will take time for these issues to resolve. We can't say in a 4 year, 5 year, it will take 10 to 15 years for these type of therapies to stay in the market, or they will be out of the market.
Yeah,
it's too early to, I think, comment or to lament. Thank you very much.
Dr. S.P. Yadav is waiting for a long time. He wants to show the fossa. So can we interrupt in between and shift to the S.P. Yadav sir's OT for a while?
Yeah, sure. Dr. Yadav sir.
Kamaljeet.
Sir, good morning.
I have completed it.
Yes, sir.
Two, three things I want to communicate to the younger people, that this area must be seen, vesicoprostatic area. At times when you put a catheter and inflate the balloon, these areas go inside and they may give some color to the urine. Number two, if there is any ooze, any colored urine comes during surgery and you don't find the vessel, just tilt your scope up. The bleeder will be there on the top. Number three, some amount of the mucous membrane, yes, here at this sphincter side, leave behind. This helps the patient in maintaining the continence, and some of the vessels sometimes here should also be fulgurated. But in bipolar, the current depth is too small, so hardly there is anything. I have completed. This is the both ureteric orifices, and this is the fossa, absolutely clean. So with this, I think I should stop it and complete.
Yes, sir. The fossa is very well seen, sir.
I am thankful to Professor Anant Kumar, Ragnesh, Anush Sharma, and the whole team of anesthesia who has given the patient anesthesia for such a long time. Thank you, madam. Thank you, all the teams. Thank you, sir. Thank you, Maheshwari, sir.
Thank you, sir. Thank you.
Sir, one comment, sir. Sadasuki, sir, I mean, he was the HOD in SMS Jaipur, and he was a great resectionist.
Indian.
He used to tell something which is not written in the books, and I'd like to share with it. And he says that more than what the fossa looks like inside a distended bladder, what your fossa looks inside an empty bladder is very important. And I think that over the years, from becoming a lecturer to professor myself, I used to think about all of us when we do resections and when we see a fossa inside a full bladder, then I mean we can be over the moon. But there is a lot of difference in when we empty the bladder and then we see the fossa, then actually we get to know where the obstructing tissue is. For example, there might be some apical tissue, there might be some tissue which is hanging from the roof. I tried to look at this practical point that he taught us when we were lecturers, and I could not find it in any book, but still I think for my juniors this is very important. Don't get carried away about what your fossa looks inside a distended bladder. The whole hydrostatic distension is going to fill the prostate. But it's also important to take a look at the end of the resection when your bladder is empty, and you can course correct your resection after that. Just a point that I wanted to share.
Great.
May I invite Dr. Nachiket Vyas to please...
Can we go to Dr. Anand Kumar for a minute?
Can I answer?
Yes, sir, please.
Hello?
Yes, sir.
Nachiket is right. When you distend the bladder, in the very beginning also the fossa appears absolutely empty. That's why Ajay also has told you that once you give an incision at 5 and 7, lot of tissue will come out and you resect them. Same way, deflate the bladder and then you see how much tissue is left. I agree with you that once you deflate it, lot of tissue, lot of bulges will come here and there. But they may be too less. If you resect them deeply, you may go outside. I agree with you, sir.
Dr. Anand Kumar, sir, we are with you.
Yeah, hello.
Yes, sir.
Yeah, okay. I will show you what I have done. See what I have. First, I will show you here. So we have to take multiple sutures to lift the posterior side of the gland, and this posterior side I could dissect as much as I could see.
Yeah,
and you can see that urethra is opened here, that's why this catheter is seen here.
Yes, sir.
Okay, so we have gone, and then I have gone to the right side, lateral side, as much as I could go, and same thing I could go left side as much as I could go, and during that whatever bleeder comes we just coagulate it, and I keep my current monopolar bipolar at 5, so that because most of the structures are away from here. Now I have to go to anteriorly and anterolateral, and here I might decrease my diathermy to 3 because I don't want that sphincteric region should have the bipolar current effect. So now I have reached there. So what we will do, this is the anterior part of the capsule. You can see it here. This is the urethra. The catheter has gone here because we have perforated somewhere in the posterior side. So if I give incision here, and this is the same plane, I will just, I know where is my plane. So you can see that it was faster when I was doing it here, but since I am going anteriorly and I will be close to the sphincteric region, I have decreased my current and my process will be little slower. So same plane is, and it is also like in open surgery you do the dissection with the hand. Here also you see most of the time we do the blunt dissection and it opens up most of the times. So
Dr.
anything which is, yeah.
So do you suggest or that the catheter should be seen only, from the proximal end, not where it is seen at one more place? So while we are doing the dissection, should we see it only at the tip, I mean the proximally, or?
No, see the catheter usually comes out here. So while doing posterior dissection, probably that urethra is somewhere open and that's why now catheter is here.
So
you can see it here.
So we have to change our plane of dissection?
No, so when I'll go posteriorly, I will see. So what I am going to do it here.
Okay.
See, this is my anterior commissure. Okay?
Right.
So this is the anterior part. I am going to the apical region and I will dissect the apical region. And once I will, because I want to deliver the apical lobe away from it. Okay?
So what is the main landmark here? Because this is a crucial area. One might go beyond Viru.
Yeah, we'll show you. We'll show you. Okay. So now you see it here.
Sir, one question was that you said you use higher temperature at the, higher quadrille settings posteriorly. Is there a risk to neurovascular bundles?
Capsule is still around it, so it should not be. And I am in between the peripheral zone and transitional zone. So there is a peripheral zone and then there is a prostatic capsule and neurovascular bundle is beyond that. It should not.
Okay, sir. We'll continue with our lecture, sir, and we'll be watching you.
Dr. Nachiket Vyas.
Thank you, sir.
You are invited on the dais.
Thank you, sir. Thank you, Chairman, sir. So the topic that I was told to cover was prostatic stents. And this should have been the first topic today because everything in prostatic stents has already been discussed since yesterday and today. So I'll be skipping a lot of my slides with your permission. So coming to a little bit about the history, they were introduced in 1990 and the only indication at that time was relief of bladder outlet obstruction. Urolume was the first used metallic permanent stent, and Urolume has now been discontinued in 2004 on account of the multiple complications with the Urolume, like it was associated with incrustations and overgrowth, and it had a high very complication rate. Now we have newer temporary stents that can be placed for around 3 months, 1 year, namely the spanner and the memocath. They are still used and they are safer and they are removable. Spanner, it is made up of silicone and memocath is made up of nitinol. Currently they're reserved for select high-risk patients and palliative use that we have all been discussing for the last 1 day or so. We all know about patient selection for stenting. It's important that whenever we are putting stents, temporary stents especially, we should always rule out certain bladder pathologies, and like the patient should not have any history of a bladder tumor. At the same time, if we are putting it for patients who need palliative care for bladder outlet obstruction due to prostatic problems, then we also need to rule out some strictures of the urethra. This is because there are certain stents, the modified stents have to be placed for both. That is, you have to place them inside the prostatic urethra at the bladder neck, and stents would also be then have to be placed inside the bulbar urethra like the memocath. So patient selection is also important when you're deciding what type of stent to use. This is the classification. We all know that they can be classified based upon the duration, the material, the mechanism, and also the surface. Now, multiple stents which are coming, like the mammocath which is made, this has got a special covering, and this covering decreases the risk of epithelialization, which used to be one of the biggest, and incrustation, which used to be the biggest problem of these temporary stents. So the two types of stents which are most commonly used is a spanner stent and the Memocath 28. Memocath is available in different sizes. We have the Memocath 31, Memocath 45, and after the success of the Memocath inside the prostatic urethra, then ultimately Memocath stents, as we all know, they were also introduced for ureteric obstructions. The permanent stent overview, this is the urolome stent. The urolome stent has been used for long-term implantation in the prostatic urethra. But however, multiple issues like migration, incarceration, impaction, tissue overgrowth, there was a problem with this stent. And ultimately, sometimes when these stents could not be removed, then removing of these stents was really a big problem. This is because these stents used to be incarcerated inside the urethra, and they used to cause a lot of strictures. And the only way sometimes, if they could not be removed cystoscopically, was you had to do a urethroplasty. And these stents, ultimately, the wires of the stents had to be cut. All the wires, they had to be removed manually. And ultimately, the urethra used to become so macerated that the stricture repair or the urethral repair in these patients also was very difficult. So that is why urolome then was withdrawn in 2004. The other stent which can be used and which is very commonly, it is marketed from Denmark, it is FDA approved, is the spanner stent. The spanner stent, it is a stent which is made up of silicone and nylon, and it has got multiple parts. It has got two balloons, a larger balloon that fits over the bladder neck, and this balloon basically is that so that the problem of migration of the stent is not there. There is another smaller balloon. The smaller balloon is placed inside the end of the prostatic urethra. Then it has got a teether, and the teether is pulled out of the urethra, or it is just left inside the fossa navicularis. The problem about these stents is that they have to be removed or exchanged every 30 to 90 days. So that is why the patient would require a repeat procedure after 90 days, just adding to the cost. The Memocath, this is a thermo-expandable stent. This is a temporary stent, and it is made up of nitinol. It expands at 50 to 60 degrees centigrade, and at extreme cold temperatures or water, it used to contract. Memocaths, now they are less used inside the prostate and urethral as a urethral stent, but however, they are still very popular for ureteral stents. And these Memocaths, again, they are available in different sizes. This is a comparison table, and I would not go into the detail of the comparison table, but the only thing is that the urolume and the ileum, they seem to be the stents which now people are not using that frequently, and the spanner and the Memocath are there to continue. I would not go into the insertion techniques, has all been seeing this. Also for the spanner stent, I'll not go. The Memocath, now one of the modifications or the next generation Memocaths, they're trying to decrease the temperature for the expansion which is required, because there have been reports in the urethra of the severe scalding of urethras, and also hot sterile water at 50 to 60 degrees causing dysuria for a long period of time. They are under production, and they are trying to make this expand material at temperatures in between 35 to 45 degrees centigrade, which are more close to the human body temperature. This is the clinical success rates of the different stents. Catheter-free voiding was over a whole duration on different variety of stents. The improvement was 90%, the significant improvement inside the IPSS. And I'll just go again to the last. The future. What is in the future about stents? The future would be that they would be biodegradable stents, and which would not need any removal. We have materials like the polylactic acid and the polyglycolic acid. These materials, they are found to be more inert, and the amount of crystallization and epithelialization would be less. Then there would be drug-eluting stents, which also release anti-inflammatory and anti-infective agents locally, reducing the incidence of stricture urethra. And there are stents which are now being produced, which give also a little bit of mitomycin release as a drug. Mitomycin is known to reduce epithelialization by causing DNA damage. And there are also other stents which are, they are going to be 3D printed depending upon what shape and size is required for individual patients. They're going to be smart stents, and they are going to have sensors. And the advantage of these smart stents with sensors is that if the stents starting themselves to become, obstructive of this migration, then they will allow for real-time flow and pressure monitoring, which will help inside finding out when to change the stents and if the life of stents can be further enhanced. These are ongoing trials, and I think that in the future we will have stents which will also able to guide the patient about either going to be patient AI generated data which will come on the phone of the patient telling him that if he has any problem, then he can contact for stent removal or change. Thank you so much.
Thank you, sir. I think.
Thank you, sir.
Anand Kumar, sir, we are with you.
We are not able to listen to you, sir. We are not. Audio from the Anand sir's OT is not. We can't hear you, sir.
Just when we joined to the OT, Nachiket, I just wanted to share with you, in one of the South Zone conferences, there was a urologist, and he said,
hello,
that, sir.
Yes, sir.
Hello.
Yes, sir.
Yeah. So I just wondered, adenoma has been in block removed, and what I wanted to show you a few things here. If you come closely and watch, you can very nicely see this is the urethra. I haven't done the hemostasis, I'll show you. And here you will see the viru. This just underneath is the viru. And and this is the bladder neck. So this part of the urethra is all intact, blood supply, this sphincteric complex is all in. If I have to show you viru, I have to lift and do the dissection. Viru is somewhere here. So this is cut beyond the viru. Now this part of the urethra will be anastomosed with the prostate. And now I am going to do the hemostasis. So what I was trying to tell you that in extraperitoneal approach there is no space. Once the adenoma has come out, it was falling here and it was not allowing me to move. So what we did from the hand port, we removed the adenoma. Now you can see I have got the space. So I will do hemostasis. We can show you the adenoma. Camera either, and there may be some nodules here and there. We can either dikhao median lobe or some. I'll just show you the specimen. There may be few nodules are there which will remove once I'll do the hemostasis.
Sir, we need the surface view, sir. We are seeing that.
Yeah, we are going to show you.
Yes, sir. Now we can see you.
So this is the urethra. That was the anterior part, so the median lobe. That's the median lobe, and this is the lateral lobes. And there is one extra adenoma you can see. There will be few more lying there, few nodules. We'll remove all of them, and then we will do the urethral reconstruction. Now, first thing I'm going to do is the hemostasis. I packed the fossa for 5 minutes, but now you will see that hemostasis is quite easy. And with the bipolar or monopolar, we'll do hemostasis, and then the urethral reconstruction will start.
Thank you, sir.
So you can have now inside the view.
Yes, sir.
You can see that you are getting now. These are the something is bleeding.
Anand.
So we will.
Hello.
I will just do the 30-degree up, so that you can get a better view of the fossa. Now, whatever is bleeding under, you can see here, we'll just touch it.
Anand?
Yeah.
You have done a wonderful job. I just a few things to share with you. Before doing this procedure, one should ideally do a endoscopic evaluation to know the configuration of the lateral lobe and the size. Relatively, one is larger and the other is smaller. So what I do, I will take out the small lobe first into the bladder, lobe one by one. keep it attached to the median lobe, and then go to the other lobe. Because the bladder neck is a very tight and rigid. It's very difficult to deliver the whole of the prostate and mass through the bladder neck. And this is the problem which the beginner even feel, and that is why probably not able to come over this, that how to remove this. So remove first the small lobe, keep it attached to the median lobe or at the base, and then remove the larger adenoma. It's very easy, because bladder neck is the one which is a hindrance, is a very tight and rigid. You have to cut the bladder neck unnecessary. If you follow one lobe by other, then there is no need. It simplifies. Thank you.
Yeah, you are right. It is not necessary that whole gland should come out in one go. That is not necessary, because we always, prostate surgery is always into pieces. You do TURP, you do whole up, you make 3 lobes. So more often, when the gland is too big, it is not possible to take out one. So what we do, then we cut the anterior commissure, take out the one side, then take out the other side. Median lobe, if causing problem, you can take it separately, but most of time median lobe is attached to the one of the thing. Now you can see there is one nodule is still there. So I am going to take care of this nodule, and this is the 5 o'clock bleeder which I am trying to coagulate. So now this nodule is left behind. This nodule is left behind. We'll just remove the nodule. I will not go deeper to it, like just inoculation of these nodules. That's all. And then reconstruction will start. And now the diathermy is at 3.
So can we move
So
to the last
that is
lecture?
the advantage. Our vision is so good, we can do a very good hemostasis. With the combination of bipolar or monopolar, we can. So that's the urethra. You can see that half of the urethra is preserved. And if I have to show the view, I have to go the sections some here, which I am not going to do it. And this part will be reconstructed. So here is the sphincteric complex. All the apical adenoma has come out. Only this nodule I'll remove, rest everything has come out.
Great job, Dr. Anant. And
Thank you.
I was just mentioning one of the conferences in South Zone, and we had a urologist who has done a lot of work on the Bernoulli's principle, and that is the physics principle, that how much prostate should be removed. Does we need to remove whole of prostate? When Dr. Nachiket was talking about stents, we have been discussing all through about iTind and all these modalities, and now we can see how much prostate, the whole prostate has been removed. So the question arises that what he did was that he is not doing any of these newer modalities. He is doing TURP with modulation. Modulation means he is calculating pre-operatively the bladder as well as the prostate, urethra, and then he is doing a very modified resection just to see that he voids good, well. So the whole community was against him, but this is one thing which is an insight into the research, and that is how the research has developed, that how much to remove and how much not to remove. Do we need to remove whole prostate, or we tailor it as per the dynamics of the system is concerned? So I think that future is here, AI is here, and 10 years, 20 years from now, definitely things have to change.
Now you are very right. See, we all know you remove the medial lobe, patient start widening. In a very large gland, people have removed one lobe and came back after some time to remove second lobe. Okay, and then when you do the cancer prostate, we do only channeling. We just create a good channel, patient starts widening. So it's not necessary, but you know, if you have done enucleation, like either you do in laser or you do in robot, the one thing is or you do the open operation, whole gland is out. And we all know this is aging process. Whatever peripheral part we have left will be growing. It won't stop till the patient meets the guard. And that's why if it is done in early 60 and 70s, the patient needs secondary procedure after 10-15 years. So if you do the only limited part, the patient will come back after some time when the residual adenomas will grow. So that's why the best result is achieved after simple prostatectomy, laser prostatectomy, and laser enucleation, and robotic surgery, where the most of the transitional zone and the BPH is removed.
Yeah, yes, sir. I think you have made a very valid point, and this is exemplified because once I operated in Singapore, and it was Dr. K.T. Fu who says that the whole Singapore used to tell that Dr. K.T. Fu does a wonderful TURPs. But today, why I am concerned is that the people in whom I did TURP 10, 15 and 20 years back, they come back to me with not obstructive symptoms, they come back to me with hematuриas. So the kind of statement which was made by him, no, we have to live more than that. So he lived at the age of 80, he said, that the people he did TURPs, they come back to me at that time. So therefore, it is the longevity of the procedure which is defined by complete removal. And being a benign disease, I think we should invest our time and energy to do a complete removal. But then the modalities which are coming have different set of indications, and time is going to tell us about their stand.
So can we move to the...
Many patients who had a Eurolift, after 5 years, they are coming back now, and they are requiring TURP. So in a follow-up of the Eurolift data, if I am correct, at 5 to 7 years, 20-25% patients are requiring another procedure.
You are right, sir. I think I have done HOLEP for prostate artery embolization failures. I have done HOLEP for Eurolift failures. I have done HOLEP for ITIND failure as well as the resume failures. So this list is growing, and I feel that all these modalities are giving me more volumes.
So, Dr. Varshney, you indirectly want to say to the younger generation is, please be careful while adopting these newer techniques. They may not last.
See, newer technology
there is a
has
specific case selection.
Younger patient will like to keep his ejaculation and sexual function intact, and he is paying price for that. Many patients, when we discussed, they said, okay, if I need secondary procedure, is fine, but at least next 10 years I'll be enjoying. And after 10 years, he may not be able to enjoy, so he won't mind. So everything has got its pros and cons, and one has to see that what patient wants. And nowadays, I'm sometimes very impressed with the patient argument and what they come, what they have read, and what they want to communicate. So we have to listen to them. It's the patient who is going to suffer, it's the patient who is going to get benefit. We are here to support them with the logic, with the science, and with our skills. And so everything has got the indication.
Yes, I think this is a natural trend. Whenever a new thing comes in the market, there is always an excitement as well as a criticism. But as I mentioned, it takes time for it to find its level, where it stands. Like the people are talking about these days, stents in the prostate and the urethra. We know the history and evolution when the sachets invented the internal optical urethrotomb, and the results were presented in early 80 in a bouse. And they thought this is a panacea for all and every stricture, wherever it is, irrespective of the site length, it can be dealt and managed. And that was the message given in that conference. But it took time for it to find its precise indication where it can be used. Then came the era of the urethral stents, and that also went away with the time. And then came the era where the people really looked into to do a good urethroplasty. They're like buccal mucosal graft, snot grafts, and all those things. And things are now refined and well defined. This is how the evolution had took place.
Yeah. Hello. Now we have cut down the pneumoperitoneum. Kitna rak kar diya? Pneumoperitoneum is 8, and now you look at the fossa. It's not bleeding. So after
Very
the
good.
reconstruction, that part will also be gone. And one thing I would like to say, I hate stent because I was the one who removed most of the stent, whether memocath, and many varieties have come. And I know how the urethra was injured, and it was so difficult to remove it. Some instruments were broken, some urethra was tortured. So I hate stent. I don't think stent will have a place unless we get some absorbable stent, and that absorbable stent have some paclitaxel or some other anti-proliferative agents. So once the stent has melted out, that stricture has melted out, probably that one may have some future. Rest is all speculation. Okay, so now I'm going to do the reconstruction. Lens off karo.
Okay.
Okay.
So just one statement that I was in one of the conferences at Pune, and the way the panelists are sitting here, we had very top urologists of India who were sitting in the panel, including Dr. Mahendra Bhandari, Dr. Madhav Kamath, Dr. S.N. Wadhwa, Dr. N.P. Gupta, like that. Those were the panelists. And the question given to the panelist was, if you have 100-gram prostate, what would you like to get done? And the answer, the thing is, which is so interesting and that is very pertinent to this gathering, that all 5 top urologists of India replied 5 different modalities way back, 20 years back, for it to be done for themselves. So that is something which should be understood, because it is not only the technique or the skills, it is your perception and mindset. And when you apply to yourself, you are weighing, and that is where the whole gamut of this thing. Sir.
What I said yesterday, this is what you are confused, because at the end of it, you are not clear.
Sir, we are running 1.5 hours late, sir. We will continue with the lecture series.
I would request Dr. Vivek Saxena.
Again, excuse me, please. Just
I would
a
request Dr. Vivek Saxena, Senior Director, Interventional Radiology, Max Hospital, Saket.
I think we have to, this is our responsibility, being a panelist or a chairperson or a demonstrator, that people should go with a clarity. Our aim is not to show, I'm doing this, we have done this, this is that. No. At the end of it, what is your message? What should be done generally by a common urologist? He is sitting in a small city or in a town, what he can do, what he can expect. This is not what we are saying, we have done 1 case or 2 cases or 3 cases or 4 cases. Well, you can do wonders. What in their hand, they can commit blunder. So this is very important. The message has to be very clear.
Sir, are you hinting towards doing a live poll right now between the audience?
I think we have to give them a clear message. These are the academic exercises still in evolution. They should not go with the idea and start trying this, that these are the wonders.
So the 2 words, wonders and blunders, rhymed so beautifully. Thank you very much.
Request Dr. Vivek.
Good afternoon. I see that it's difficult to take surgeons' minds out of surgery. I will endeavor to do just that for a few minutes. So I'm here to present a slightly different perspective on how we can manage prostatic enlargement. Yeah. So We are all aware of all the modalities. We have 80% people who develop BPH, and medical therapy and surgical therapy are well documented and known to all of you. To overcome the adverse event and sexual dysfunction side effect profile associated with TURP, newer alternatives have been developed, out of which prostatic artery embolization has emerged as a promising modality. So PAE provides relief of lower urinary tract symptoms by not only reducing prostatic size, which is done much better by surgery or other methods, but it alters the morphology by affecting ischemia-induced apoptosis. Also, it reduces the conversion of testosterone to dihydrotestosterone, which enhances apoptosis. So PAE is not a quick fix solution. It is a slow motion exercise, and it causes the release of obstruction over several months. So the inclusion criteria is generally moderate to severe LUTS with IPSS more than 13 to 18 and decreased urinary flow rates or acute retention. Exclusion criteria are all of them, including malignancy, infections, detritus failure, neurogenic bladder. Clinical assessment, of course, we have to work very closely with the urologists and to optimize patient selection. In the era of Google, it is, as somebody said, a lot of patients come demanding stuff. So the most important is the IPSS score assessment, which is done, which you're all aware of. We do require imaging, which requires a multi-phase CT and a truss, and MR is optional, and in case there is any suspicious lesion, then biopsy should also be done. Of course, if uroflowmetry and PVR suggest that there is no obstruction, then we are really not in that business, because then you don't need to do anything. So the prostatic artery anatomy, actually the prostate anatomy this is the transitional zone. So the transitional zone is what everybody is concerned with in terms of benign obstruction, and that is what we intend to target with the central part of the prostatic artery. So a little bit about anatomy. It's internal iliac anatomy is the internal iliac divides into anterior and posterior branches. This is the Yamaki classification, which I'm sure you must be aware of. It basically divides internal iliac artery from the point of urology into superior gluteal, inferior gluteal, and the internal pudendal arteries. So you have the most common is the internal iliac artery divides into a superior gluteal, which is the posterior division, and the gluteal pudendal trunk. And after the second most is the IPA is separate, and the common gluteal trunk divides into superior and inferior gluteal. So the vascular supply of the prostatic gland consists of vessels that supply the central gland and the periphery. These branches may arise from a common trunk or different branches. When they arise from a common trunk, it's important to note that the prostatic artery often originates from the inferior vesical artery, and after that it supplies the inferior bladder and the seminal vesicles, and then it divides into the central and capsular divisions. So you have a central division which supplies the anterolateral pedicle. It is the prime target because that is what supplies the transitional zone. And then you have capsular division, which is from the outside. So when the prostate enlarges, the prostate artery is often tortuous, and especially it becomes kinky and corkscrew-like. So in this, this is the prostatic artery, and then this is the inferior vesicle and going into the seminal vesicles, and then this is the central branch, and this is the peripheral branch. So our aim is to only go into the central branch so that this part is taken care of. Of course, we want to avoid the seminal vesicle branch and the peripheral branch. So these are the different types of prostatic arteries. I will illustrate them. First, the type A is the type 1 prostatic artery is the one which arises from the superior vesical artery. So you have the superior vesicle, and then you have the prostatic artery coming out from here. And type 2 is when it arises from the gluteopudendal trunk, which is here. So the superior vesicle comes out here, and then the gluteoperitoneal trunk. And type 3 is where it comes from the obturator artery, which is a little lower down. And type 4 is when it comes from the internal pudendal artery. So it is important to note that the prostatic artery often has anastomosis with other pelvic arteries. So there might be, that might be why there is partial failure. So I'll skip the procedure. This is what a prostatic artery looks like on scans. And then we enter the central division, and we are supplying we are basically taking out the capsular. So this is a dyna CT that we do, so that once we reach where we want to be, if you take a dyna CT, you can see enhancement in the prostate. This is what a prostatic artery looks like, and this is going here, and this one here. If you can see, this is the typical corkscrew pattern that you get here. And this is the fine artery that's going here. This is the corkscrew, this is the prostate. So the clinical outcomes, there is a 70-90% improvement in LUTS, and the reduction is just 20 to 40%, but it does improve quality of life scores, and there is a lower rate of sexual dysfunction. However, importantly, reintervention may be needed in 10 to 20% patients. Complications are minor. Minor are post-embolization syndromes, while the major ones are fortunately quite rare, which non-target embolization, which if you are selective enough, it's not a problem. So this was, just present a few articles. This is a very recent article in 2025. They have done a case of around 1,000 patients, and they were assessing patients at 1, 3, 6, and 12 months. And this study was a retrospective study of cases done from January 2014 to 2023. Assessments were all the usual. They assessed all of these. So amongst patients with acute urinary retention, they were able to void at the first voiding trial, which was at 1 month. Of 126 patients in the retention cohort, 119, almost 94% were catheter free at 3 months follow-up. The prostatic size, of course, the median reduction is around 20 to 40, median of 32, which is significantly less than any TURP, any other urological procedure. While the median PSA reduction was about 50% from baseline, which was 65% with TURP. 65% of the patients were BPO medication free at 1 year, and the IPSS score improved significantly, almost 74% from 23 to 6. Quality of life was improved, and a Cochrane review showed improvements of both IPSS and QOL. PVR improvements was about 40 ml mean change from the baseline. This was similar to what was seen in patients undergoing any of the other procedures also. As I was saying, 94% of the patients became catheter independent, and the IIEF score, which is the erectile function score, it showed no significant difference even up to a 60-month follow-up. And what was very important was that PAE did not adversely affect sexual function. Preservation of antegrade ejaculation, erectile functions of patients at 12 months follow-up was there. There was preservation. And the median, there were some side effects, but it was very less, only 0.65%, which were, some of them were not really related to the, So there were other studies from the Asian group which also gave similar results. This I would like to say that there was a UK rope trial which said that the place of PAE in the care pathway is between that of drugs and surgery. So allowing the clinician to tailor treatments to individual patients. These are all retrospective studies which have over 10 years experience, and most of them have over 100 patients. The ones that are included have over 100 patients. So if you compare the two, the main difference is the sexual side effects, and of course the reintervention rate is slightly higher with PAE, and the sexual dysfunction is slightly lower. So current guidelines, EAU also gave a guideline in 2023 that PAE is an option for men with LUTS due to BPH who prefer a minimally invasive treatment or are not surgical candidates. Similar with AUA, which also said that should be offered in centers with expertise, especially for patients with large prostates or high surgical risk. The limitations are that it requires advanced imaging and IR expertise, vascular anatomy can be complex. So in summary, PAE is a safe, effective, minimally invasive treatment. It's especially beneficial for patients unfit or unwilling for surgery. And of course, there is a significant learning curve to PAE. Thank you.
Any questions from the floor?
Well, excellent talk. I just wanted to know, with your expertise, that how many cases, because the anatomical, these arterial variations are, as you said, very diverse.
Yeah.
So, have you ever abandoned a procedure for want of getting into the right place? And if yes, then how preoperatively you counsel your patients?
So preoperatively, we do tell them that there is a risk of failure at least on one side. It is, we generally are, at least I have done about 10 cases recently, and they are all patients who are unwilling for surgery or unfit for surgery. But once the larger the prostate volume, the easier it is to get into the prostatic artery. Yes, it is not difficult to get into the prostatic artery, it is difficult to get into the capsular, into the central division of the prostate artery. Because if we do not isolate the seminal vesicle or the inferior vesical branch, then we will have more symptoms which are the main reason why somebody is getting the prostatic artery done. So yes, we do counsel them that there might be a need for subsequent intervention.
Yes. Sir, can we offer, sir?
Yeah, hi.
Can we offer PA in the CKD patients? Like most of the elderly patients are diabetic and hypertensive with hypertensive nephropathy and with deranged kidney function test. So can we offer, or it's a contraindication?
It's not an absolute contraindication because the volumes of contrast that we use have come down over the. So in our procedure, we are using diluted contrast. We use a total of about 80 cc.
So what is the upper limit of the creatinine? In which patient you can offer PAE?
1.5.
1.5, not beyond that.
It's difficult to do beyond that because then we are able to explain the kidney risk. Or of course, if the patient on dialysis, then all that doesn't matter.
Okay, and what about the role of PA in carcinoma prostate patients?
No, we are not offering in carcinoma prostate.
So, do we have any limitations of size of prostate in such cases?
No.
We can do in any size?
Yeah. The bigger it is, the easier it is to get into it, the prostatic artery.
Thank you, sir.
Thank you.
Can we go back to Dr. Anand for a minute?
Give the voice over there.
Sir, can you explain to us what is happening? Hello?
Sir, Anand sir?
Yeah.
We are connected to your router, sir, right now. Do you have any
Yeah, I
comments?
think anteriorly I have just perforated the capsule, so I'm just putting one stitch there. I just saw that there was a, so I'm trying to close it. And now I have done trigonalization, so that means that I brought the urethra to the trigone and this bladder neck is too big. So if I try to close all around, it will be little difficult. So isko yahan kaat do jara. So what I am trying to do it is that I'll close up. Now everything is done. We just have to put a catheter. Catheter is nicely, since trigonalization is so good that the catheter just moves to the bladder, and then lose ho ja raha hai bar bar. Dekho. And then we'll close the anterior capsule, put a drain and come out.
Great, sir. Perfect job. Thank you.
So we conclude our first lecture session. Thank you, Chairperson. Thank you, speakers. So we now move to the next lecture session, where we have to focus on the prostate biopsy and diagnostic techniques. For that session, we have distinguished panel of chairpersons, Dr. Anup Gupta, Dr. Rajiv Yadav, Dr. Pankaj Panwar, Dr. Ashish Kumar, Dr. Manoj Tumawala, Dr. Nachiket Vyas. Our first speaker is Dr. Satish Ranjan. I invite you on the dais, sir, to please speak on trus probes and trus biopsy. Dr. Rajiv Kumar Yadav from Lucknow, please join the panel of chairpersons, sir. Dr. Shailendra Goyal, Dr. Wahib Zaman, Dr. Shailendra Goyal, Dr. Wahib Zaman, so please join the Wahib Zaman. Sir, please join the panel of chairpersons. Stage is yours, sir.
First, I would like to thank organizers for giving me opportunity to talk on the trus probes and trus biopsy. So I will be presenting in following orders. First, basics of trus probes, common finding in trus, and trus biopsy and systematic reporting. So transrectal ultrasonography was first attempted by Japanese urologist in 1963. And first systematic biopsy, succinct biopsy, was demonstrated by Hogg and Estamy in 1989, which is a basic of modern 12-code systematic biopsy. So principle of grayscale ultrasonography is transducers detect the reflected echoes, process it, amplify it, and suppress the background signal, and finally assigning a value which corresponds to change in tissue density, and which is a process to an image what we see on the screen. These are the indication of trus, starting with simple prostate, BPH, infertility, implant insertions, and of course in diagnosis. So before we are going for trus biopsy, we have to understand the machine first. So this is flex focus, BK flex focus. We need to understand the keys also. So what we are showing in top right upper corner is for adjustment of brightness at the different depth. This is for central key or mouse. This is for brightness of a screen. And this is for splitting of image you can have in this machine or other in any BK medicals. We can have both sagittals and axial sections on the same screen. And this is for freezing of images. So first we have to notice that brightness should be at the medium gray scale, and that gray scale should correspond to the peripheral zone of the prostate. These are the different transducers, either end fire, side firing, axial or biplanar. This is a prostate biplanar transducer from the for the flex focus. It has frequency of 5 to 10 megahertz and angle view, field angle view is 126 degree. This is a triplanar transducer for same flex focus having frequency of the 4 to 12 megahertz and angle of field view is 140 degree. If you have a higher frequency, you will have better resolution, less penetration. And this transducer we have seen yesterday while using BK500. This is these transducers having a frequency of 4 to 14 megahertz and angle of view is 180 degree. So what is biplanar? So we in biplanar transducers we can have both axial and sagittal sections at the same time. In triplanar there is a facility for see at the apex. You have to just switch the buttons here and you can have end-on view and you can take biopsy from the apex area, which is one of the hidden area. This is the needle guide for taking biopsy. What we are using is a universal needle guide. There is a two needle probes, guide probes you are seeing here. One is oblique and one is straight. One which are oblique, which is for either taking biopsy in axial or sagittal sections, which are straight, which is for in-non taking biopsy. So before inserting the rectal transducer, you have to explain about the procedure, take the consent, digital rectal examination to confirm the findings and simulate the procedures, talk with patients and distract the patient to alleviate pain. Patient must have passed stool in the morning and if there is history of constipation, then bowel preparation is required. If it is not required. For machine settings, you have to select the transducer, enter the patient details, enter the probes after covering the probes with condom and inserting jelly on the both sides. Adjust the brightness. It should be medium gray scale of normal peripheral zone. Adjust the zoom. While taking the biopsy, you have to zoom in, and while taking the volume, you should have zoom out. So reference point for judging the lesion is medium gray scale image of the peripheral zone. If some lesions is darker, it is hypo, and if it is lighter, it is hyper. So patient positions, we take biopsy in both the position, left lateral and lithotomy. In left lateral, hip and knee should be flexed and buttocks should be at the edge of the table. So this is for probe manipulation. In trans imaging, this is for left lateral position. If you have radial or biplanar probe, if you move probe C-felt, then you should have seen prostate base, seminal vesicles and a bladder neck. If you move caudally, then prostate apex and proximal urethra. In all other planes, if you angle the probe at the considering the sphincter as a fulcrum, if you move towards the scrotum, you will see more cephal image, and if you move towards the sacrum, you will have more caudal image. In sagittal imaging, patient is in left lateral position. If you have side firing or any other probes like biplanar or triplanar, if you rotate the probes clockwise, you will see left side of the prostate, and if you rotate the counter clockwise, you will see right side of the prostate. In firing, you have to move up and down. If you move the handle up, then left side of the prostate. If you handle down, right side of the prostate. This is the for systematic scanning checklist. Scan systematically in both the planes. Image should be recorded in all the areas and measure the prostate volume, ecotextures and symmetry. Note for nodules, focus on apex, base and posterolateral margins, which is most common site for prostate or hidden sites. Look for capsules, neurovascular bundles, SB and ED, and color Doppler window always not required. This is for volume measurement. You have to take the transverse diameters in axial planes and rest two diameters in sagittal planes and multiplied by 0.52, which is pi by 6, we will get the volume. Normal prostate is symmetrical. In sagittal plane, we will see bladder in other directions. Seminal vesicles is almost always visualized. And the neurovascular bundle is located at the level of the seminoprostatic angle. So in a benign nodules, we will see either heteroechoic central gland, homogeneous adenoma, or thin peripheral zone. You have to note that most of the prostate cancer is hypoechoic on truss, but all hypoechoic nodules on truss is not a CA prostate. In carcinoma prostate, you will have either hypoechoic adenoma in the peripheral zone, irregular margin, or capsular invasions. For analgesia, we'll do the pudendal unblock or prostatic block. You have to inject 5 ml of the 2% of lignocaine at the seminoprostatic angle. And we have to understand that we used 18 gauge 25 centimeter needle. You have to understand that functional length of that needle is 2.5 centimeter. So you have to keep away from the capsule, don't prick the capsule, and you have to keep away 0.5 centimeter away from capsules. That will take 1.5 centimeter prick and goes beyond the 1.5 centimeter. So don't prick the capsule. If you prick the capsule, then we will likely to get the anterior biopsy. These are different systematic biopsy, and this is a basis of modern tall core biopsy. Someone takes in this direction, but I will like to take from the right to left, from the base, mid, and apex. And I do a cognitive fusion if MRI is available also, and I take extra code if there is a suspicious lesion at the apex also. So these are the absolute contraindications, and rest things like anorectal malformations and anorectal pathology is relative. Thank you. Thank you so much, sir. Thank you. No, sir. I use both. We have, sir, triplanar, so that has both end and side.
So very nice lecture. In your practice, when you go for biopsy, what is your antibiotic prophylaxis protocol?
So we do extended prophylaxis, like starting Ciplox TZ 1 day prior BD, and then give at the day of the biopsy and 3 days also. So we'll give 5 days of antibiotics and single dose of cephalosporin at the day of the biopsy.
Any patient who's on anticoagulants, what is your protocol? Like patient is on both aspirin as well as the clopidogrel.
Clopidogrel should be stopped 5 to 7 days prior.
So you want to stop both of them, eh?
Yeah.
Okay.
Not for 75 mg aspirin, but if he's taking 150 aspirin, we have to stop.
Dr.
Satish,
Ranjan, just
very good
just,
presentation.
Just,
You
sir,
have,
sir, Dr. Anant want to just say a word,
Yeah.
and we'll just interrupt you for a moment, sir.
okay,
Sorry for. Sir, Dr. Anant, to you, sir. Can we connect
Now,
to OT?
Hello, can you hear me?
Yes, sir, we can hear you.
I just wanted to show you the bag, and this is the irrigation is going on, and you can see this is clear, and the irrigation I have slowed down, I have just little bit this much with the irrigation. Can you show it here? And we have not given any traction. So at the end of that, mild traction will be given, and this is the color. You can see the color is coming, and this is the, I can further slow down the irrigation, and you can, isko jara focus karo. You can see the irrigation, and the color is clear, and no traction is yet given. But at the end of that, we might put just little bit of traction.
So Dr. Anand sir, it was very nicely demonstrated. Dr. Anup here. Sir, for how long you keep this irrigation?
The irrigation will be as soon, probably it will be off in the evening or tomorrow morning, but it is just a precautionary. Suppose something happens, this irrigation is there, next morning patient will be moving around and can be discharged, irrigation will be closed, and catheter we usually removed on 7th day. It can be removed on 5th day, but usually patient comes back after a week and we just remove it.
Okay. So thank you very much, sir. And it was
Okay,
really very
you.
nice demonstration. Thank you so much.
Thank you.
Satish, I applaud you have precisely your time, and we are anxious as a chairperson that you are describing so much, you may not finish at time, but you have primed your presentation like this. Another thing, is there any role of betadine instillation before biopsy along with the antibiotic and local anesthesia?
Next topic is there for, okay.
Hey, Dr. Satish, you have experience with end firing probe. We use them end firing
Right
probes.
now I am using at end firing only.
End
So,
firing.
yeah, so I'm not that much comfortable with end firing, but due to the logistic reasons, I am using end firing.
But I think there is another movement required because the needle guide, it
Yeah,
comes
yes,
only
sir.
from one side. So if you don't take the left side and the right side,
Sometimes you use
you have to
without
rotate.
needle guide also,
Yeah,
so that is a.
Okay.
With the end firing, if
good
you are
afternoon,
focusing,
You have to-
then you have to focus
Yeah,
on the
yeah,
left
right.
lobe first, followed by the right lobe.
Yeah.
Otherwise, you have to change the position every time you take the biopsy.
Yeah, I think that's the rotation movement to turn also on
Yes,
the other
sir.
side.
Yeah,
Otherwise,
yes.
the needle
Right,
will not
yeah.
reach the side. Yeah, okay, thank you.
Good morning, everyone.
Thank you, sir.
Good morning, gentlemen. So we'll proceed with the next case capsule of the day. So we have a 59-year-old male patient with predominantly voiding and storage gluts. He has been on alpha blocker with dutasteride since last 2 years. He's diabetic and hypertensive. Physical examination and digital rectal examination was grossly normal. He had a grade 1 gland. On evaluation, he was found to have a 31 grams of prostate with median low projection inside the bladder with significant post-void residual volume. His urine and blood workup were normal. His PSA was 0.15. His flow rate, his maximum flow rate was 8.9 on uroflowmetry. This was the flow pattern. He had 170 cc of residual volume. These are the ultrasound images. You can see the bladder neck projecting inside the bladder, median lobe projecting inside the bladder. And the plan was made to perform resume on this patient. This case will be demonstrated by Dr. Rohit Dadwal, consultant urologist and uro-oncologist at Fortis Hospital, Mohali. Thank you, sir. Over to you, sir.
Hello, good morning and greetings from OT. This case is around 57-year-old male who is having a moderately enlarged prostate and having voiding lower urinary tract symptoms, not tolerating medications well. And he sort of wants to preserve the sexual activity as he's young. So today we are going to demonstrate a new way to treat the BPH. So this is known as resume or water vapor therapy. It's a new technique in which we use water vapors to sort of shrink the prostate and open up the channel, which will eventually subside the symptoms. So before we move on to the procedure, as it was demonstrated earlier in the morning, I'll just quickly go through the hardware first. So it contains two set of pieces. One is a disposable handheld radio frequency device, and second one is this generator. This is a permanent thing. This is a disposable one. So in the disposable one, we have 4 triggers and 4 channels. So there are 4 triggers. One white trigger is for irrigation. If you press the irrigation once, it will start the saline flow. So here I would like to tell you one thing, that saline, which is connected with this 3 liter or 1 liter of saline, whatever it is used for irrigation. For water vapor generation, we use sterile water vapors, which is inside this sterile syringe tubings. So first is this, can you focus? Yes. So first is this white button. If you press it once, it will start the irrigation. If you press it twice and keep on pressing it, it will increase the flow, which is also known as turbo mode. There is a gray button which is just behind it. If you press both white and gray buttons together, this will deliver the needle outside. So there are fine pores inside the needle at least 3 rows and 4 in each row. So these pores sort of deliver the water vapors inside the prostatic parenchyma. There is one more button here. This is used to retract the needle. Again, I'll demonstrate. If you press both the buttons together, you will deliver the needle outside. And again, if you press this button, this one, it will retract the needle. This blue button is for delivering of water vapor. So you have to keep it pressed for at least 9 seconds and it will automatically stop after 9 seconds. So each treatment is consists of 9 seconds of duration, and with each 9-second treatment, we sort of deliver around 0.42 ml of steam inside the prostatic parenchyma at 103 degree Fahrenheit. So what it does is it sort of kills it denatures the cell membrane, kills the cells instantly. Also, it denerves and also it coagulates the blood vessel. So not only it shrinks the prostate, but also halt the progression of prostate for few years or so. So before we start the procedure, we always do a cystoscopy first to see the status of the urethra, to see the status of the prostate, median lobe, bladder, and whether there is any stone inside the bladder or not. So as you can see, we are going inside. This is the external sphincter. We come on to the Veru. There is a meat in the, these are the lateral lobes, and there is a median lobe also. So bladder is not that much tuberculated, no stone, and bilateral ureteric orifices are normal. So at the end of cystoscopy, we always empty out the bladder. Why? Because there is a sensor at the tip of resume device. If the bladder fills in between the treatment, it will stop working and it will cause problem. So you sort of empty the bladder first. So after doing the cystoscopy, we attach this resume device over this scope. So as you can see, we are using Karl Stoll's 30-degree scope. There's a channel at the back of the resume device. It goes inside and it also clicks in place. So that click signifies that you are in place. Jelly. So now we are going to, that's it. Light source, देखना, light source. Light source. There is a problem in the light source. ये यहाँ पीछे से थोड़ी प्रॉब्लम है. नहीं लाइट सोर्स में लाइट नहीं आ रही. लाइट ऑन कर दो. नहीं इसकी लाइट नहीं आ रही. All right. So can we see the endoscopic view? Yeah. So if you can see, there is a metal tip at the end of the scope. If you this sort of mustard colored metal tip is there. From the tip to the proximal end, it makes around half a centimeter, 0.5 centimeter of this length. So in this way you can measure it. So the aim is to do 1 centimeter contiguous overlapping treatments. So how do you measure it? One field of view is half a centimeter, two field of views makes 1 centimeter. So you have to give treatments around 1 centimeter apart, so two field of views apart. One has to start it from around 1 centimeter distal to the bladder neck so as to preserve the ejaculatory function. We are ready to proceed? One good thing about this scope is it's very fine. It's around 18 French, so there is no problem of development of stricture or stenosis whatsoever. So I'm going inside the bladder. So while doing cystoscopy with this scope, one has to be very careful because this tip is again metallic tip. It is distal to that end of scope. So you should always remember to insert it, because if it causes bleeding, the whole purpose is lost. So the purpose is to keep the patient healthy, and there should not be any bleeding. So generally we start at the bladder neck. So what I do is generally I start measuring the length of the prostatic urethra. So I'll start from the bladder neck. This is the bladder neck, as you can all see. I'm keeping my tip at the bladder neck itself. This is one field of view, second field of view, third field of view, fourth field of view, and fifth field of view. So it is around 2.5 centimeter prostatic urethra. Then we move on to one lobe, again keeping the tip at the bladder neck, one field of view, second field of view, just distal to the second. I come on to the bladder neck, 6 o'clock position. See where is the maximum bulge. So here I can see the maximum bulge, here it is. And I sort of press against the prostatic parenchyma so as the water vapors do not leak. Keep on pressing it against it, then I start the treatment. One treatment is okay. Again I come back, 1, 2, just proximal. See where is the verumontanum is, see where is the maximum bulge, here it is. You have to be proximal to the verumontanum, sort of 0.5 centimeter, one field of view proximal to the verumontanum is okay. Again I press against the prostatic parenchyma, I deliver the water vapors. In a good injection, there should not be any water vapor leakage, and you can see the blanching of the prostatic mucosa. If you carefully see, there is a blanching of the prostatic mucosa. On one side, the treatment is done. Now we move on to the contralateral side. This is the bladder neck, one field of view, second field of view, just distal to the second. I go at 6 o'clock position, see where the maximum bulge is. Again, I press against the, don't forget to press against the prostatic parenchyma, otherwise in a supple prostate, it will cause leakage of the water vapors and eventually will lead to the failure of the therapy. Distal to the, again I see where is the maximum bulge. So there it is. Each treatment forms around 1 centimeter radius or 2 centimeter diameter lesions. So that will cause eventually cell wall death and sort of widening of the channel, which serves the purpose. So treatment on the lateral lobes is complete. Patient is having medial lobe also. It's a very good case for this demonstration. For medial lobe, as you can see, this is a medial lobe. So you go inside the inside the space between lateral lobe and medial lobe. This is the space on the left side. So again, you see where is your, you just stay 1 centimeter distal to the bladder neck, 1, 2, here. So we don't give a treatment at the medial lobe at 90 degree. I just sort of angulate my instrument to 45 degrees. You can see I'm here. I'm angulating it to 45 degrees so as to prevent the injury to the rectum. At 45 degree angulation, I insert the needle.
So, Dr. Rohit, this is Dr. Anup here. So, you're doing a wonderful job. We'll keep you watching. Meanwhile, we want to connect to Dr. Tanuj on the other OT. Okay? We'll come back to you.
All right, sir.
Okay. So can we connect to Dr. Tanuj, Paul? Dr. Tanuj?
Good morning, sir. Am I audible?
Yeah, you're audible. We can see the external view. You can show the internal view also.
Yeah, I'll just start with the scopy. Has someone presented the case already? Okay. I think they're presenting the case.
Good afternoon, gentlemen. So we'll proceed with the next case capsule of the day. Are the slides visible?
Yeah, it's visible now. You can go ahead, please.
So We have a 59-year-old male patient with the combined storage and voiding LUTs. And this patient has been on alpha blocker with dutasteride since last 6 months without any benefits. So his examination and digital electrical examination were grossly normal. He had a grade 3 prostate without any nodules. On evaluation, his prostate size came out to be 50 grams with median lobe hypertrophy. His urine culture was sterile. His PSA was 2. Rest of the investigations were grossly normal. On Euroflow, he had a peak flow rate of 6.9. This was the pattern. These are the ultrasound images. Here we can see the median lobe projecting inside the bladder lumen. And the plan was made to perform a urolift on this patient. This case will be demonstrated by Dr. Tanuj Paul Bhatia. Thank you. Over to you, sir.
Thank you for presenting the case. So I have already done a preliminary cystoscopy. We saw the urethra was fine, except a passable ring. Am I audible?
Yeah, we can see you and you're audible also.
Yes, sir. So this is we are entering the prostate. This is the verumontanum. As we go ahead, we can see the obstructing lateral lobes. Right lobe is little more enlarged than the left side. Then as we walk along the floor, and even though the ultrasound has reported a large median lobe, it's not a typical median lobe that we would expect to see in this case. Little bit of a high bladder neck, which is not bothering me much because anyways the plan is to create an anterior channel, which we do with a urolift. These are the ureteric orifices and the bladder is fairly trabeculated. Now the challenge in this case is this encroaching lateral lobes, which we will take, I think we should be able to easily take care of with the urolift implants. Now what I did initially was I measured the length of the prostatic urethra. So this is the bladder neck. I keep my finger here. There are markings over the scope. As we come back towards the veru, we come back. And this is the verumontanum. So the length is about 2 centimeters. About 2 to 2.5 centimeter. So most probably I should be able to do with 2 implants on each side. So that is the initial plan. And first we will place these implants and then we will see what next. So if I have your permission, I will go ahead with the procedure, sir.
Yeah, please go ahead. And
implant these.
And if you have a median lobe, Dr. Tanuj, then what is your strategy?
Sir, if there is a median lobe, if it's a grade 1 median lobe, then it's not big worry.
We can't hear you now. Your audio is gone. Can we connect to audio of Dr. Tanuj?
Can somebody please connect the audio?
Yeah, we can hear you now. Yes.
Yeah. So if it's a small median lobe, generally it's not of much worry, sir, because when we make this. Okay, I'll just make this point and then. So when we have a small median lobe, as we place the implants, the bladder neck gets stretched and the outlet opens. So small median lobe is not a big problem. If it's a medium to large median lobe, you have to take a call based on cystoscopy, whether you will be able to treat the median lobe or not. And many a times we are able to do what is called as a median lobe sweep. But this should be done after a certain number of cases only. It needs a little expertise to understand how a sweep is done without causing much bleeding and how much force is required to do that. I think Dr. Rohit wants to make a point, sir. I have been given the message. So
yeah, we can connect to Dr. Rohit now. I think he wants to give his final remarks. Dr. Rohit?
Is a 5 minutes procedure and we are done with the procedure. I am just demonstrating the post treatment cystoscopy. As you can see, there is no or minimum bleed. There is no bleeding whatsoever. So when you give a good treatment, there should be a blanching of the prostatic mucosa. As you can see, there is a blanching. At the end of procedure, sometimes you feel that you have done nothing, but this thing will keep on shrinking for the next 4 or 6 weeks. And in the next sort of 3-4 weeks, patient will have a good voiding. It will report a good voiding. So we have done more than 100 cases now, and in our study, what we have seen that most of the patients who have received less than 4 injection, less than 40 grams of the prostate, we keep the catheter for 1 week or so, and patients with more than 40 grams of prostate, we counsel the patient that he will require a catheter for at least for 2 weeks. If you counsel the patient beforehand, if you tell the patient that it will need 4 to 6 weeks to show its effect, then there is no problem. In our study, I did a retrospective analysis of more than 100 patients. More than 90% satisfaction rate. More than 90% of the patients, they said that yes, they will recommend this procedure to their known and loved one. The only problem with this procedure is this takes some time to show its effect. It takes around 4 weeks to completely open up the channel. And the second thing is the cost, of course. But given the minimally invasive nature and there is no bleeding, you can offer it to the young ones who want to preserve the sexual function, or the patients who are not fit for any sort of anesthesia, or patients who are at high risk. This is a boom for them. So with this, I end my session, and thank you so much for listening patiently. And I'll be happy to attend to any questions.
Dr. Rohit, there is one question. Main is bothersome catheterization for 1 to 2 weeks. That bothers the patient.
Yes.
What is your experience?
Sir, this is
how do
the
you counsel?
known. This is I tell this to the patient that this is inevitable. If you are going in for resume and want to get free of catheter early, that is not possible. If you are willing to keep it for this long, because it will be there. So this is inevitable. So if the prostate size is less than 40 cc, you'll have to be on catheter for 7 days at least. If it is more than that, 2 weeks. This is inevitable. Otherwise, most of the patients, they are not bothered with it. But some do have this irritative symptoms sort of because of the bladder irritation with the balloon. So what I do is I generally prescribe that anticholinergics along with this anti-inflammatory medications that do help.
Do you give alpha blockers as well?
Yes, sir. It's a very good question. So as I earlier mentioned, that it will take around 4 to 6 weeks. So what happens is after you inject the water vapors, there is inflammatory edema. It will first block the channel and then it will start opening up the channel. That's why the catheter has to be in place. So that's why I give anti-inflammatory for a few weeks, and after that the effect will come after 4 to 6 weeks. For that period of time, we have to sort of bridge the gap with the medications. I generally prescribe alpha blockers for at least for 6 weeks.
Thank you so much, Dr. Rohit. Now we'll move on to Dr.
Thank you, sir.
Bhatia, OT.
Am I audible, sir? Am I audible, sir?
Yes, you are audible, Dr. Tanuj.
Yeah. So 3 things we have to keep in mind while doing a urolift. First thing is, whatever rotation you want to do of the implant, it has to be inside the bladder. You cannot come into the fossa and then rotate. So whatever rotation has to be done, it has to be inside the bladder. Second, you have to be at least 1.5 centimeter from the bladder neck, because the diameter of the needle is such, if you are less than 1.5 centimeter from bladder neck, then your suture can enter the bladder and patient can develop a stone later. Third thing is that all the implants have to be above 3 and 9 o'clock position. That means in the anterior and I mean the anterolateral position of prostate. So these 3 things have to be kept in mind. For my first implant, I am rotating the device inside the bladder, and I am now exchanging my hands, and I am roughly in this position, which is about, say, a 10 o'clock position. I am coming inside the prostatic fossa. So we take 3 field of views. One field of view is 0.5 centimeter. So 0.5, 0.5, and 0.5. Roughly this, but there is a bulge below. So I would like to take this bulge up. So I go back inside. I do a little bit of sweeping in this area, and I compress. Can you appreciate the compression, sir? And I come a little further away. Okay. Now that is a compression of about 15 to 20 degrees that I have given. I am ready to fire my first implant. So when I press the blue button, first I have to unlock, sorry. I unlock it. Then when I press the blue button, my needle has gone beyond the capsule. By pressing both the buttons, the needle is retracted and we can see the suture. We give double compression and then we start walking towards the bladder neck. As we walk towards the bladder neck, we see a white line. Can you see that white line, sir?
Yes, appreciate.
Just halfway through, and then I press the blue thing and the implant is fired. Can you appreciate the placement of first implant, sir?
Yes.
Now I'll do the same thing on the opposite side. I go back into the bladder, rotate here only, and take the second implant. Thoda or little more distally we will come for the second implant. Yellow. So, which one? That is placed. I've seen. We'll check it again. Now we go again with the device. It is there. Okay. Now again we rotate inside the bladder. We take 3 field of views, 1, 2, and 3. We give a little compression. We unlock the device. We pass the needle. Little more compression. Then we press both the buttons. We can see the suture and we start walking towards the bladder neck. Wait for the white line. Not there. This is the white line. Little more. Yeah. Now we can see halfway through and we fire. So 2 implants have been placed. See, this is well within the fossa. Even this implant is within the fossa, but this is a more preferred placement of the implant, like in this on the left side. Now we come back to the Veru and we look at the anterior channel. I think I'll use the cystoscope for that to show you how the channel is opened so far. Cystoscope dijiye.
Sir, can you hear me, sir? This is Dr. Manoj. Tanuj, sir?
Yes, sir.
Sir, for small prostates, when you compress it too much, sometimes you can hit the bone and it gives a weird feeling or a typical sound. So how do we...
So in the small prostate, we should not compress too much. If you compress too much, then only you will get the bone hit. So in a small prostate, probably a 10 to 15 degree compression is enough. And just one compression is enough. So I'm coming back to the prostatic fossa. This is the Veru. I look up from here. And see, left side is nicely taken care of. I may not require another implant for left side, but right side definitely requires one more implant. So we'll take the third implant now. So for smaller prostate, avoid too much compression. For larger prostate, give little extra compression.
How do we know that...
Implant, please.
You'll have any tactile feelings, sir, when you hit a bone or something? So when we did last time, the urolift person is there next to us and is able to recognize that we hit a bone. But
I can't hear clearly.
So when we hit the bone, no, sir. So
Yes,
I personally felt that the clip is okay. But the urolift person who is there, who is helping us to do, he was telling that we hit the bone. So typically he says a sound will come.
Yeah, that sound comes and you feel it.
Yeah.
You feel a tack, you feel a typical tack, like if you have used tackers, when you place a tacker in a hernia case, similar feeling you get with when the urolift, the needle hits the bone. And there are still ways to save it, but again, that's for when you have done too many cases. So we come back to the right side, make a little anterior. 1, 2, 3, and I'll come a little beyond that 1.5 centimeter mark. I'll give a little compression here. Then unlock the device, pass the needle, press a little more compression.
Sorry, sir, we want to interrupt you. We want
Then both the buttons together.
Dr. Devanshu,
The suture has come.
present. Next.
We start walking towards the bladder neck, waiting for the white line. Oh. So we have fired the implant.
It's almost the same place where we have fired earlier.
No, it's a little behind that, sir. I'll just show you. See, now we are at the Veru and we have an anterior channel already.
Well, we are going
I'll show you with the
to
cystoscope.
invite Dr. Devanshu Bansal for the next session. We're continuing our lecture. Devanshu.
Yeah, I'll just show you with the cystoscope.
Tanu sir, we will keep you watching, so we will now proceed to our next lecture.
Yeah,
Dr.
I'm
Devanshu.
almost done in this case, I think. Let me just show you what I think might be the final view. So I'm coming back. This is the Veru. Yeah, I think after going a little in, this part of the fossa is taken care of. And I think 1 or 2 implants near the Veru will be required in this case. Regarding the 2 implants, this is one. The other one is further proximally.
One question is there, sir.
So
Will you continue?
I think I'll take this part again on right side and then on left side. You can start with the talks and I'll come back again once I'm finished.
So next on board we have Dr. Devanshu Bansal, who is going to speak on pre-biopsy preparation.
Veru के लेवल पे लगाऊंगा. सर वो पहले किया था ना.
Thank you, organizers, for this opportunity. So in this presentation, we'll be discussing a lot of questions that were in our minds after the previous talk, that how do we prepare a patient before the biopsy regarding the antibiotics, anticoagulants, and bowel preparation. So let's start with a case scenario. He's a 62-year-old man who is diabetic, hypertensive, and a history of chronic DVT in the left lower limb, with an incidentally detected PSA of 9.4 with a normal prostate on examination and a Peyer's fold lesion on the MRI. He is on Ecosprin 75 mg once daily and dabigatran once daily for his DVT, and his renal function is normal. So,
Please, you can continue.
okay. So this patient who is on Ecosprin and dabigatran, the questions that come to our mind is, what is the preoperative management that we want to do for Ecosprin? Do we need to stop it? When do we stop the dabigatran? How do we do the biopsy? We do a transperineal route or a transrectal route, and what is the antibiotic prophylaxis that we would use? So let's start with anticoagulants and antiplatelets. So antiplatelet agents are effective in the arterial circulation and are used for primary and secondary prevention of coronary artery disease, MI, TIAs, stroke, carotid artery stenosis, and peripheral vascular diseases. After coronary stent placements, the patients are placed on dual antiplatelets, and in high-risk patients with multiple cardiovascular risk factors, also antiplatelet agents are used, specifically Ecosprin. Antiplatelet agents do reduce the cardiovascular death by almost 1/6, and there is a wide variation in the practice of stopping aspirin before the procedure. So let's start with Ecosprin only, because most of the patients that we encounter are on Ecosprin because of their age and comorbidities. So there are mainly 2 meta-analyses with contrasting results that show what to do with Ecosprin. So the study by Wong et al., they studied 9 articles in a meta-analysis, and they found that on stopping Ecosprin or continuing Ecosprin, there was no difference in the risk of hematuria or incidence of hematuria after transrectal prostate biopsy and TURP. Whereas the other study, that was a meta-analysis by Karmignani et al. Of 5 studies, they found that the incidence of hematuria with continuing aspirin ranged from 20 to 65%, and without aspirin was 22 to 60%. The risk of hematuria did increase in patients who were continuing aspirin by almost 30%. So the relative risk was 1.36 with continuing aspirin versus stopping aspirin. There was no difference in the incidence of rectal bleeding and hematospermia. Now coming to hematuria, most of the patients suffered from mild self-limiting hematuria, and severe hematuria was rarely encountered whether the aspirin was continued or the aspirin was stopped. Similarly, rectal bleeding and hematospermia incidence were the same, but the duration of hematospermia was longer in patients with aspirin. So the authors concluded that aspirin did increase the risk of hematuria in patients going for TRUS biopsy, but the risk was of minor bleeding, which was self-limiting. So the guidelines suggest that those patients who have recently had a stroke, they should continue aspirin if they're undergoing a TRUS biopsy. If the patient has had a coronary artery stent placement, then a dual antiplatelet therapy is required. If it was a drug-eluting stent, then it is required for 12 months, and for a bare metal stent, it is required for 3 months. For those patients who have cardiac risk factors, a low-dose aspirin may be continued without any major bleeding risk for following a TRUS biopsy, but a minor hematuria risk is increased by aspirin, and that is usually self-limiting. But for those patients who are taking low-dose aspirin without any specific medical indications, they may discontinue the aspirin for 5 days and then be posted electively. Coming to anticoagulants, the risk of major embolism for patients with cardiac valves has reduced from 4% per 100 patient years to 1% per 100 patient years with anticoagulants, and the risk of thromboembolic complications with the risk of with discontinuation of anticoagulants is very high. The gold standard drug that has been used in anticoagulants is warfarin, and this requires bridging with heparin derivatives before a procedure. But newer anticoagulants have also now increased in use. That includes the factor 10A inhibitors like apixaban and rivaroxaban, and direct thrombin inhibitors like dabigatran, which our index patient was on. So the newer oral anticoagulants are gradually replacing the warfarin use because of their fixed dosage, no need for a blood test surveillance, and fewer drug-drug and drug-food interactions. But these drugs are not reversible, and because INR cannot be used for their surveillance, it cannot also be used for monitoring after stopping them, and they're predominantly cleared by kidneys, so if the GFR of the patient is low, then the duration of stopping these drugs increases. So usually these drugs require stopping 24 hours before the procedure. If the renal function is normal, then you can stop these drugs 24 hours before the procedure. You do not need any bridging with the heparin, and you can do the procedure, and after 12 hours of the procedure, you can restart them again. If the creatinine clearance decreases, then the duration of stopping dabigatran increases, whereas the rest of the factor 10A inhibitors can be stopped 1 day before the biopsy. So in a nutshell, the warfarin usually is stopped 3 to 5 days before the procedure to achieve a target INR of 1.5, and is bridged with low molecular weight heparin 3 days before the procedure, which is stopped 1 day before the biopsy, and then they are restarted after 24 hours of the biopsy. But the newer oral anticoagulants can simply be stopped 1 day before the biopsy without any bridging. And if the patient is very high risk, you should always get a cardiology consultation prior to the biopsy. Now coming to the issues of antibiotics and infections, there is a risk of post-procedural infection of 0.1 to 1% following a biopsy, and the risk of hospitalization of 0.6 to 4.1%, and the infection rates are rising, and the fluoroquinolone resistant rates are also rising because of the organisms like E. coli, which are the most common reasons for the post-TRUS biopsy infections. Now the historical standard for TRUS biopsy has been fluoroquinolone antibiotic prophylaxis, but now several questions come in mind. So first question is whether we should do a rectal preparation with povidone iodine before doing a TRUS biopsy. And this systematic review by Suboy et al. With 10 RCTs showed that a rectal preparation with povidone iodine did decrease the risk of overall infectious complications in patients undergoing a TRUS biopsy. It decreased the risk of fever, it decreased the risk of sepsis as well. Although the overall rates of sepsis were very low to give it a statistically significant result, but it was going towards decreasing the risk of infectious complications with rectal povidone iodine preparation. And that has been included in the guidelines now. Now the next is whether we should use empirical fluoroquinolone antibiotics or should we do a targeted prophylaxis before a TRUS biopsy. So this meta-analysis shows that they compared the patients who were having an empirical prophylaxis versus a targeted prophylaxis with a rectal swab, and they showed that a targeted prophylaxis reduces the risk of post-TRUS biopsy infections compared to empirical antibiotics. But there is still a controversy regarding this, that whether you should do empirical fluoroquinolones only in all patients or do targeted prophylaxis in all patients, because the rectal swab is usually required 2 weeks before you take up for the biopsy. It increases the cost, it needs the patient to come back and do a biopsy at a later date. So we'll talk about what to do it in the coming slides. Now compared to transperineal versus transrectal route, there are 2 meta-analyses with contrasting results. The earlier meta-analysis in 2021 favored the transperineal route of biopsy. They showed that transperineal route decreased the risk of infections compared to TRUS biopsy, but a more recent meta-analysis of 3 trials which were published in 2024 showed that although transperineal route inched towards decreasing the risk of infections, but there was no statistically significant difference in the infection rates between transperineal biopsies and the transrectal biopsy. But this comes with a caveat that those patients who are undergoing a transperineal biopsy did not have any antibiotics as well. So this has also been studied whether for transperineal route only skin preparation is enough or we need to use oral antibiotics as well. And this meta-analysis showed that actually if you do not use any antibiotics as well in a transperineal route and only use a skin preparation, that is enough. The incidence of fever, the incidence of genitourinary infections, the incidence of sepsis and readmission were all the same for following transperineal route of biopsy if the antibiotics were used or not used. So the guidelines suggest that you should always use, you should prefer the transperineal route for prostate biopsy because a decreased risk of infection and decreased use of antibiotics. If you are using a transperineal route, you should prepare the perineal skin with betadine and oral antibiotics may be omitted. If you are using a truss biopsy, then you should do rectal cleaning with povidone iodine. And targeted prophylaxis is still a matter of debate. You can make a judgment by history taking if the patient is having recent use of antibiotics, recent admissions for infection, recent fluoroquinolone use, or in your area fluoroquinolone resistance is very high, then you should prefer to go for a rectal swab and a targeted biopsy or an augmented antibiotic use with addition of aminoglycoside or cephalosporin or alternate antibiotics. If the area, in your area, the fluoroquinolone resistance levels are very low, if the patient does not have any recent history of antibiotics, then empirical fluoroquinones may be used. And a last word about bowel preparation. So bowel preparation we do for, before truss biopsy, we advise the patient either a suppository or an enema one night before the procedure. But according to studies, it does not show any difference in the risk of infections. It increases the inconvenience and increased cost and is not recommended by the guidelines. So what do we do in our index patient? In this patient, probably we will stop the ecosprin for 5 days, stop the dabigatran 1 day before the biopsy. Whether we choose a transperineal route or transrectal route will mainly depend on our expertise. If both are available, transperineal route may decrease the use of antibiotics and the risk of infection as well. If we are using a transrectal biopsy, if the patient does not have any previous antibiotic use, an empirical fluoroquinolone may be used. Otherwise, a rectal swab with targeted prophylaxis will be required in this patient. Thank you.
Thank you, Dr. Devanshu. It was a very nice summary of the topic. And I think it covers most of the commonly encountered issues when we go for biopsy. I think when you ask for the proctoglycine enema in these patients, you're right, we might not decrease the infection rates, but it definitely improves the visualization during the ultrasound. And also, artifacts will be decreased because the rectum is filled with the stools. Your procedure will be very cumbersome.
I agree, sir.
So, any other questions?
Dr. Devanshu, you said about the CKD, what the cutoff of GFR, will you decide the timing? Is there any
they have given a table, they said that if the GFR is more than 80, you can stop them 1 day prior. If it is 50 to 80, you stop the dabigatran 36 hours prior, rest of the factor 10A inhibitors can be stopped 1 day prior. And less than 30, dabigatran is not recommended at all for use. So,
okay, it's fine. About the DOAC as well, if you're saying, but our convention was to stop it 2 days before, 2 to 3 days. So, I mean, why is 24 hours? Because you consider
sorry,
as a high.
which one?
I mean, the usual, we know it is to be stopped 48 hours before. That's what we consider. You're saying 24 hours before.
Yes, for neuro oral anticoagulants, the guidelines recommend stopping it 24 hours before the biopsy.
Okay, thank you.
Dr. Devanshu, you said as far as this part is concerned, it's okay. But the problems comes after surgery, after 2 or 3 weeks. If the patient is on anticoagulants, there is usually no immediate problem.
Right.
Problems of hematuria or secondary hematuria is after 2 weeks or 3 weeks. It's not immediately. I agree with you that whether you stop or don't stop ecosprin, there is no problem as far as immediate postoperative part is concerned. But a patient who was on anticoagulants, his hematuria will remain for a longer time.
Right.
After 2 or 3 weeks. That is the issue.
Okay.
And I think about the rising resistance of bacteria here, I mean, we have a debate about transperineal and transrectal. I think it makes more sense of transperineal in terms because fluoroquinolone resistance is very high.
Yes, so the expertise of transperineal needs to be widely adopted if we are going for an antibiotic stewardship.
Okay.
Yeah, I have one comment to make about, sorry, please. I have one comment to make about transperineal and transrectal biopsies. The incidence of infection in transperineal biopsies is 10 times less. then transrectal biopsies. You know, the transperineal biopsies, the grid was developed by Ginsberg, and he did a meta-analysis and a study also about the cost implications. The incidence of urosepsis, UTI admissions and readmissions in transperineal biopsies was 0.5%, and in transrectal biopsies was 5%, 10 times less. And it was, when the cost analysis was done, then it came out to be $3.3 billion inside the US.
Right.
So, I mean, so that's why then Ginsberg, who made the Ginsberg grid for transrenal biopsies, advocated that would be saving so much of money. So I think slowly they're moving from the transrectal biopsies, because the implications of sepsis, even though in our country are not that much, but if you look inside the US and Europe, then it's billions of dollars.
Right.
So there might be a spatial now shift in the few years towards transperineal biopsies.
Right.
I just want to make a comment. Dr. Tanuj is waiting for the final picture. Please connect the OT with Dr. Tanuj.
Hello.
Thank you, Dr. Devanshu.
Dr. Tanuj, you are audible now.
Yes, sir.
So have you fired some more?
No, sir. See, we have to understand the purpose of doing a urethral lift is to create an anterior channel. Even though there is a bulge posteriorly, we need not worry about it. We have a nice anterior channel. This patient is going to void well. Of course, we'll keep him on alpha blockers and dutasteride for some time, because the best results come after 3 months. So any sort of mist we are doing, we continue the alpha blocker for some time. But what is important is not to get into the temptation to take care of this tissue, because the goal is to make an anterior channel, which we have done nicely here. I think you can appreciate the nicely open bladder neck there and the fossa.
Yeah, we
so
can
this is
see
enough.
that, yeah.
Yes, sir. We have used 5 implants in this case for about 55 cc gland. So quite okay. I think this patient will do well.
Dr. Tanuj, what is the learning curve for this procedure?
There is a little bit of technique to put these implants, sir.
Yeah.
And the company is quite supportive. They get these models on which they make you practice. They support you also for your initial cases. Maybe 1 or 2 implants they might help you with. So they help you overcome that learning curve, and it's important to have a mentor initially to understand the correct technique.
Yeah.
I would say it takes about 5 cases to understand how to do it in the best way.
Okay, 5 cases, right? Okay.
And what about, Dr. Tanuj, what about median lobe? You
Median
said
lobe?
Initially
Sir,
there was mild bulge.
In
was
the
there.
ultrasound they said, but you can see, sir, there is no median lobe. There was very minimal, and what happens is that up to a grade 1 median lobe, when we place these implants, the bladder neck gets stretched and it becomes flattened. So small median lobes, no need not worry. Large median lobe, very large, better not to do urolift. Medium size median lobe, maybe grade 2, you can do a median lobe sweep, but that also after you have done a certain number of cases, because it requires some technique. How to squeeze that fluid out of the median lobe, it takes some time to understand, sir.
One more question. Will you continue anti-inflammatory for this patient?
Sir?
Any anti-inflammatory will you give to this patient?
No, not much necessary, sir. Even we had these apprehensions, whether an implant will cause pain or anything. Implants don't cause pain or discomfort. Whatever discomfort is there is because of the catheter only if you place it. That also, most of my patients who are not on catheter, we do a catheter-free procedure. This is one procedure in which you need not, it's not absolutely necessary to place a catheter, but this is a workshop case and it's a little inflamed gland. So we will be putting in a catheter in this patient for 3 days.
Dr. Tanuj,
yes, sir.
In your experience, which is better, resume or this urolift?
Sir, in my experience, there is a different patient for resume and there is a different patient for urolift. And there is a different patient for iTind. We do all the 3 procedures. Anybody who's having persistent UTI, I would never put an implant. So that is very clear. A young patient or maybe a not so young but unmarried or desirous of child and ejaculation and who wants a guaranteed ejaculation, I would prefer a urolift. Again, median lobe has to be kept in mind. The patient is bucking.
Thank you.
So those things have to be kept in mind, and you can do a resume or a iTind before a preliminary cystoscopy. But if you are doing a urolift, it is very important to do a cystoscopy beforehand so that you can plan your case, so that you can see whether that patient is a good candidate for urolift or not. And also you can plan the number of implants, because the cost goes up with the number of implants. So you have to inform the patient beforehand that this is the cost going to come. Or if it is an insurance patient, you have to take permission for that many implants.
What is the cost of implant per implant?
Sir,
How
I
much?
think currently the MRP is around 75,000 per implant. When it came in, it was very expensive. Now at least it's in reasonable range, and I think all the three procedures, the cost comes to a similar amount to the patient.
20,000 per doctor case में से.
Is it
Sir, hospital
This is
case.
true. This is not. I'm nothing to lose. This is true. But
Sir,
leave
hospital.
aside that Tanuj.
Sir?
That Tanuj.
Yes, sir.
I have only one query in this case because you have put implants from outside and inside. Outside there is a capsule to hold on, but inside
Yes,
there is
sir.
only mucous membrane.
Yes, sir.
Mucous membrane plus prostatic BPH, benign prostate. So,
Yes,
so you tie a knot around anything, around a tree also. Agar aap, tree also. Slowly, what will happen? That thread will go inside. So is there any study where cystoscopy has been done after 3 months, after 6 months, after 1 year? Can you see the implant after 3 months or after 6
No,
months?
sir.
Or after
No, sir. It gets covered by mucosa, sir.
Yes,
A
not only
nicely placed
mucosa.
implant would,
This
yes,
will
sir.
go inside as per nature law. This will go inside and the prostate will bulge between the two implants, and slowly it will come back. So I wanted to know for how many months, 3 months, 6 months, 1 year. Just you tie a thread around a tree. Slowly that thread will disappear. Tree will grow and thread will go inside. Same way on the inside or in the urethral side, there is nothing, no capsule. It is only the mucous membrane and the prostate. So between the two implants, prostate will definitely grow and you will not be able to see the implant after 6 months or 3 months or 8 months. Then I believe same signs and symptoms will appear as far as the law of nature is concerned. Thank you.
You are right, sir. And we have to understand, and the patient has to understand that this is a bridge. MIST is a bridge between medical therapy and a formal surgery, like a ablating surgery, like a HOLEP or a TURP. So if we accept that, our patient accept that, and we quote them the data, what the data shows that this is the rate of recurrence and this is the rate of reoperation. If they accept it, only then we go ahead with these procedures.
Sir, fine. Then the time limit should also be the rate of recurrence after 3 months, rate of recurrence after 3 years, or rate of recurrence after 10 years. It's not only that patient improved 30%. 30% for how much
No,
time?
sir. No.
6 years,
Sir,
5 years?
Sir, we have data of up to 8 years till now, and 5 years, and I think there's a 13%
8 years is a
reoperation
very
rate.
good time. 8 years is
Yeah.
a very good time.
There are studies of 8 years, there are studies of 5 years, and there is a reoperation rate of about 13.4% with Eurolift. But again, then you can do another Eurolift for him, or you can always do a HOLEP or TURP, which is possible after Eurolift. So we have to understand this is a bridge. It is not a definitive procedure. It is for that patient who does not want to undergo surgery or who cannot afford to get anesthesia because of reasons like a poor EF, or I have had patient on ambulatory oxygen. No anesthesia could be given. We did Eurolift under local anesthesia and a catheter-free procedure. So patient was, so this is a bridge. Maybe if in future, if he is fit, then maybe you can do something. If he is not fit, you can again do a Eurolift if required. We don't know whether it will be required or not, but we will not know unless we start doing these procedures.
So I think what Dr. Yadav is saying is wonderful, but the question is we have to understand the natural history of the disease. The reason why I am saying so is that I often get patients, and just to quote a doctor's father who came when he was 60 years of age, and I said that, well, this whole, he fitted into a HOLEP, but somehow his father refused. And he kept on refusing. He was coming to me regularly on a follow-up, 6 months, 1 year, 2 years, 3 years. But his symptoms never became so bad that to qualify for surgery. And then he came at the age of 86 and his flow was still good. So therefore, question is that we have to understand that all these procedures are industry driven, and the natural history of disease is definitely something to be pondered about, and we don't have to offer anything and everything to every patient. We have to understand the mindset of the patient, mindset of the family, and offer them the judicious tool only when it is indicated.
Abhi connected hai.
We are running short of time. So up next we have Dr. Sridhar P from AIMS Delhi, who will be speaking on transrectal fusion biopsy.
Hello, badhiya.
Thank you, Tanu sir.
Thank you. Yesterday we saw some beautiful demonstrations of transperineal as well as transrectal fusion biopsies in the OT by our colleagues. And in this topic, I will be presenting how do I perform MRI transrectal fusion biopsy of the prostate. I hope I will be giving some insights from my perspective. Yeah, I have nothing to disclose. So before jumping into the procedure per se, why fusion biopsy? So since the introduction of dissection biopsy by Hodge et al., the TRUST 12-core standard biopsy became the standard of care. However, it is limited because of its random sampling, and it can miss some clinically significant prostate cancer lesions, especially in the anterior as well as the apical lesions. So then the MRI was incorporated into the MRI guided pathway, and MRI can detect suspected lesions, and the lesions were graded with the PIRAT scoring, which enable us to have improved in the clinically significant prostate cancer detection as well as the reduction of unnecessary biopsies. So this fusion biopsy is ideal for biopsy naive, prior negative biopsies, and also in the management of active surveillance. So these are the various platforms available in the market for the fusion biopsy. You can see the type of rigid or the elastic fusion method. The one which we use in our center is the Artemis, which have the elastic fusion method. So this is the system. It consists of a workstation with monitor where you do the fusion mapping, and on the image which on the right side shows the transducer holder and the robotic arm. It is a semi-robot arm and with a smooth movement. So coming to the workflow. So this slide demonstrates the step-by-step workflow of the transrectal fusion biopsy. The first and foremost step is the MRI acquisition. You have to review the MRI, find the suspected lesion, and mark the region of interest. Then this MRI acquisition and segmentation is done in a separate software, which is the Profuse, and once it is done, the image is exported to the Artemis machine. In that Artemis machine, one has to have a real-time TRUST acquisition, image acquisition, and it should be segmented in 2 segments. Following which, the Artemis platform enables the fusion of both the MRI model as well as the transrectal model. Then the biopsy is executed. We will see it one by one. The step 1 is the MRI acquisition and segmentation. For this, we use this Profuse software, which is given in the Artemis machine. The MRI images are uploaded, and the first segmentation is done in the T2 weighted image because it has a high resolution, and the suspicious lesion can be marked with the 2x2 slides, concurrently running the T2 weighted image as well as the diffusion weighted image. With experience, we can find the lesions. However, in difficult cases, say PIRAT 3 or so, you can take the help of a radiology colleagues. So one has to verify the adequacy of the both planes, sagittal and coronal planes, in the segmentation, because it is one of the important step in the fusion biopsy. And once it is segmented and the MRI model is exported to the Artemis machine. So in this image, you can see the yellow arrow, and you can see the yellow outline of the prostate. This is the segmentation of the prostate. And the pink line, which shows the region of interest, in this case, it is in the right side of the transition lobe. And the first image on the left side, it is a transverse image. Center one is the coronal, and the last one is the sagittal. So the step 2 is giving the periprostatic nerve block. So we use routinely a 5 ml of lignocaine injected at the mountain, eliciting the mountain triangle at the base of the prostate as well as the seminal vesicle, and it improves the patient comfort, and the VAS score is very less. So this picture depicts the installation of the periprostatic nerve block. In the right side image, you can see that nicely elicited like the fluid inside between the prostate and the rectal mucosa. Coming to the step 3, which is the TRUST acquisition and segmentation, which is done in the Artemis. The TRUFS probe is attached to the articulated robotic arm, and it is mechanically stabilized. And there is a knob which you can rotate 360 degree to acquire the truss image. Once it is registered, and it should be segmented in 2 planes manually. And with this, we can create a 3D truss model. So this is the image which shows in the articulated arm, you can see a knob. Once it is stabilized, and at the level of the mid-gland level of the prostate, you rotate slowly 360 degree. Once you start rotating, this is the image acquisition which will happen, complete 360 degree. Once it is completely rotated, it gets registered, and it will be further helpful for the segmentation. The next step is the segmentation. So this is the registered image of the prostate, and it has to be segmented as yesterday depicted by, beautifully by Dr. Amitabh. The outline is marked in the both axes, the transverse as well as the sagittal, for the segmentation of the truss model. So now we have 2 things, which is the MRA acquisition and segmentation with the ROA, and the truss model which is already segmented. The next step is to fuse both the models. So with the Artemis, we can fuse both the MRA and truss models, and the Artemis which we use is the elastic fusion. It has a compensates for the deformation. Even if the probe is slightly pressed, it automatically changes. And one has to be very careful. Always try to verify the landmarks of apex, base, urethra, and calcification if at all present. So this image is the fusion image. On the left bottom, you can see the truss image with the region of interest marked in the yellow line, yellow marks, and the corresponding MRA image is shown on the right side bottom. The above one, which is the fused model, the MRA truss fused with the region of interest as shown in the coin-like yellow lesion. The final step is the navigation and biopsy execution. We use a 18-gauge automated biopsy gun, 25 centimeter, and as per the AUO consensus, for the targeted biopsy, 2 nicely spatially distributed cores were taken routinely from our center. Apart from that, 12-core systematic biopsy. So the Artemis machine, which has a beautiful probe tracking technology, and it has the angle sensing position encoders, so that like the angle is rotated, it can be rotated left and right, moved up and down to enable all the distributions of the prostate gland. And in this image, if you can see that the lesion of targeted lesion is marked as a 13. I want the audience to note in the right side image, which is the corresponding truss real time, which is running corresponding time, and there are 3 markings which we can see. So on this, you can see this is a left lobe, this is a tracker line, and we can see the 3 markings. One is this red bow tie, this pink area, which is the region of interest, and the central red dot is the area through which the biopsy needle is going to go. And the top one, which is the distal most horizontal line, is the once you start firing, the tip will go, and that is the distal most part of the biopsy gun needle. So one has to keep the needle, biopsy needle here, and then fire. It is about 2 centimeters, it will go inside the prostate. So few tips and tricks for this MRA transrectal fusion biopsy. The main point is the segmentation accuracy. So in order to have a successful targeted biopsy, you have to verify both angles on the real-time pulse while firing. Avoid excessive probe pressure because it can cause deformation. Though the Artemis can have an elastic fusion registration, but still one has to avoid probe pressure. And always it's to recheck the segmentation element periodically in the both angles, sagittal as well as the transverse. And it is a good idea to ask the pathologist to report in core numbers from 1 to 12 and the 13 or 14 as a targeted biopsy. Always save the image for follow-up and for future reference. So I want to highlight this point to whom the fusion biopsy is not needed. Very high PSA with the over advanced disease, patient with the diffuse hard nodule patient, straight away go with the standard core biopsy with in fact a limited core biopsy. And if the Pyrat's lesion is say 1 or 2, it's a benign pathology. Patients with contraindication to MRI obviously we will not be able to, and in resource limiting settings where we could go for a standard 12 core, it is equally effective. So coming to the few slides on the Ames data, The one which is the earliest study which was published by Dr. Rohit Kaushal, we acquired this machine in 2014, and this data comes from 14 to 17. It is a single arm study. 130 men was analyzed. The overall cancer detection rate was 27%, and you can notice that targeted biopsy had a higher clinically significant prostate cancer detection. The one point of which I want to highlight is it is always accompanied with a systematic biopsy, because in this study we noticed that about 8% of significant prostate cancer was only found in the systematic course but not in the targeted course. Similarly, another 8.3% were found only detected via the targeted biopsy course, not in the systematic. This shows the added value of systematic biopsy in combination with the targeted biopsy. And also, the Gleason score was upgraded in 26.7%, meaning in systematic biopsy, it had a 3+3, and in few patients, it has upgraded to 3+4 also in almost 26.7%. Thank you.
Thank you, Dr. Sridhar. Very nicely summarized. So, in your institute, you're doing for all the patients, except when you summarized whom not to do. Otherwise, in all routine patients, you're doing the fusion biopsy?
Yes, sir. In the gray zone with a normal DRE, yes.
Any questions from the audience?
Sir, can we have the questions after the debate, because the topic is the same? We can have the question with Dr. Amitabh as well as the Dr. Sridhar, both.
So we conclude this session. Thank you, chairpersons. I would request Dr. Pankaj Panwar, Dr. Anup Gupta, and Dr. Manoj Tumawala to please be on the stage for the next session. Our next chairpersons would be Dr. Anand Kumar, Dr. Vikas Singh, Dr. Swapnil Kushwaha, Dr. Pankaj Panwar, Dr. Anup Gupta, and Dr. Manoj Tumawala. Next, we have a debate, which is a high-energy session. The debate is on transrectal versus transperineal MRI fusion prostate biopsy. Dr. Sridhar P. will be speaking in favor of transrectal, and Dr. Amitabh Singh will be arguing for transperineal biopsy. Dr. Sridhar P.
Good afternoon. At the outset, I would like to thank the team Max Saket, Professor Anand sir, and Dr. Rohit Kaushal and Dr. Pragnesh especially for giving this wonderful opportunity. So we have a debate on the topic of transrectal versus transperineal in fusion biopsy technique of the prostate. So I have nothing to disclose. So before jumping into the debate per se, I would like to give a few glimpses about the evolution of the prostate biopsies. So in the start of the early 1920s, people used to do an open prostate biopsy. Put an incision and they go inside, palpate it, the prostate, and if at all there is a lesion, they would do a perineal prostatectomy. And it was by Ferguson et al. In 1930, the first transperineal biopsy was described, and the first transrectal biopsy, finger guided, was described by Astraldi in 1937. And it was in 1950s to 1970 where the more and more imaging technologies developed, and the first truss was introduced by Takahashi in Japan. However, it was not a highly resolution, was not widely used clinically. And in 1974, Watanabe, he described a clinically useful truss, which is the main base for the upcoming era. Then was the 1980s, where the modern truss-guided biopsies started developing. It is all because of the landmark study published by Hodge et al., who described a section biopsy of the prostate, and later on which there are more modifications, extended biopsies, saturation biopsies, and ultimately the 12-core biopsy became the standard of care. And the 2000 was the era of MRI transfusion biopsy, and recently there is a talk that is a resurgence of the transperineal biopsy. The proponent says there is a concern about the infection and it is very difficult to reach the hard to reach zone biopsy with transrectal. So this image, which is the Watanabe chair, patient used to sit on the earliest truss image in 1974. Patient used to sit on the chair, and the prostate can be imaged as shown on the right side picture. So transrectal versus transperineal is actually not a recent debate topic. If you see, the proponents, they started early to do with the transperineal biopsy, and they found it's cumbersome, painful, and mostly it required a GA. And ever since the introduction of the sectant biopsy, the truss became the global standard. However, recently people started having fluorocoronal residence and sepsis, which sparked the resurgence of transperineal biopsy. So I will consider it's a very old question, re-emerging with modern tools and changing infection dynamics. So in this debate, I will be talking in favor of MRI truss transrectal fusion biopsy. So yeah, it has been a successful run. Why? It is the most validated biopsy technique in the last decades, more than 50 years. And accuracy, it has a higher clinically significant prostate cancer detection as compared to the standard truss, as shown in PROMISE study, precision trials, and MRI first trials. And it decreases the unnecessary biopsy, prevents overtreatment, and it is widely performed across Europe, USA, and Asia. And coming to the practicality, it is very easy, OPD setting, perform under local anesthesia, shorter learning curve, and the residents can be easily trained and make them to do a fusion biopsy. So I would like to say that truss fusion is the original workhouse, and based on which the transfusion fusion is still trying to catch up. So why there is a pressure for a transperineal fusion biopsy? So the proponent says there is an infections concerns, rising antibiotic resistance, and the fear for post-transrectal sepsis. And the TP is frequently marketed as a zero sepsis risk. And there is industrial push. The device companies, especially the Precision Point, are promoting the freehand TP platforms, which can be evident in the movement of Trexit 2020 in UK. If you can see, the Precision Point cleared the FDA in 2016, and within 2 years, 2018, the UK started moving towards the transperineal, excluding the transrectal. Based on this, all the guidelines, majority of the European guidelines and the NHS are leaning towards the transperineal, influencing the practicing persons. And yes, the recent TP trials are getting visibility and it's creating a more hype. So I feel there is a push for the TP is more about perception and policy than a proven superiority. Is it real? Let's try to decipher the latest evidences, high quality RCT, which was published in the last year. So for this, before starting this, like majority of the trials, majority of the studies, like the TP is having a lower incidence of infectious risk, is based upon the systematic analysis and systematic review and meta-analysis from the cohort studies. And these studies are published very new. First 3 trials came in last year, and the recent one, the Translate trial, which is exclusive from the UK, is published 3 months back. So first, taking the primary outcome, say cancer detection rate per se, what this trial says. The PROBE trial and the PREVENT trial are from the US, John Hopkins and MSKCC. They tried to use both biopsy naive and repeat biopsy and biopsy naive patients in the PREVENT trial. They found there is no difference between the transrectal versus transperineal fusion biopsy in terms of clinically significant prostate cancer detection. The France trial, which is the PERFECT trial, who randomized a biopsy naive MRI positive lesion, they also found that the overall clinical significant cancer detection rate there is no difference. Interestingly, they found that the transrectal, for obvious reason, detected more posterior lesion as compared to the anterior lesion. However, for the anterior lesion comparison, though the TP detected more, it was not statistically significant. In contrast to the above 3 trials, the latest trial, which is that Translate trial published 3 months back, exclusively from the London, they have shown that TP biopsy detected 6% more clinically significant prostate cancer than the transrectal. Coming to the second important outcome analysis, that is the post-biopsy infectious complication rate. So all these trials says there is no major difference between these two groups. So what the guidelines say about TP versus TR? The EAU, American and the NCCN guidelines, EAU prefers TP, quoting the systematic review and meta-analysis of the previously published cohort studies. They prefer TP, and which is evident in their practice as well. Though they have not mentioned a satisfactory answer in the infectious rate as well as detection rate. Whereas in the AUA and NCCN guidelines, they are very neutral. One can prefer either transrectal or transvaginal fusion biopsy. So why I am in favor of transrectal? Because it is effective, comparable detection rate. 3 out of the 4 recent good quality studies have shown there is no difference in the clinically significant prostate cancer detection. It is established, time tested, more than 50 years in the market. It is efficient in the sense it is a OPD procedure done locally, easily reproducible, as well as trainable to the residents. And finally, it is safe. Infectious rates are rare. So I conclude, transrectal fusion biopsy is effective, established, and efficient. It was, it is, and it will be there. Thank you.
Good morning, everyone. Thanks to Anand sir, Pragnesh, and Rohit for giving this opportunity to speak, especially in favor of transperineal biopsy. I personally feel the transperineal is the future one. So half of my job has been done by Nachiket sir and Devanshu, because they have explained why transperineal is better than a transrectal biopsy. But I'll be just going in more detail. So if we are doing transrectal biopsy, then I have to remind myself that I am going through the rectum, which is full of fecal matter, full of bacteria, more than 10 to power 11 colony forming unit per gram of stool. And every time when I'm pushing the needle, I'm pushing the bacteria into the blood and the prostate, causing to the urinary tract infection. Even the nature has realized this fact. Initially, he made cloaca, where all the tract is coming along, but lately he realized, the nature realized, and he separated actually from the urogenital tract from the alimentary tract. But we are not doing the same thing. So this is actually a retrospective study from 84 international studies. They try to evaluate the incidence of symptomatic UTI, febrile UTI, and hospitalization. And the incidence is as follows: 5.2%, 3.5%, and hospitalization incidence is 3.1%. So this meta-analysis tried to evaluate the difference between risk of infection between the TR and TP, and the TR was almost having 6 times higher infection rate compared to the TP biopsies. UK experience, definitely almost 60% of biopsy in UK, they are being done with transperineal, and they have reported almost 0.1 to 0.2% of infection rate in their case series. Antibiotic resistance is a very important aspect. Leoflox resistance is almost 15 to 20% in Western world, and I think it is more than this in our country. We are experiencing a lot of antibiotic resistance, so we have to be careful while choosing the route of biopsy, whether it is TP or TR. I think we have to move towards this TP. Now, coming to the detection rate. So this is a retrospective study, very good retrospective study, where the author did a whole mount specimen analysis, and they tried to evaluate the yield of transperineal and transrectal biopsy. And they found that TP biopsy detect more anterior lesion, it detects more smaller lesion, and it detects the lesion which are more limited, actually more initial stages like T1C or T2 diseases. So this is a, you can say, propensity match score, where almost 4,000 patients were included from 15 European centers, and again, TP biopsy had almost more than 5% detection yield compared to the TR. And this was probably the first randomized trial for the TP compared to the TR, where the same patient underwent TP biopsy and TR biopsy. And again, it showed that TP detection yield was much higher compared to the TR biopsy, almost up to the 15%, whether it was clinically significant prostate cancer or whether it was overall prostate cancer. So hence, the guidelines, EAU guidelines says that TP biopsy should be your first choice. But as Sridhar told, these 3 trials, Prevent, Perfect, Pro-PC, they showed there is no significant difference. So you just see the numbers, don't see the p-value, and you just see the protocol, what they followed. Prevent followed this culture-guided anti-prophylaxis, bacterial prophylaxis, but still they got 4 patient sepsis, whereas in TP biopsy they did not have any sepsis. Even though the patient had only povidone iodine paint or chlorhexidine paint in the perineum, that's it, without any antibiotic. Whereas Pro-PC, still they had more numbers of the infection with TR biopsy. Perfect, they had more number of the infection rate compared to the TP biopsy. And you have to emphasize on this fact that all these TR biopsy, they had either augmented prophylaxis or they had culture-based antibiotic. Whereas the TP biopsy group, they had either single dose of antibiotic along with skin preparation, that's it. Now coming to the cancer detection rate. So you may see the difference in favor of TP biopsy, although it is not clinically significant, but there are caveats with all these randomized trial also. So I'll be coming one by one. Pro-PC admitted that their investigators, they are not very well experienced with the TP biopsy. So that might be the reason why they are not picking more number of clinically significant prostate cancer with the TP biopsy. Prevent trial had primary outcome of infection rate. So having cancer detection yield was the secondary outcome. So the number of patient calculated depending on the number of outcome of infection rate, not for the clinically significant prostate cancer. And if you'll see the perfect trial, the number of patients were only 270 patients. That is very underpowered study to detect any clinically significant outcome in terms of cancer yield. So this is the caveat with all these randomized trial. And Pro-PC was only single institutional study. Whereas this Translate study, it tried to actually accommodate more than 10 centers across the UK just to have a different heterogeneous population, different investigators with different kind of experience, and it is still again showed that there is a definite advantage with the TP biopsy in terms of detection yield, and that is more than 5%. If you'll come to the economical and healthcare impact, as Nachikesh sir has already mentioned that it saves a lot of huge cost by preventing the infection, readmission, rehospitalization, admission to the ICU care, giving extended antibiotic prophylaxis. Now there are certain advantages of TP biopsy also, because now we are detecting cancer at earlier stages because of the fusion biopsy, so option of giving focal therapy is coming up. Now we are having cryotherapy, laser ablation, HIFU. So if we are doing transperineal biopsy, so by doing modified Ginsburg mapping, you get a better idea like how can you focally ablate the prostate. Whereas in transrectal biopsy, you are seeing the prostate in a very angular view, so you don't have that actually 3D mapping of the prostate. Just like you make a grid for the brachytherapy seed placement. So when you see the prostate in down from the apex to base, you can ablate that lesion very confidently. Again, so I would just argue with, just advise you everyone, so don't be a buffalo who likes always to be in mud. Try to always be a swan, white, clean, without any dirt. So that's that I would like to end my talk. Thank you.
So thank you, Dr. Sridhar, Dr. Amitabh. Both have put their point of view in a very correct manner with all level of evidences. So we have rebuttal also? Okay, so we will have rebuttal and then we'll have the audience poll.
Transrectal is also called transfecal route.
That can be a synonym, sir, yeah. Thanks, Dr. Amitabh, sir. Okay. Coming to the anterior lesion. So I feel it's a myth. Only transperineal can reach the anterior lesions. But in reality, the needle trajectory adjustment in transrectal can significantly improve the detection of anterior tumors as well. And it is evident in that you can see in the perfect trial also, the clinical significant detection rate of for the anterior tumors is not significant. So I want to take this example which was recently done, this biopsy. One can see that the region of interest in the anterior zone, anterior muscular stoma on this. This is the transrectal image as well as the corresponding MRI fusion biopsy. So the way how to tackle this is like to introduce this needle further here, keep that, I told in the last the lecture where the bow tie, the red tie, the point of firing, keep this at this level and start firing. One can reach the anterior zone as well. So Dr. Amitabh, I think anterior tumors aren't a locked dose. A simple trajectory adjustment, or you can call it as a desi jugaad in Hindi, with which the transrectal opens them too. Coming to the second point, which is the infectious or urosepsis rate. So it's a myth that transrectal has a higher infectious complication, and if it is in reality, that infection risk alone decided the fate of these techniques, I hope this transrectal bias would have been there for more than 50 years. So the evidence says the risk is rare, manageable, and outweighed by the practicality. So Dr. Amitabh, we don't ban flying because of the simple turbulence we used to have. Likewise, we don't abandon transrectal for an occasional infection. Coming to the last but not the least, transrectal biopsies, they are like easy, OPD basis, faster, under local anesthesia, easily reproducible and easily trainable. Whereas transperineal biopsy requires, majority of times requires a GA, requires over and need a stepper, extra manpower and resources. Also, in a patient with a high PSA and a hard prostate, it is pragmatic to do a transrectal, it is a limited core rather than to go for a transperineal biopsy. Last but not least, to conclude, transrectal biopsy is like Sachin, it's classic, dependable and time tested, whereas TP biopsy is like Virat, modern, aggressive, but still he is compared to the Sachin. So legends set the standard, successor only try to match it. So TR is not outdated. I feel it is the Sachin of the prostate biopsy. Thank you.
So I did not make slide for the rebuttal, but I want to correct Sridhar. If you'll check the this score rate of Virat Kohli, he has excellent rate for the second inning. So if he is chasing, if you want anybody who want to chase, actually, so he is the Virat Kohli, not Sachin Tendulkar. Sachin Tendulkar, actually, he did well for the first inning, not for the second inning. So so there are two very important points. One is pain, and another is the requirement of general anesthesia. So in this prevent trial, actually, so they try to analyze the pain score, and it was higher in TP biopsy, but it was very marginal high. So it was high just by 0.6 score, and that gone significantly lower down within 1 week. Another point is requirement of general anesthesia. So I can tell you, in our institute, now we are doing almost 40 to 50% biopsy under local anesthesia. So there is a definite protocol. When we bought this machine, this focal therapy HIFU machine from Sonablate, we went to Imperial College, London. So Dr. Hasim has developed that protocol to TP biopsy for local anesthesia, and their sisters are doing TP biopsy under local anesthesia. So what they do, they apply this prilocaine gel over the perineum skin for 1 hour. They keep it pasted. So there is a patch actually. So you just paste it. So it just numb the skin. Then you infiltrate local at the skin level, and you infiltrate the muscular. You just make a combination of 0.5 bupivacaine and 1% lidocaine, and you just inject almost 10 ml or 15 ml on both sides, right side and left side, and patient is perfectly fine. You can do almost 12 core, 15 core under the local anesthesia. Patient does not complain anything. Another is a very important thing for, you can say, anterior lesion, you told me. So I have done TR MR fusion biopsy for almost 9 years with the same machine, Egan machine. So I agree, the lesion, if is at anterior aspect of the base of the prostate, you can target it. But if it is at the mid gland, or if it is at the apex of the prostate, then with TR transrectal probe, it becomes very difficult, because what happens when you move, when you try to reach up to the apex, what happens most of the time, that transrectal probe, it comes to the anus. So it doesn't rest into the rectum. It comes up to the anus, and then you poke the needle, it becomes so painful for the patient, because now the needle is going through the skin of the anus. And sometimes what I have seen, the probe comes out through the rectum, if the lesion is especially at the anterior aspect of the mid part of the gland or at the apex. So that's how, if you are doing TP biopsy and the lesion is at the anterior aspect of the mid gland and the apex, it is very easily targetable, and you can be 100% confident that you are not missing the lesion. So with that, I would rest this case. So I think that TP biopsy is the future. More and more centers are going to purchase and they are going to learn how to do TP biopsy. I can tell with my personal experience, I don't know how many of you are reporting the vasovagal attacks after getting the TR biopsy. I did TR biopsy at my father. I kept him for almost 2 hours in my hospital. I asked him whether he is fine or not. He didn't have any complaint. I sent him to my home. And when he reached home, he just fell down because of the vasovagal attack. And this is a very repeated complaint, vasovagal attack after getting TR biopsies. But I haven't seen any vasovagal attack with the TP biopsy. So these are my personal experience. With TP biopsy, I am even detecting 5 mm lesion, which I could not do with the TR biopsies. So these are my real experience. These are not in the literature. So that's why I am convinced, because I have been doing TR biopsy, I am doing TP biopsy, so I am seeing the difference between TR biopsy and TP biopsy. So these are just enough points to convince you whether TP biopsy is good enough or not. But I agree, TP biopsy is not feasible in every center, so we should not we should not forget how to do TR biopsy. But I think TP biopsy is the future. Thank you.
Okay, thank you. So we'll have some final comment from Dr. Anand Kumar, sir.
Yeah, transrectal biopsy we have been doing for long, and post-op fever, some hematuria, some rectal bleeding is not uncommon, and readmission because of the fever, even though we give 1 day before antibiotics, we give Ciplox TZ to all our patients, but invariably some of the patients get, and some are readmitted, and then they stay for 2-3 days till their infection is taken care of. And rarely somebody can have septicemia also and require intensive treatment. So that transfecal route is associated with infection. And the problem is nowadays we have so much of bacterial resistance, and that can cause problem. Cleaning the betadine enema and cleaning the rectum with the betadine makes lot of difference, and that's what is being followed more often, and that helps a lot. But it is associated with fever, and that is, at least most of us have this experience. Transperineal is not associated with this kind of problem. And second thing is, we have also noticed we get a lot of patients from international. If you done then the biopsy, and usually after a transfecal route, it is recommended that you should wait at least for 4 weeks and then do the surgery, because whatever infection has gone is subsides. But after transperineal route, you can operate within a week if required. So there is some advantage, but transperineal route is more cumbersome, and maybe the people have not learned it. And some of the device like we have often require general anesthesia, but freehand transperineal route can be done without general anesthesia.
I think Dr. Anand Kumar sir has said the 2 things which always goes in against TP in people's mind, as Dr. Amitabh also said. One is people say it requires GA often, but now we know it can be done at a local. And second, of course, we think it is more painful as compared to the, but I think now let's have a show of hand. How many of us we are doing transperineal in the audience? Can raise hands? Okay, so if given a choice between TR and TP, how many would like to do TR? Can have a raise of hands. And how many will have TP? So I think this is not a debate. Yeah, that's what I'm saying. It's not a debate. We should all learn TP, I think. That's a way to go forward. And as the time will improve, it will become more and more amenable to all other patients. And I think both are going to coexist. It's not that TP will replace TR. Both are going to coexist. This is what we feel.
But in England, transrectal biopsy has been stopped, and many European countries are not doing it. America is still, both are being done, but TP is more commonly done than the transrectal biopsy. Australia also, they stopped doing transrectal biopsy.
So, We are now left with the last surgery of today's live operative session. ITIND will be performed by Dr. Jha, so the OT is going to take some time, 10 to 15 minutes. In the meantime, we are going to have 2 industry-sponsored talks. I would invite Dr. Ashish Saini to please speak on anatomical endoscopic enucleation of prostate using STFL. 10 minutes लगेंगे, 10 minutes.
I'd like to thank Professor Anand Kumar sir, Pragnesh and Rohit for this opportunity. So we'll be talking on anatomical endoscopic enucleation of prostate using the TFL, the way forward. And in AEP, what do you need in your laser? You need a laser which has a better tissue ablation, lower energy, better hemostasis, has a shorter learning curve, it is affordable and it is durable. And so is TFL better in tissue ablation? So looking into the dynamics of laser, a holmium laser and TFL, they are both highly absorbed by water. And the absorption coefficient of holmium is 31.8 centimeter versus it is 129.2 centimeter in thulium with a wavelength of 1940 nanometers. So the TFL optical penetration depth is 4 times less than that of holmium laser. Because of that, basically an optical penetration depth is the depth at which the intensity of the radiation inside the material fall by almost 37%. So the TFL always requires a lesser energy. So if you look at 0.314%, it is 37% of the energy is still there with holmium versus it is just 1.7% with TFL. So TFL pulse almost vanishes at 1 millimeter with an undetectable initial intensity of around 0.0024%. So that is important, that it requires lesser energy and it is able to create that vapor channel at an initial lesser threshold. Is a TFL easy to maintain? So important is affordability. And if you are setting up your own center, if you are in a corporate, you can buy anything, but if you are having your own center, then you need something which is having lesser energy, is smaller in size, and is able to, as a plug and play model. So we all know it's a plug and play model. It is a device which is lesser in weight, and you can easily carry it also. The cooling system is also an issue with the holmium, where the chillers may be an issue. There is a lot of noise because of the chiller, while the TFL has a fan ventilation. So it is something which is a better machine looking at the dynamics. So the cost saving is sensible spending, and we can save on this machine. I have this machine for almost 5-6 years now, hardly any maintenance is required. So is TFL better in hemostasis? So this is a patient where we are doing at 35 watts, and one can see that there is hardly any bleeding. Yesterday we got a case after 12-core biopsy was done, and I think if there was a holmium, it would have been difficult to complete the procedure. So if you follow the landmarks, you will be able to, so this is a patient who was on ecosprin, and then we were able to do the procedure and with both the ecosprin and ticlopidine. Is TFL faster than holmium? So there is an improvement around 10 to 15 minutes, that's the data. It is faster and quicker to learn enucleation using a thulium fiber enucleation. Can it be done in a larger prostate? Yes, it can be done in almost, this is a study where it was done in more than 80 grams, and there were for joint BPHs more than 200 gram also, TFL can be done. Is it easier to learn than holmium? This is the data where they say that a HOLEB may require almost 50 procedures, and that may be a very big block for anybody who wants to learn HOLEB, while it is 8 to 16 cases for a TFL. Is it better in preserving erection? Yes, because we are using lesser energy, there is a better hemostasis, the neurovascular bundles may be less in damage because of the thulium. And since it has a shallow laser penetration depth, that's the reason that there will be a better improvement in IEF score. This is one of the study where they have done into how it works and what was the impact on the erectile function. So the operation theatre noise, as we said, that it is very less with holmium. I think this ad will surmise.
ये नहीं, वो निर्मा सुपर नीली डिटर्जेंट टिकिया।
लेकिन आप तो वो हमेशा महंगी वाली टिकिया
लेती थी। जब वही महंगे दामों वाली क्वालिटी, वही सफेदी, वही झाग कम दामों में मिले, तो कोई ये क्यों ले? वो न ले।
मान गए।
किसे?
आपकी पारखी न।
So this is how you, what you will choose. You will choose something which is cheaper, does the same job, and you are able to maintain that for a long time. So I think Conclave is a clear winner when it looks into a better tissue ablation, lower energy, and a better hemostasis. And for people who want to learn enucleation and they say that enucleation is difficult, this is the picture when I went for this. I trained for it for 1 year. Almost everybody said that you will not be able to complete this grueling ultracycling event, but I think you just follow the process. The outcomes are always overrated. If you work, you will be able to achieve anything. Thank you. Any questions we'll be able to answer.
Sir, as you said, you were doing Conclave with 35 watt energy. So they have got a 35 watt machine also, which is slightly less expensive. Is it possible to do Conclave with the...
Yes, you can do that. In a larger gland, you may need 45 watts, but with 35 watt, you can do it. We have even demonstrated it in 30 watts. So there was a conference in South and people said that we have a 35 watt machine, so we did it in 30 watt also.
And one of the benefit of Conclave machine is that it is small and probably portable also.
Yes.
Has anyone got any experience of portability? Are they using it taking it to the different centers?
I will give you an example. I was operating on a case in Apollo. They got a machine from a vendor. The machine fell from the trolley, the entire laser machine. And I was like, what is going to happen? They were able to repair the machine after 1 month and it was still working. It is not possible with holmium. You cannot even take the holmium machine from one theater to another if there is a stepper. So I think it is a durable, it's a Russian machine, so I think it's very durable.
And does it have any kind of cooling problem? Because one of the times I have seen that
actually
the Conclave machines stops working for some time, you decrease the OT temperature and then restarts.
I have found that if it is very cold, then you need to warm up the OT. It doesn't happen nowadays with the modular OTs because it is temperature controlled. So
nice to explain. Thank you, sir.
Thank you.
I will be speaking next on the hemostats and the energy devices. This is a sponsored talk by Ethicon. Hemostasis in the robotic urologic surgery. Types of bleeding. There are different types of the bleeding, capillary, venous, and arterial that we used to read during our undergraduation. So the arterial is a bright red blood that all of us know. So 5 universal bleeding situations are there: continuous oozing, difficult to access, potential rebleeding risk, problematic, high pressure vessel bleeding. All sorts of the bleeding can frighten a surgeon until and unless we have got the guts to control the bleeding, depending on the expertise level. So, as we all of us are using Surgicel, which is very popular hemostat, it is being manufactured by J&J, manufactured from the cellulose obtained from the wood pulp, and in combination with rayon, it is regenerated and oxidized to form the original Surgicel, which is available in the market. So there are multiple variants which are available: Surgicel Nunit and Surgicel Fibrillar, which is processed after the carding, and Surgicel Snow. The Surgicel is having a unique and reproducible carboxyl content, indicates that it is having high quality manufacturing process and signals its reliably reproducible performance. The content is almost 19.5%, which is highest among all its counterparts. One of the key mechanisms of action for this hemostat is mechanical. If the product cannot be placed correctly or stay in place, it doesn't provide a good base for the platelet aggregation. If the material is harder, it will not conform to the damaged tissue as well. If the material breaks down when it is wet, it will not provide a stable matrix for the platelets. Improved mechanical action implies in the shorter times to hemostasis. The Surgicel family, it is a plant-based product, you can say organic in the Desi language. It is having a bactericidal advantage. It coagulates even when saturated with the blood, and cord-free suction can be used on the Surgicel that we usually see during our robotic partial nephrectomies and other procedures. Multiple forms are available that we have already discussed. So there is a proven bactericidal effect against MRSA, Pseudomonas aeruginosa, vancomycin-resistant Enterococcus, and E. coli. The effect of the topical hemostatic agents on the coagulation cascade, the oxidized regenerated cellulose, that Surgicel, it usually acts by promoting the vasoconstriction. The gelatin with thrombin, it helps us in getting a fibrin clot earlier. So these are the multiple hemostates which are available. Now coming to the energy devices, endocutters and GST reloads. The advanced staple line security requires a device which is designed and engineered to support key surgeon needs. So first is two-stage compression, and simultaneously it should control the tissue movement as well. So which is possible with this Echelon and GST design launched by J&J. So there are multiple cartridges which are available depending on the size, whichever is the requirement, ranging from the white to the black. The black is the largest cartridge which is available. The two-stage compression which is offered by J&J delivers more uniform compression, Echelon, and the other competitors which are available in the market, you can see it is very vague and it doesn't provide a uniform compression. The powered vascular stapler by J&J is, the tip is more narrower and blunt tip is there. The shaft is thinner, which offers the greatest angle of reach in the tight intercostal spaces. So it enables the most precise placement on the fragile vessels. It has enhanced stability. Thank you. So we will now connect to the OT. Dr. Jha is ready with us. He's going to demonstrate ITI-ND. Can we have the case presentation, Dr. Umar? This is the last surgery of today's live operative session. Are we connected to the OT? Jha sir? Dr. Jha? Are you able to listen?
Yes, I am able to listen. I'm just waiting for the presenter. Basically, this is a 57-year-old male. I have a brief height. Umar is just, yeah.
Dr. Umar.
Good afternoon, gentlemen. So we'll proceed with the final case presentation of the day. So he's a 57-year-old male with mixed lower urinary tract symptoms since last 5 years. He's been on alpha blockers since last 5 years, and the dose has been increased to twice daily since last 1 month. He's in view of storage LUTs. He was also started on Mirago since last 1 month. He's a hypertensive male. Local examination was grossly normal. However, notably he had phimosis, for which circumcision has just been done. He had grade 2 prostate, which was non-nodular and non-tender. On ultrasound, his prostate size was 31 grams. His urine and blood workup was normal. PSA was 0.31. On Euroflow, he had a maximal flow rate of 8. This was the pattern. These are the ultrasound images. So the plan has been made to perform circumcision with iTind placement. This case will be demonstrated by Dr. M.S. Jha, Director of Urology and Kidney Transplantation, Max Hospital, Saket. Thank you, gentlemen.
Okay, so good afternoon, everyone. Can you hear me?
Yeah, we could hear you. You have we
yeah,
could
so
hear
I'm-
you.
It's
So
okay,
you have
sit
done
down,
the
sir.
circumcision is done?
Yeah, circumcision is done, sir.
Okay.
Now we are just doing the cystoscopy. And I am using a 19 French sheath because this is the minimum size required for the I-10 device to be placed through the sheath. We cannot use a 17 French sheath to place the I-10. And so once I have entered the bladder, I have just see this is a high bladder neck, and the lateral lobes are not exactly kissing. So basically it's a problem of a high bladder neck.
It's a
So
good
this
case
is
for the
a
I-10.
a good case for I-10, and rough estimate of the distance from the viru to the bladder neck. The bladder is mildly trabeculated. So I'm just filling up the bladder, and the I-10 device can be deployed more easily in a filled up bladder. So now I'll remove the scope and leave the sheath inside. Isko aur bhar do. Now if you can have the external view, do we have the external view? Can you see this I-10 device?
Yes, we could see the device.
So this will be placed through the sheath of the 19 French scope, and I am just pushing the device. Once it reaches, I am keeping the blue line on the top. So that gives an idea that the anchor would rest at the base. So as soon as I enter the bladder, I got a giveaway feel, and after that, I'll remove the anchor and leave the device in. Now I'll be taking out my sheath and going by the side of the I-10 to position the इसके बेस वाली चीज को बोलते क्या है 17 की दे दे शीट अच्छा 17 so now I am going in with a 17 French sheet because the device is around 5 French in size. I don't want to traumatize the urethra much, and a 17 French sheet is good enough to do the job. So we can see the blue line is on top, and this is the device deployed in the bladder. So under vision, I'll be pulling. Can you see this anchor?
Yes,
This
we
has
could
to
see
be
it.
pulled-
Yes, very
this has
nicely
to be-
seen.
This has to be pulled into the prostatic fossa so that the anchor just comes and rests behind the bladder neck. Since it's a high bladder neck, so I am having to exert a bit of a pressure to get the anchor in. Yes. So now can you see the anchor
Yes,
is resting behind?
anchor is nicely placed.
And now I'll be these are the 3 wings at 12, 5 and 7. Now the important part is while withdrawing I have to see that the external sphincter is closing well, which ensures that the device is not beyond the sphincter. So this is the sphincter closing. We can see the sphincter closing.
Yes.
This is the anchor has gone, and I was just trying to, because the sphincter was not closing too well, I was trying to push in the device. The anchor has gone into the bladder. I'll pull it back again.
Yeah,
Yeah.
anchor is in
So-
plasma base. I
Yes,
think you
so-
can leave it there.
Yes, I'll be leaving it here. Now here the sphincter is closed, so I'm coming out. Now, do we have the outside view now?
Yes.
So now this thread has been, this is an irreversible step. Once I open up the knot, then I cannot go back in and reposition the device. Till now I can still go back and reposition. Now I'll be opening up this knot and pulling out the guide wire. So this is the guide wire, which is the 5 French diameter tube. And we are left with the thread outside. Now this thread will be made into a loop and tied on the penis to fix the thing. And while removing the device, we put this thread through a 22 French catheter or a 14 French access sheath, and For now, for a temporary drainage, we can put in a 10 French infant feeding tube, although that is not required, but just for safety purpose, we'll do it in the sterile environment of the OT and remove it by evening. So I'm just placing a feeding tube.
But this patient was not in retention, no?
He was not in retention. We can avoid putting in a tube, but he has been under anesthesia for some time. So we can just put it for some time or empty the bladder and remove the tube right now. So I'm just emptying the bladder and we can remove the tube. And this knot will be now, we can shorten the thread a bit and we'll tape it to the penis.
Excuse me, sir. Is it done in local anesthesia or we need general
because this is a conference case we are doing under general anesthesia, but as you could see, we can very easily do it under local anesthesia.
It is the best thing is you put jelly and then give midazolam. The patient will be sleeping and for 10 minutes, and in 10 minutes you can place it nicely.
Thank you, sir.
Jha, sir, this is Dr. Vikas.
Yes, Dr. Vikas.
As I saw you, you attempted twice to put that anchor just distal to the bladder neck. So would you prefer that the ITIN devices come in at least 2 or 3 sizes for smaller prostates so that the external sphincter doesn't get affected by the device?
No, I am not aware of it because this is manufactured
it is not
by
available
Olympus.
yet. It is not available yet. It is coming in only with the one standard size. So would you prefer to have 3 different sizes for different patients?
In a small prostate, maybe a smaller size might be so far, because this prostate was also hardly 30 cc. And we didn't have a problem, we were able to, because you can slightly put it into the bladder as well, just the anchor has to be at the bladder neck. So we haven't encountered a problem as yet. The Olympus guys are here, maybe we can talk to them and have a different size for a very small prostate. For a large prostate, obviously ITIN might not be a very good procedure. Till 50 grams, 60 grams, you can do this procedure with the size available.
And sir, about the removal of the ITIN device, are you comfortable with that 22 French catheter?
No, removal is one part that we are talking to the company and they are in talks with some local manufacturer, because the removal device that they have, which they bring for the demo purposes, that's a very soft silicone tube that's good for removal. But the access sheath is slightly hard, and putting in a blunt access sheath is not all that easy in the urethra under local anesthesia. A 22 French catheter is still softer, so we can put that in.
Sir, why not just take the patient to the operation theater and take a cystoscope sheath, take the forceps of digestant removal, pull out the thread from the scope and go just like a guide wire and remove under the vision inside the sheath?
The thread is outside strapped to the penis, so we don't need to pull the thread with a cystoscope. And pulling this with a cystoscopic forceps is not possible, because in one case that we did, the thread broke while pulling because it rubbed against the sharp edge of the access sheath. And then I tried pulling it with the cystoscopic forceps, so you have to hold the base of the device, the thing that was protruding at the apex of the prostate, just beyond the virumontanum, that round thing. That's a very hard structure. You cannot hold it with a cystoscopic forceps and then pull out the device.
And
so we had to put in a nephroscope and then hold it with
a... cause damage to the urethra.
That is why I was advising whether we can put in a cystoscope sheath inside just at the level of sphincter under vision,
but pulling it,
by keeping the thread inside the sheath. Inside the sheath, and then retract the device inside the cystoscope sheath instead of...
that can be done, I think.
That can be done. Yeah, we can
just
try
like
that
the way
as
we
well.
put in guide wire while putting digestant, we keep the guide wire inside the sheath and then put the digestant. Same way we can do it.
That can be done.
Yeah, that is one possibility. Yes, we can try this. This time we can try putting in the cystoscope sheath and over the thread, and then just pull the thread. Just the way we deployed it, we'll try to remove it into the sheath and out.
And also, sir, one fundamental problem that I agree with Dr. Nachiket Vyas, sir, that this device has an advantage over the limited BNI that we can do in a small setting of 10 to 15 minutes, is that it doesn't cause any bleeding to the patient.
Yes, there is no bleeding, and post-op discomfort is also very minimal because this thread hardly causes any discomfort. We just give a anti-inflammatory for a couple of days, and we continue the alpha blockers for 2 weeks, yes. And at times, if the patient is very obstructed, we can give an alpha blocker for a month. But apart from that, it's a very well-tolerated procedure. And especially when we compare it with Resume, the post-op discomfort in Resume persists for almost a couple of months. In this case, in a properly selected patient with a high bladder neck and who is desirous of preserving his antegrade ejaculation, it's a very good procedure. And practically a daycare procedure, and if finances are not a concern, because this is an expensive device. Olympus is selling it for around 2.28 lakh rupees MRP.
Yes, sir.
So that is...
One last point, sir, then I'll finish, is that only matter that prevents us from reusing this device, although it is made up of nitinol. We all know how good the memory of the nitinol material is. What is preventing us from reusing this device? That small knot?
No, the reusing means I'm sure no patient would be wanting to
you use it in one patient. You use it in
Yes.
one patient. At the time of removal, you keep the device, and I don't know what the legal implications are. We are reusing Resume also for many patients, although the FDA doesn't approve it. But what is the exact physical hindrance in reusing this device in another patient? You can keep that plastic applicator with you, and
yes.
Is there any problem? It costs too much for such a small nitinol device.
Sir, I don't think for someone who is spending, suppose we reuse it in one patient, so for someone who is willing to spend around 4 to 5 lakh rupees for his prostate, won't be willing to use the device that has already been used on somebody else.
Yeah,
So he would obviously want to have a fresh device.
Thank you so much, sir. Thanks for your input.
Sir, one question. What are the chances of it coming out of its own?
Very little, only if he pulls on the thread very hard, because it's not going to,
Then it will
removing
get stuck
it
into
requires
the urethra and cause damage.
Yeah.
It has to collapse before it comes.
So he has to be careful not to pull the thread, so that is very unlikely. In that much IQ level, I suppose all the patients would be having, those who are going through these minimally invasive procedures. So they won't pull on the thread, it won't come out on its own.
Thank you, sir. We are thankful to you for an excellent demonstration of ITIND. We are now having a lunch break for half an hour. The lunch is being served in the dining area. Following the lunch, we will be back with the case discussion and Thanksgiving cake cutting ceremony. Thank you.
Thank you, sir. This one.
At the session. Among the panelists we have, I invite Dr. P.N. Dogra, Dr. Shailendra Goyal, Dr. Umesh Ojha. You're leaving, sir? Dr. Pankaj Maheshwari, are you there? Dr. Pankaj God.
Okay, only 2 cases, yes. Dr. Pankaj Gaur, can you please join us in the panel? Change किया. So this is the index case. A 68-year-old male, hypertensive, diabetic. He had been treated for BPH with alpha blockers since past 3 years. He has no history of urological intervention. He presented to emergency with sudden inability to pass urine for past few hours. He had severe suprapubic discomfort. He had no fever, no flank pain, no hematuria. So clearly a case of acute urinary retention. On examination, the bladder was palpable. DRE was a non-nodular prostate, no neurological deficits. So such kind of elderly male with acute urinary retention on background of lower tract symptoms, the immediate step would be obviously a Foley catheterization. And the labs were done. Creatinine was 1.4, serum PSA was 12.1, urinalysis was mostly no infection was there. Ultrasound KUB 55 cc prostate, no hydronephrosis. So only positive finding was little high creatinine and high PSA. So what would be the next step, Dr. Goyal sir?
As his PSA is high, and I think we should also have when we are doing a catheterization, ideally sample should be taken before catheterization, and free PSA should also be done. And of course, when we are going to plan operative decisions, so here we can't decide between whether it is a malignant or benign. So we should, when the PSA is high in this category, we may go for the multi-parametric MRI after repeating the creatinine, because this may be a part of obstructive uropathy that may come, creatinine may come down, and we can do a contrast study after that.
Right, sir. And yes, sir.
Then to compare afterwards is a different thing, but in acute phase to do PSA on that, start doing more investigation. I think that unless clinically you are suspicious on your PR, or you have a record of past PSA with you, this man is on medical treatment for a long time, so I'm sure they must have done PSA earlier. So if you have that available, and then you find that there is a difference, but I would be little hesitant to send PSA at this point in time, or do MRI?
Point well taken, but if we have a PSA record, and this is the acute rise of PSA, that can be attributed to the retention or catheterization. But if we are planning or keeping the patient for 3 weeks on catheter, I think that's not acceptable most of the patients. then we have to decide whether we are operating or not. If we are operating, then we must rule out the tumor rather than a finding TURP biopsy coming as a carcinoma and then we plan for the radical prostatectomy after the TURP. I think that will be a more difficult
Can I say, sir? Sir, I 100% agree with you that I would feel PSA should not be done at this time because invariably you would get the PSA
Of
high
course.
and it would only confuse the picture rather than
But if
helping
we are
it.
planning surgery, then and the
Clinically it is
biopsy-
benign, old PSAs are normal.
No, if old PSA are not available. If
Still-
old PSA are
still
available, they
whether,
are normal.
Whether
then
you
doesn't
take this
make
PSA as
sense.
12 or 24, your further treatment plan doesn't change.
We will do the TURP.
That's a question which will come later on. Means
We
the
will give
question
a
is,
widening trial after 5 days, and after 5 days he doesn't void. Then we will wait for a month for the PSA to.
So we will stick to this case only.
Yes.
Won't go to hypothetical thing. This case has been in follow-up since 3 years, as we have seen. Ultrasound is not showing very large prostate. So we have to rule out first whether it is a primary retention or there is some secondary cause. Might be he has taken some cough syrup or he has taken lots of fluids, or there can be secondary, there can be a
Precipitating
reason
factors.
which has caused this thing. So it is appropriate to put a catheter, start on the treatment, and then we can give a trial. If the trial fails, then at that time, maybe because we have given that treatment, then we can do PSA total and free both. And we can compare the previous PSA. And then we can proceed in this case.
I don't know, at least I would feel in my practice I would not do PSA at this level,
this-
but I
this
would leave
moment
it
it
for
is not
everybody to
required
take a call.
As far as the guideline is also concerned, there is no need of PSA in the setting of acute urinary retention, and if it is in the rising value during the acute urinary retention, it will be again repeat after 14 days.
So because you see both or rather all three factors, the large prostate, the retention itself and the catheter, all three would raise the
Raise
PSA.
the
So
PSA,
doing
that's
PSA
right. Is of no
doesn't
value.
really help. That is what I have been practicing.
Yes, sir. You're right, sir. The PSA was repeated after 4 weeks.
Point.
and-
I mean, it's for the youngsters. What happens? The cycle starts. You do MRI, again it'll show sometime due to acute inflammation or infection, a different picture, pyrite 3, pyrite 4. Next thing they do is biopsy. So the whole picture gets vitiated. That's why you have to be a little careful when we start the process.
Okay. So point well taken that obviously PSA should be omitted when the patient is in retention, and if it is already done or patient has already got it done from outside, you just counsel the patient and repeat the PSA after a few weeks. Maybe it will show the downtrend and that will be fine. So regarding this case, PSA came down after 3 weeks on the downtrend. Regarding further, in the panel, will you proceed directly to the surgery or will you prefer a trial without catheter? Dr. Manish Chaudhary, sir.
I would prefer a trial without catheter because he never had a retention in the past. This is first episode. It may be a provoked episode of retention. We don't know the details. So he deserves a trial of voiding.
Okay, any different opinion in the panel?
So I would take a decision based on how his symptoms have been around 2 to 3 months before this retention. A patient who has had a significant IPSS before, say, the common history that I asked at this time is what was your IP? I would calculate the IPSS score around 2 to 3 weeks before the date of retention. If patient was reasonably okay 3 weeks back and retention trial, but if it has been a severe IPSS score 3 weeks back, then probably giving trial doesn't make sense.
Okay.
The second factor that I would base my decision would be whether there is a significant IPP.
Okay.
One more factor I will take into account is the rising in the serum creatinine. If his creatinine has settled down after the catheterization, after 2-3 days, if creatinine came down to 0.8 or 0.7, that means that this is the acute rise of creatinine, means this is a significant obstructive uropathy, then the surgery is preferable choice than a trial of voiding.
So the next question arises, if we are going for a TWOC, then what will be the ideal time after the drainage?
After 5 days of alpha blocker, maybe anytime
I
after
would
5 days, you can
put him
count
on
a weekend of 7
silodocin,
days.
and 3 to 5 days after silodocin is the right time.
Okay.
Before
Right.
catheter removal, look at things like there should be no constipation, patient should be optimally mobile, and only then remove the catheter.
Right, the guidelines state the same, that After starting alpha blockers, you can attempt without catheter, maybe 3-4 days. And there are factors which predict that the trial will fail, that the larger prostate volumes, severe LUTs, as stated by Dr. Maheshwari sir. I've had bad IPSS before retention. That means it's a progressive thing and it's not a precipitated thing, so he might fail. Then high PVR and older age.
Excuse me.
Sir.
You are mixing up the story. You are talking about the EU guideline in which this is a de novo acute retention of the urine patient without any prior medical therapy.
No, he was on alpha blockers for past 3 years.
Listen. These guidelines suggest the patient, those who are not on any type of medical therapy, and they have a spontaneous, you are missing the terminology. Okay. Right terminology is spontaneous acute retention of the urine, and the other one is a precipitation. So here there is no precipitation factor. It was a spontaneous acute retention of the urine while he was on medical therapy. Here these guidelines do not apply what you are telling. They are for de novo patient, those who have never taken a medical therapy before and they present with acute retention. Sorry for interruption, but that should be clarified.
Yeah, absolutely right, sir. So in this case, the patient was given trial wide without catheter, but he was unable to pass. PVR around 350 ml. Patient was recatheterized and planned for a TURP.
Again, an issue which again I wanted to emphasize. You are mixing up. Here the message is not going right. This patient already on medical therapy developed spontaneous retention. There is no need for giving a trial. You could have stayed by taking him for surgery.
Yeah.
He's not a de novo patient. Again, it's a progression of the disease.
Medical failure.
He was
actually.
taking
Failure
medical
of
therapy 3 years. Despite that, he developed acute retention of the urine without any precipitation cause.
Right.
So,
Sir, in the same case, is there any role of change the alpha blocker from either tamsulosin to silodosin or alfujosin? Is there any role of changing the alpha blocker?
I don't find any role is there.
Or adding 5-alpha reductase?
No. 5-alpha reductase. 5-alpha reductase will take 3 to 6 months to act. You will not wait till then.
Right.
It is only you're talking about the alpha blocker.
So
in this patient, this story doesn't fit into that what you are writing. He is a state-way candidate for a surgical intervention.
Yeah, this was, sir, and this was explained, but the patient just wanted, just please give me one trial. Maybe that day he took more water, that was cold day. So
these are the patients, they always make some excuses.
Yes.
If there is a blood in the urine, they say, I have taken some गर्म चीज मैंने खा ली. मैंने कहा जब ठंडा हो गया तभी तुम हॉस्पिटल आओगे. Don't believe patient.
So this patient was planned for surgery, but why he was inpatient, he had acute coronary syndrome. He developed non-degeneration myocardial infarction with raised cardiac markers and shifted to cardiology. Coronary angio was done. It was suggestive of triple vessel disease. So he was started on antiplatelets, and after stabilization, after a few weeks, patient underwent a coronary artery bypass surgery. Patient recovered the surgery well. Now he is post 3 weeks CABG, open heart surgery. Echo ejection fraction improved to 60%. So now.
So what happened in meanwhile? I mean, you gave the talk was failed, he was recatheterized?
Yeah,
and
he was
he's
recatheterized.
still on catheter for 3 weeks?
No. Yeah, he is on catheter for 3 weeks. It's just that the surgery was planned, and in the same setting, in the same admission,
on
patient,
the evaluation, it finds to be a triple
patient
vessel
had
disease.
this myocardial infarction, heart attack, and raised cardiac markers. He was shifted to the cardiology unit, managed well, and then coronary angio. So this whole cardiac picture, new picture came into this. Now the CABG is done. Patient has recovered from that surgery. The ejection fraction improved. Now obviously he is on antiplatelets. Initially on the first 2 weeks he was on double dose of clopidogrel. Now aspirin 150 plus clopidogrel. So come to your OPD. So Dr. Dogra sir, when would you want to operate such kind of patient now?
Well, the cardiologist says something the anesthesiologist says something. Here we are dependent on mainly because he is taking this blood thinner. Okay. From the cardiology point of view, they say 3 months is okay. After 3 months you can operate. The anesthetist says preferably 6 months, but if you want, you may be at 3 months itself. But ideal will be 3 to 6 months time one should wait.
Okay, so 3 months of more catheterization. So would you like to change the...
After 6 weeks of CABG, we can take him.
You can do the resume.
After CABG, 1 month, you can do it. We have done many transplant after 1 month of CABG. But after
PCI. After the coronary stenting, you invariably they advise 3 weeks. 3 months. And number of times those patients who are waiting for transplant, we have after 6 weeks of cardiac stenting, we went, did transplant, but we didn't stop antiplatelets. So we operated on antiplatelet. But after a number of times, cardiologist said to us, if you are in a hurry, get the CABG done. After CABG, you can safely take it after 3 to 4 weeks.
Resume would also be contraindicated in patients on antiplatelet. All missed procedures are contraindicated in patients with antiplatelet.
Well, again, I would like to emphasize same thing, Anand. If you read about this issue of antiplatelet, anticoagulation, and the surgical intervention, if you read the article by the anesthesiology, their journal, and the cardiology, they say something different. But we as a surgeon, you see, responsibility is on us. They don't come to the OT and see what are the problems, what we face as a surgeon. They simply advise the incidence of complication is 2%. It's not 2%. If it happens, it is 100%. So we can't decide like that. So it is a mutual decision, but these cardiologists and anesthesiologists, they take the things lightly, and the surgeon has to really take a bold decision depending on his counseling of the patient. And this is what I feel. We will not hurry to go for a surgery which is not urgent or life-saving. If it is a life or limb-saving surgery, it is okay, acceptable. But if something goes wrong, you will not stand in the court of law that what was the hurry to operate this patient.
Right,
okay.
sir.
I think the message is very, very clear that because BPH is not a priority surgery, we should wait till the patient absolutely stabilizes.
Right, sir, absolutely right. It's an elective procedure. I mean, neither the patient nor the attendant nor the anesthetist would like to take that much of risk for elective surgery. So if we are delaying surgery, maybe 3 months, so would you like to change the catheter to maybe suprapubic, or we'll keep in on PUC, or teach him CIC or something of that sort?
No, patient is fine with the indwelling catheter. 3 months, nothing going to happen. Patient again, you have to counsel the patient. If it's not a long term that you will put him on the SPC, you can keep on indwelling catheter, change every 3 to 4 weeks. Tell them how to maintain the hygiene, catheter care, metal care. 3 months is not a...
And even with dual antiplatelet, doing a SPC would carry a risk of bleeding.
Right. So I think the same was opted for the patient also. He was advised frequent change of catheters, maybe around 3 weeks.
It's only a question of what you see in your lifetime. If you see, you will see only one problem in your lifetime, and that is it. These problems will not come many times. I know a patient, very VIP patient. Gastroenterologist did a endopapillotomy of the pancreatic duct. There was some obstruction, and he was on blood thinner. Probably they didn't take history, or he didn't disclose. That patient died of the bleed, of falling endopapillotomy, because you can't do anything else there. Similarly, in a urology, deep pelvic organ you are operating, here you can't do anything. If the prostate after surgery starts bleeding, what you will do? If it's a surface surgery, it's a different. You can put pressure, pray, and all those things. But you can't do anything if it's a deep in the pelvis. So guidelines are different. They are applied differently in different situations. But don't put a sweeping statement, this is like that, this is like that. No. You have to individualize, see the situation, what you are doing.
Right, sir. So, patient is on waiting with frequent catheter changes. But this patient, I mean, this is not here, but actually this patient had UTI with pan-resistant organism, only intermediate sensitivity to colistin. So obviously the patient was given higher antibiotics, the culture became sterile. Now,
What was the
organism? It was Klebsiella, sir.
These days, this is the pattern we are seeing. Klebsiella, that too mild sensitivity to colistin. Rest they are all resistant. This is a pattern in all the hospital, at least I have seen Delhi. People are coming with a problem. And here you have to talk to your microbiologist. That they are not doing the drug sensitivity against the Klebsiella, ceftazidime group of drug. They are not testing those. So they should do specifically testing against those drugs which are suitable for this type of organism. So we don't give colistin for a Klebsiella.
No, it was tested for ceftazidime, that was also resistant.
Resistant.
Yeah.
The best drug is Klebsiella is the ceftriaxone, which is, even if it is coming as a mild sensitivity or resistant, the drug of choice is ceftriaxone for the Klebsiella. We have seen patients, not that anecdotal, frequently we see these patients are coming from different hospital, Klebsiella resistant to all. What do you do? Now you can't say, I will not do anything. You have to act. And invariably these patients, they are given this ceftriaxone group of drugs, injectable of course, and then you cover them with adequately with antibiotics, you can operate.
Sir, I have just one small point to make here that whenever the patient is on catheter and culture comes positive,
Yeah, same question I was coming to.
reassure that the sample was taken properly. You will be surprised at a lot of centers, they take sample from
Yeah,
the
from the
urine bag.
Yes, right.
So unless the patient is really symptomatic and properly collected sample, don't act on that.
Okay, yeah,
I
right.
would also take into consideration his total count and CRP before really deciding about cholesterol.
Exactly.
In
I was
our
coming to the
center,
same
in
only.
our center, it is a routine. All patient, we have a trained technician. They take the sample, take the syringe, clean the catheter, aspirate it. We even don't disconnect to take the urine. And we aspirate the urine from there, clamp the catheter, aspirate the urine, and that urine is sent for culture. And what antibiotics, I have now at least more than 12 patients who are resistant to everything. And our microbiologists put all the drug combination and they are resistant. So I have not operated them. And I told them God only can help you. Because if I operate you and you go into septicemia, I am gone. And now they are doing combination of JV septa plus astronome. This combination is currently worked in few patients and they became, and then that is the most important thing. You don't give these antibiotics. You should have a proper plan. I will start this antibiotic. Now, after 72 hours, I will operate, and same antibiotic cover, I will make you catheter free. Otherwise, if catheter is still there, you give antibiotic, it becomes sterile, and then next time, even he will become resistant to that antibiotic. So the plan should be ready. Antibiotic, 72 hours later, operate, and same antibiotic, catheter should be out, and work is finished, and then continue for 10 days.
I got it, Anand, you are right. This patient, if they are having castor and this type of organism, patient is not having any kind of fever, no TLC rise, and CRP and all those things. I think you should not take them as UTI as the other patient who are really symptomatic.
Yes.
They are different group of patients. So this is mainly a colonization, because these organisms are not going to vanish with the foreign body inside the bladder, urinary tract.
True.
So you have to get rid of this foreign body, only then you can expect that something will be taken care of. So we can't just say, till the castor is there, organism there is resistant, I will not do anything.
So, in
Fresh
yeah. So actually, this was a clinical UTI. Patient had dysuria, had little turbid urine, fever, a little bit maybe high CRP levels. So basically, the point which was I was coming to, that the patient attendance again coming to you, sir, this infection, and we have to keep catheter for 3 months. So they want to get rid of the catheter so that the UTI doesn't come back. And you are talking to a cardiologist, they say that 1 month is the time, I'll feel safer. You're talking to an anesthetist, and she says, no, it's an elective procedure. Why do you want to get it done so early? Let's wait for maybe more than that. So then how do you do? I mean, just ask the anesthetist that we have talked to cardiologist and we'll take to the OT at around 1 month, or you will wait more?
No, like you have a tumor board meeting.
Mm-hmm.
Same scenario in these type of patients. You should have a medical board meeting, cardiologist, anesthesiologist, microbiologist, infection control diseases, and a treating urologist. You should take the consensus opinion, record it. Don't take it lightly, so that you are safe. Then whatever decision taken, you are safe. You have recorded that this, you have taken an opinion of all these 4, 5 people concerned in the management of this particular disease. So I will go by that, rather than I say my opinion is the last opinion and this is the rider. I will do like that. No. I will always have an opinion of all these 4 or 5 people, those who are concerned with this, and record in the case sheet, and also tell to the patient and their relation that this is the decision.
I think this message is very important, because earlier we thought that only in complicated cases like transplant and all, we need to have opinion, recorded consent and all that, but the time is changing. And the youngsters like you, by the time you come into the practice, scenario is completely changing. So I think what Dogra Sahib is saying is very important to have a proper discussion. The fact that the relative has gone and checked with cardiologist, anesthesiologist, and even the culture report, they may not take kindly when things don't go well.
Mm-hmm.
So I think that message is very important. Secondly, this culture thing. Now again, today's patient, they read every line of the report, will go to ChatGPT or whatever it is and find out all the details. I think one of the important things where very senior physician had told me that many times in vitro and in vivo behavior of the organism is different. And I think that statement is sometimes very important, because as he very rightly said, everything is seen, which is resistant, but when you really give those antibiotics which are known to work against these organisms, do work. So I think these are the few things, and in doubt, I think take a proper consent with, I think, multiple people on the board.
Right, so points will taken. So after thorough discussion, it is around 1.5 months and all are on the same page. Obviously the blood thinners haven't been stopped yet, but the anesthetists are, they feel okay to get the patient in the OT. So regarding the procedure, what did you choose, Dr. Goyal sir? The patient is on aspirin 150 milligrams and clopidogrel 75 milligram, and he's refractory retention, acute retention, and we have to offer a procedure for prostate. So what is the choice, sir?
I think what you do best should be chosen. As an experienced surgeon, you know everything works, and when your stars are not in your favor, nothing works.
Mm-hmm.
So you can do PVP. PVP had advantage that immediately there will be no bleeding, but after 10 days, when the necrosed tissue sloughs,
yeah.
then the secondary hemorrhages happens in the PVP also. Laser enucleation also done best. So what you can do best, that will be the thing.
Okay. Dr. Maheshwari, sir?
I would 100% agree with Dr. Goyal that PVP on paper looks good, but because now he also had a raised PSA and we are interested in histopathology also, so probably a enucleation procedure would be something I would look at. Many times perioperative, they would permit you to switch from dual antiplatelet to single antiplatelet, or you could go for a bridge therapy.
Mm-hmm.
And with that, it should be possible to do a holmium laser enucleation. If facilities are available here, probably TFL may have an advantage because of a better hemostatic quality.
Any different opinion? Dr. Gaur, sir?
Yeah, if TFL is available, then TFL should be the first choice in this case.
Right. And regarding the, if one is trying to do PVP or because not much cases we do of PVP. So is there any in the mind that regarding the efficacy of PVP with, as compared to the resection of prostate or enucleation of prostate?
For a 40-gram gland, probably the efficacy is good. It is for very large glands that PVP may have a debatable efficacy. But still, as Dr. Goyal said, the risk of secondary hemorrhage is significant. So I would be more comfortable doing a TFL enucleation here.
But
No,
we have
PVP
done in
is
the
okay.
past, many patients who were on acetram and warfarin, we have done green light laser. And this patient did it, I think, out of, I don't remember number, one only patient who came after 3 weeks with secondary hemorrhage. And with the conservative treatment, he settled down. But green light laser is, when it works in the patient who are taking acetram and warfarin, it can work in dual platelet also. So nowadays actually green light laser is not available on lease. So we have started using thulium laser for the same purpose, and that also works well.
You see, USA, this green light laser is very popular in the United States. And they recommend all those patients, those who are on this blood thinner anticoagulation, this PVP laser. And we have also done quite a reasonable number of patients, and we don't find any this delayed bleeding phenomena. Only thing is disadvantage, you don't get the tissue for the histopathology.
Right.
That's it.
Mani sir, do you have any separate opinion regarding the same? Because you are in US for a long time.
I agree with the panel, but based on my experience, what I've seen in US, the number of patients who are on blood thinners are quite higher compared to what we see here. And most of the time we have to operate on dual antiplatelets, and in that situation somehow it won't be in the guideline, but the expert opinion and experience wise, most of the people prefer green light over other lasers just because of better hemostasis during the procedure also, and delayed bleeding issues also.
And also insurance purposes, you want to discharge the patient earlier.
Yeah, that is also true.
Yes. I know the trends are different across the Atlantic Ocean in the management of the medical problems.
But in this case, he is also having a pan-resistant kind of bacteria. And PVP is more, I mean, the risk is more for sloughing and hemorrhage if it is a continuous bacterial infection is there.
That is true.
That's why TFL I have chosen over that.
Yeah, very.
In green light, what is happening? You are evaporating all the tissue. All the bacteria,
Slough out.
everything will all get evaporated. And then whatever is left, same thing. So that doesn't make much sense. And it works very well, the green light laser.
Okay, so I mean.
There is one more difference in the practice that I've seen over there, that for colonization, the infectious disease people, they always give recommendation regarding the antibiotic. Surgeon cannot decide in West. And usually their advice is to just start sensitive antibiotics just before the procedure and not in advance. If there is clear-cut colonization, like no symptoms, no dysuria, no fever.
Right. So, I mean, all very good points. Regarding this case, the most important was to interdisciplinary discussion, a meeting or that kind of thing for the safety of the patient and information for everyone. So with cardiologists, what is exact cardiac issue? So it is a valvular disease versus a coronary disease. Then how is it safe? When can we stop the antiplatelets, anticoagulants? If there is need to bridge the this antiplatelet therapy, anticoagulant therapy, then with anesthetist, how risk they are feeling with the attendants. So it should be a joint decision making, and then only we should come to a conclusion. And regarding the procedure, obviously what is best in your hands, just do it. Yeah. So thank you so much.
mention that what was
So,
done to this patient?
patient is in waiting, sir.
Still waiting. You wanted to
We want your opinion for the patient.
So actually, they were not able to decide, so they just wanted to be safe. Then sorry, so he's around 4 weeks. Maybe we'll be operating him 2-3 weeks later. So yes, he's in
to
waiting.
do thulium laser.
Then no one can question then. Okay, thank you so much, sir.
Thank you, sir. So to
So,
conclude,
my question is this: the patient who do not have a past PSA record came with a retention urine, and you are planning to do operate as a benign prostate, and you do not have any PSA, and you are not planning to do PSA.
In this patient?
Not this patient.
Okay, no.
Any patient came with a retention urine, no past PSA record. Would you operate without PSA?
No, we will do in that case. If we have decided to do a surgery, then we'll do a PSA. It is not necessarily will be high. It was high in this case, but in many cases it will be
Many
normal.
cases it may be high,
But if it is
falsely
high,
high.
then you have to either go with the biopsy, prior biopsy, or you have to wait. You have to wait for 2-3 weeks, repeat PSA, and then you go for the surgery. See, you have to see the trend.
Good afternoon. To conclude, as we come to close the Max Prostate Conclave 2025, it is with my immense pride and gratitude that I stand before you. Over the past 2 days, we have witnessed an extraordinary exchange of knowledge, live operative workshop, simulation training, panel discussions, and thought-provoking lectures and that enriched us. This conclave has not only showcased surgical excellence in prostate care, but has also strengthened the collaboration between experts, residents, young urologists, and who represent the future of our society. I extend my heartfelt thanks to our eminent faculty, guest speakers, and international speakers. The name will be Dr. Ritesh Goyal, Dr. Sudhir Kumar Divana, Dr. Nikhil Khattar, Dr. Tushar Aditya Narayan, Dr. Amit Agarwal, Dr. Gaurav Garg, Dr. Aditya P. Sharma, Dr. Raman Tanwar, Dr. Pankaj Gaur, Dr. Karandeep Guleria, Dr. Manish Chaudhary, Dr. Rohit Joshi, Dr. Arup Kumar Nath, Dr. Anil Vashne, Dr. Manoj Tumala, Dr. Saini, Dr. Anand Kumar, Dr. Samit Chaturvedi, Dr. Vimal Dasi, Dr. Nikhil Vastev, Dr. Rohit Kaushal, Dr. Amitabh Singh, Dr. Vivek Vasudev, Dr. T. Manohar, Dr. M.S. Jha, Dr. Nachiket Vyas, Dr. Vivek Saxena, Dr. Amit Kumar from Radiology, Dr. Devanshu Bansal, Dr. Sridhar, and Dr. Anuj Sharma. I extend my heartfelt thanks to our organizing committee for providing every help that needed for the conference. As we conclude, let us carry forward the spirit of learning, innovation, and teamwork. May the insight gained here inspire us to advance prostate health and patient care together to a greater height. Thank you all for being part of this journey. We look forward to welcoming you again in the future for the next edition of the Prostate Conclave. At the end, I would like to invite Dr. Anand Kumar, Dr. Dogra, Dr. Umesh, Dr. Maheshwari for the cake ceremony. Dr. Jha, Dr. Rohit, Dr. Vivek, Dr. Manish Chaudhary, Dr. Jha for cake ceremony. Yeah, sure.
Well, I think before we do that, on behalf of delegates, I must congratulate the whole team for an excellent workshop. when I read this workshop coming up, I was not too sure whether to attend or not to attend. But when I saw the program second time, I thought that this is so important. Even at a senior level, we need to know what new things are happening, and learning never stops. And I am so happy I decided to come here. I have learned so many things in 2 days, this prostate conclave. And I really mean it, because when we are in academics, I think we must know whether you are doing or you are not doing what is the recent trend. And that was my purpose of coming. And Anant and your team, you have served that purpose. So once again, thank you very much on behalf of all the delegates to all the team. Excellent cases, excellent demonstration, excellent discussion, and excellent hospitality. Thank you very much.
We have a birthday party of Gurmeher, and a daughter of Jasneet. So, Jasmeet. So, I will invite her also for the cake cutting. One last announcement. Those delegates or faculties or guests who has not checked it out yet, please check out the room.
Can I make one small request? Please, मुझे कल का रात का आपका presentation भेजिए. It will be used purely for my students' exam. Okay. It will not be used anywhere.
Absolutely.